You, Marty. Now, so my daughter was born preterm. She arrived, was it 30 weeks or 31 weeks or something like that? Anxiety, confusion. I don't want to say regret, but sometimes you regret. And then for those of us who are Africans, you begin to ask, I mean, come on, you are professionals. I'm sure you've seen and heard all these things before, where people feel that some old lady or some jealous ex of your husband or jealous ex of your wife or somebody has jujued you. And if you see preterm babies, it's shocking. Through my, advocacy, the smallest we saw was 800 grams. And, hey, 800 grams. For those of you who remember St. Louis sugar, remember that sugar in the blue box? That's about how, like that. Anyway, so my daughter was born. Kolebu, almighty Kolebu. We had to be going up and down the stairs because the lift weren't working at the time. Weren't too sure if she would survive. It was terrible. So my wife had to go there every, 6 hours to go and breastfeed. She just refused to breastfeed. So they put all kinds of tubes in her nose. She was lying in the incubator. All kinds of, what do you call it, drip? That's how we call it. You call it infusions and that. And baby. And you come and find that she's pulled the thing out. So there was one morning, we arrived there and she was turning greenish, yellowish. Because apparently she had pulled whatever infusion out. And the nurses, I don't bash nurses that much because they were busy and they were hot and there was so much pressure on them. As a parent, you may take your anger out on the nurses, but here's a NICU full of like 15 preterm children and Charlie nurses will be hot. So we had to go into the corridor, scream, let them come back, fix the things. It was a traumatic close to 10 days of my daughter at NICU. Then somehow they gave her the all clear. You may take her home. BBI, you okay? Good. And then she comes home. And just by the grace of God, she lives a normal life. Very normal, as if nothing has happened. As if she wasn't born preterm. And she started talking early. I don't know if it had to do with the fact that she was preterm. She started talking early. She started making noises early. She stopped breastfeeding in 1 month. Yeah. My daughter stopped breastfeeding. Put it in and then she'd push it out. 1 month, she stopped. She didn't find anything exciting about putting a breast in her mouth. So then we had to rely on other food, supplements, SMA. I went through the whole process. SMA Silver, SMA Gold, SMA Premium, all kinds of things. By age 3-4 months, no difufu. I'm not exaggerating what I'm telling you. I'm not exaggerating. She had no teeth. So, you give her SMA, after a while, she stopped. Baby food, it was as if she was really in a hurry to come to the world. And we were wasting her time. So now you have to cut fufu into small pieces. And you have to make her soup differently. And she started eating fufu. Banku, rice. You mash the rice. And that's what you eat. You give her SMA. Baby food, no. So we had to find ways to, because some of those baby foods also help them to grow. So we had to find ways of mixing it. Basa. Long story short, Last week, Friday, she turned 20. So she's 20 years old. And she's still talking. So why incubators? This is my personal story. We started, it was over drinks. Okay, Dr. Grace, I'm telling part of the story. We're having drinks as friends. And the year before, that is the year 2014, I had helped a company called CCML, Christian Council Microfinance Limited, to try and raise funds to build a kidney center for the 37 military hospital. He raised $150,000 to try and build. That is another story. It never got built. Confusion, baby, but that's another matter for another day. So I was having drinks with my friends. And one of them was like, Charlie, you cry. I said, Griffith for cry, I'll pay $150,000 a moment. Yeah, dear, let's do something. I said, something like what? He says, let's go into the health space. Let's see if we can do something for them. I don't know if it was the alcohol that was speaking or if he was in the spirit. But both ways, it made sense. Now, what do we do? Health space. There's so much to cover. What do we do? What do we do? What do we do? Then I said, how about incubators? And he was like, okay. I mean, he didn't really know what it was. He was like, okay. Then he asked me, why incubators? I said, but my daughter was in an incubator. According to my mother, I was born preterm. So let's start doing some research. Then we started. Hey, moya deal. So went to see Professor, is it Ifwa Hesse? Professor Ifwa Hesse at Kolebu. Because we're completely at sea. We didn't know what we were doing. We just wanted to buy incubators. Anyway, just go and buy incubators. Went and had a conversation with her. She gave us reading materials. She advised us on what to do. She thought it was a good idea. She encouraged us. And then now, where do we get the incubators from? So we started fishing around, going back and forth, asked people who knew better than we did. And then we settled on an equipment manufacturing company called Draeger. So we went to Draeger, went to their local rep in Accra. He says, yes, I have incubators, top range, best in the world, blah, 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 blah. Each one is $10,000. We're like, eh? I didn't send me a copy of my $10,000. Okay, let's look elsewhere. We got quotations from China. We got people from Turkey and Thailand, from the UK, from the US. But we were skeptical about the Chinese products, let me be honest. We're skeptical. We weren't too sure. We're in an area we didn't first of all understand. And so we didn't want to take any risks. So I went back to Prof. Hesse. I said, Prof, we have some people who have refurbished ones they want to donate. Some others have refurbished ones they want us to buy. We have quotations from China, from Turkey, from Thailand, from the UK, and all the ones we're getting from the UK were refurbished ones. And then some people in the US said they bring these medical equipment for free. So we had to clear them from the port. We said, okay. Then the proposal they gave us was that we'll give you, I think, 5 incubators, 10 hospital beds. We said, hey, we just want incubators. So that fell. So Professor was like, look, if you want the best, Draeger is a good company. They manufacture, we know them. The other options are equally good. But if you can raise money to buy new ones, we would appreciate. So my friend and I said, okay, I will become the chair of this organization. So went through the process, registered Kokroko Charities Foundation, blah, 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 blah. And you, who was in the spirit and said we should start something, you become the operating officer. His name is Dennis Educhum. So he took it up. Then we started trying to raise funds. And you know how difficult it is to raise money in this country. We went to people who thought that we're on a frolic of our own. They were not interested. Some would also ask you, $10,000. It was difficult, but we pushed on. I used my platform on radio to talk about it, to interview Professor Hesse, interview other people. We went back and forth, back and forth, back and forth. Anyway, to cut a long story short, our very first donation, which I still remember, in the year 2015, was from a lady who became a member of parliament, became a minister. Her name is Barbara Otinjesi. So I phoned her. We're just calling random people, organizations, individuals, tapping into our network of friends. So I phoned her one day. I said, oh, we started this, if you'd like to contribute. She's like, speak to my husband. And I know her husband, Dr. Otinjesi. So I called him. I said, Charlie, big brother, in your say, more, at the end, I'm long story short, Barbara says, okay, I'm running to become member of parliament for Prestea Huni Valley. If you would put that incubator in the Huni Valley Hospital, I'll foot the bill. I said, I promise I'll do it. It started like a joke. Our first incubator, our first donation came from Barbara. She gave us $10,000. Just like that. And I'm saying, so Barbara Otinjesi gave us $10,000. We got the incubator from Drager, transported it. It's a very delicate machine. To transport it was quite difficult, but we transported it, took it there, installed it. Luckily for us, technicians were already there who knew how to use it. And then we started. Back and forth and back and forth. People started throwing some in. We launched a short code. It didn't work. So don't let it make it seem as if it was easy. We launched a short code with MTN. It didn't work. We directed people to contribute. It didn't work. We tried to do a raffle. It didn't work. We went to individuals. Some shut the doors in our face. We went to corporate bodies. Some refused. Others were helpful. One of the biggest support we got was from GMPC. At the time, Dr. KK Sapon was the chief executive. So I walk up to him and say, Wafa, CSR budget, I say, I feel must say $4 million. Man can cry. As my uncle, me the year you my pow. Me see school dying, me say, me so far. So 4 million dear. My kaka. My kaka. I say, no, penny, baby, when you need to now, Obi, you want to buy a farm hobby. And I'm saying, it's not about me. Me, my woman marry, but maybe I'm more fast, be madam for be. Obi, it's not about me. And if you met KK Sapon before, he's a very blunt person. In fact, I'm not kind of mean because me ferry. But Obi onim Dr. KK Sapon piano. Or you pain. So wait, what he said was, if somebody has gone to enjoy their enjoyment and you get where I'm going. Now, Okani na pepe. Long story short, that year he gave us $50,000 from GMPC funds. So that's 5 incubators taken care of. The following year, somebody told me again that they've increased their CSR from $4 million to $6 million. I went back. And I KK Sapon say, bear me dribblings to go. From next week. Bra airport office. Smobrim bra tema. Molete na ira. Yehu baby ewo committee for her. Look, we went back and forth for about 8 months. Back, forth. I went to his house. Mr. Wafa said, "The cost $6 million." I said, who's been telling you these stories? You don't sit on our board. How do you know what is going on in there? They say, I'm a journalist. I hear things. And I hear $6 million. Wafa, you did give us small. Back and forth. Oh, I can't find your letter. You know the things bureaucracy does. Long story short, GMPC gave us $100,000. So for Kokroko Charities to have been successful, one of our biggest donors was GMPC and Dr. Keke Sapo. I deliberately mention him because there are people we went to and they just told us to Charlie Mofamadi and Nonko. Some of them also didn't understand what we're trying to do. Keke Sapo himself said he didn't know why I was bothering myself with it. But because me tete no. And I'm eternally grateful to him and to GMPC. Enterprise Insurance helped us. So many other companies, individuals came on board. At a point, we almost gave up. Let me be honest. Our target was 100. And that is $1 million we are talking about. So some people thought, more Bodamwana. But when you go into a NICU area, it is depressing. It's depressing. You go and see someone, look, Kofodia, a woman had a preterm in Kofodia. The only place that they could salvage her was to bring her to Kwewu Government Hospital. That day, kind courtesy Mr. Chumberima of Midwest, who bought 2 for us, we made a donation and the ambulance drove her in. Unfortunately, she lost her child. And there are women here, I'm sure some of us are mothers. When she walked out of the NICU, Taflache, she was close to naked. And she didn't care. She was in a state of mind that she was oblivious of what was going on around her. And people tried to cover her, and when tried to cover, she just takes the cloth off. And she was screaming and shouting in the corridor, and it is depressing. So we've seen the good, the bad, the ugly, but we've also seen some beautiful stories. We went to Whole Government Hospital, Trafalgar. When we got there, there was a woman who had twins, preterm. Bako cried saying, Namino. She had just had twins. She had given birth about maybe 2-3 hours before we arrived. Preterm. And we are donated 2 incubators. The doctor looks in my face and says, you're just an angel. That's all you are. Because we're rotating these kids. Now, we're fresh. 6 years later, when we went, the 2 little girls were there, 6-year-olds, beautiful girls. The only unfortunate thing was their father had just died. And it was, I'll give you a list of where we've done. So my friends from the Pediatric Society, I became part of your family by accident. I do not regret it. We targeted 100. We started in 2015. And even though we've run out of money, we're still trying very hard to complete. As I speak to you today, we've done 62. And the reason, forgive me, the reason why we pull the brakes, as I mentioned, is because truth be told, Yesikasa. And when you go to some places, you don't get the immediate support that you envisaged. And so we have slowed down a bit, but we are hoping that we'll make progress as we go along. 1 second, let me just open this. And so, Madam Vice Chancellor, here is my report card, if I can call it that. So, we've been to every region in this country. Tamale Teaching Hospital, we gave them 3 incubators. Yendi Municipal Hospital, 1. Cape Coast Teaching Hospital, 3. Kofodia Regional Hospital, 1. Nsawam Government Hospital, 1. Kwewu Government Hospital, 2. Agomenya Catholic Hospital, 1. Chebi Municipal Hospital, 2. Tetekwashi Memorial Hospital in Mampong, 3. Presbyterian Hospital in Donkokrom, 1. You know where Donkokrom is? We had to put it on a pontoon, cross the lake. It was, yeah, bro. La General Hospital, as it was then known until they broke it down, we gave them 1. Police Hospital 1, Tema General Hospital 3, 37 Military Hospital 1, Ghana West Municipal Hospital 1, Lekma Government Hospital 1, Konfanochi Teaching Hospital 2, KNUST Hospital 2, Agogo Presby Hospital 2, Atonso Agogo Government Hospital 2, Efijasi Government Hospital 1, Sunyai Regional Hospital 2, and we got a car accident there that day. Efian Kwanta Regional Hospital, Pristia Honi Valley 2. So after the first one, we gave them another one. Dixcov Government Hospital 1, Ho Teaching Hospital Trafalgar 3, Keta Municipal Hospital 2, Jirapa Catholic Hospital 2, Nadoli District Hospital 2, Upper East Regional Hospital 2, Bolgatanga Bongo District Hospital 2, the Navrongo War Memorial Hospital, we gave them 1, Gosso Municipal Hospital 2, Swedru Government Hospital 3, Sene West District Hospital 1, and Inquanta South District Hospital 1. Total so far 62 out of the targeted 100. Now, somebody says, why did we give a smaller hospital like Swedru Hospital 3 when some of the bigger hospitals exist? It was a needs assessment we did. We looked at how we don't just go and just dump an incubator, that we try and follow the, data and statistics that we have. But there's this particular person called Richard Kwanzaa. He's a fancy man. Fancy food him. Nenyo Abre Orcas not a real concept. So actually, the 3 we gave to the Swedru Hospital, he gave it to us. He gave us $30,000. He calls me up one day and says, hey, as a man, now it's a incubator, so you do fusi in heavy. And I was Uncle Richie. You need school. I said, cray, I said 10,000. When the sky pay me for over 10,000. I say, then I'm quoting him. Sky pay me for over 10,000. Then I'm a hey, okay, our motto 2 CCH motor crack I 3. Mr. Uncle Richie, when you are I said, when you are the following day, he gave us $20,000. So we went there, donated, and then he says, about 2 or 3 months later, I called Charlie, I don't be donating many fans. Many fans, Intiaze, one brown, a third one. So, and this is exactly how he talks. Okasa free. I say, hey, Charlie, many fans, I have from. Then he gave us $10,000 and we went. So there are good-natured people who have supported this project. We'll continue as and when we can raise the funds. And so you continue doing what you do as professionals in the field. We would also continue doing what we do as supporters of professionals in the field. I won't take too much of your time. If you want me to answer any question, I'll be glad to do it. If not, I'll take my seat. And then at a certain point in time, I'll quietly disappear. So Vice Chancellor, and to all of you, Dr. Grace, you're happy now. I told them that it was over alcohol. I've told them the truth. And so I'd like to thank you for inviting me here. I'm honored that you found time to listen to me. And thank you also for honoring me in February in Accra. And God bless us all. Thank you all very much. And Dr. Mrs. is here. You may add the rest of your names.
Thank you very much, Chairman General, friend of PSG. We are so grateful. There's always a story behind our successes. Probably we should all be drinking over some alcohol. After that, we can be donating 10,000 here and there. Thank you so much, Chairman General. Before we move to the next keynote speaker, I'd like to welcome some guests in our midst. We have Professor Eric Tutuchao. I hope I mentioned the name right. Please welcome. Please, can you give us a wave so that we all see? He's a science director of the Distributed IoT Platform, Private and Edge Intelligence Research Lab. Welcome. We also have our very own Dr. Ojame, Dr. Adomafocus, and he's my big brother anyway, so welcome, welcome. We also have Dr. Eko Mensah. Today we've elevated him to a post. So after today, he'll come down. In our midst, we also have Dr. Enobashi Adam, head, yes, head of our neonatal unit. And we also have Dr. Nana Rekobrobe. But I know you say, why did I mention your name? But I want them to see Dr. Gerald and Nana Rekobrobe. Thank you very much. So at this juncture, we'd like to hear from the president of the Pediatric Society of Ghana. Okay. Professor Mrs. Dixon, please give her a round of applause as she goes to continue with all her duties. Her plate is so full, but she still gave us audience. Thank you so much, Prof. Chair. Our president couldn't be here in person, but we have our vice president here. He's Dr. Emmanuel Opon. He's the head of pediatrics of Asaman SDA Hospital. He's a specialist pediatrician and also a fellow in training. Okay, please, before Dr. Emmanuel comes, we'd like the guest council LOC to have a picture with our vice chancellor before she leaves. So please give us some few minutes. So big brother, Prof. Echo, join for today. Dr. Bwashi Adom, please join. Dr. Bempa, Dr. Ajman, a picture. Yes, please. Shouldn't the MC be part? Hey, for today. Thank you so much. I think every year I'll be the MC. What do you think? Every picture I'll be inside. Thank you so much. Approved. Thank you very much. So we'll go on to the next speech. We'll invite Dr. Emmanuel Pong, our own specialist pediatrician, also a fellow in training, very soon a neonatologist, to give us the speech from President.
Thank you, Nana. So my president wished to be here, but Pediatric Society of Ghana, as you know, we have our hands in many things to push the child health agenda. So she's in another meeting in Accra. I'm very honored to share this message on her behalf. She prepared a very extensive speech, but I'm not going to go through all that. She has given the permission to give the take-home message for our gathering today. Distinguished guests, esteemed colleagues, partners, our sponsors, ladies and gentlemen, it's a big, big honor for me to be here this morning. A few years ago, when the idea to create awareness about prematurity started by our gallant founding members, we wanted to just make noise about babies not surviving, babies who came too soon not surviving. But it got to a point we had made enough noise through streets, through radio talks, TV shows. The whole Ghana had heard about Prematurity Awareness Month. But the sad part is that babies were still being sent over 20 kilometers, some 50 kilometers, to access the care that a baby who is born too soon needs to survive. So we decided to shift our focus from just making noise about it to making sure that the care that a preterm baby will need, regardless of where the baby is in Ghana, is accessible. The initial idea was to engage our partners, our sponsors, to make certain equipment, low-cost equipment available. And I'm happy to report that we succeeded somehow. But last year, something became clear. Some of our healthcare workers who are outside the teaching hospitals and even the regional hospitals were not having opportunities to be trained and equipped to provide the care that these tiny babies will need. So this year, through the leadership of the PSG Ashanti and very motivated young doctors in Konfanoche, just a little over 2 months ago, we decided to have this Prematurity Conference. The initial meeting, it was clear that we were not ready to pull off such a big conference. But were we going to wait another year for the healthcare workers in the district and sub-district hospitals not to be equipped to provide care for these preterms? Every year, we estimate that over 100,000 preterm babies are delivered, specifically almost 128,000. A lot of these babies don't survive. Elsewhere, their survivability is very high, over 90%. In Ghana, we are looking at way below 50%. So we decided that we won't wait. We'll keep going and see where this leads. Even if you're able to teach and train one midwife, one nurse, one doctor, how to set up an intervention like CPAP. CPAP is one of the devices or the methods we use to help these tiny babies breathe. It will be worth it. And that's why we are gathered here today. So from my president, we have leaders in the healthcare space here. We have policymakers, we have facility managers, heads of units, philanthropists like my senior brother. The message is simple. Let us reinforce the urgency of investing in training, investing in infrastructure, and building systems that are sustainable, so that beyond this periodic awareness creation, we have systems that actually, without someone having to make a call to the head of the neonatal unit, my boss, Eno, my family member is bringing this baby. The system is robust enough to provide the care. You don't have to make a call. And it will take all of us to invest in it. To our donors and partners, some of them, as at this morning, I was still engaging to get more money to make sure that when this conference is done, we won't be in debt. Preterm babies are not allowed to owe people. Hallelujah. The theme for the conference is equity, equitable care for every preterm. I don't know what it means to you, but before you leave here, before this conference ends, decide that you identify that gap in the care that we provide. Engage, thank you very much. Engage a partner, network with someone from this conference who can help you fill that gap, so that next year we'll have very wonderful testimonies and stories from this conference. The goal of this conference, the vision from my president is clear. It's not to just make it a Ghana conference, but to have a prematurity conference that the whole sub-Saharan Africa can attend. It will be good to build capacity across the sub-Saharan region. When you read research papers, they usually don't even report Ghana. They report sub-Saharan Africa as the problem. So journey with us. Let's make this conference and training workshops what it's supposed to be. change the landscape of prematurity survival in the sub-Saharan region. So thank you. Enjoy the rest of the meeting.
Hello, okay, I'm being heard. Next on our list is the representative for our Honorable Minister, Dr. Minta Akando, who could not be here in person with us, but online he has a representative in the person of Dr. Hafiz Adam to give us his remarks. If he's online, Dr. Hafiz Adam, please go ahead. And a round of applause for him, please. Is he ready? Can we project the QR for the program? If you have your phones out, we'll project the QR for the program and then we can
Hello?
start it.
Hello?
Okay.
So it's not
Hello,
coming.
sir, please, we can hear you.
Yeah, good morning. Can you hear me? Hello?
Hello, yes, sir, we can hear
Yes,
you.
can you hear me now? Yes,
Yes,
thank you very much. Yes. Distinguished Chairperson, President and members of the Pediatric Society of Ghana, representative from our partner organizations, esteemed health work professionals, distinguished guests, ladies and gentlemen, good morning. On behalf of my minister, the Honorable Kwame Minta Akando, MP for Joabisu, and the Minister of Health, it's a great honor and privilege to join you virtually at this maiden Prematurity Conference, a landmark initiative by the Pediatric Society of Ghana. I extend warm greetings on behalf of the Ministry of Health and commend the organizers for choosing such a timely and profound theme, equitable care for every preterm baby. Distinguished guests, today's gathering is not only a scientific meeting, but a moral call to action. It invites us all to reflect on how we as a nation can ensure that every citizen and every child, irrespective of the place is born, has the opportunity to receive health care as due. It invites us to reflect again on how we as a nation can ensure that every child, regardless of where they are born, has a fair chance at a life. Global preterm birth remains one of the leading causes of national mortality and long-term disability. In Ghana, we estimate that nearly 1 out of every 10 babies born, they are born preterm. Behind each statistic lies a story of a mother's anxiety, a father's uncertainty, and the fragile hope of a newborn struggling to breathe, as we have just heard from Mr. Sefakai. These tiny citizens remind us that survival should not be determined by geography or circumstances. Whether a baby is born in Accra or Nakpayile in the northern region, in a teaching hospital or a district facility, that child deserves the same right to quality life-saving care. I am proud to know that Ghana has made significant strides in maternal and newborn health. Through the efforts of our dedicated nurses, midwives, doctors, and allied health professionals, we have improved access to maternal and antenatal care skill delivery and newborn services across the country. Our collaboration with partners such as United Nations Fund, that's UNICEF, World Health Organization, U.S. Agency for International Development, and local professional bodies have strengthened neonatal intensive care capacity and improved the availability of essential equipment. The introduction of newborn care corners, the scaling up of kangaroo mother care and the ongoing efforts under the National Newborn Child Health Strategy are clear demonstration of progress that we have made. Yet we know that our journey is far from complete. The disparities between urban and rural care, between well-resourced hospitals and those struggling with limited equipment remain stark. And this is why today's theme is not just aspirational, but essential. Equity in health means that the quality of care a child receives does not depend on the family's income, location, or background. It means that a nurse in a district hospital is empowered, trained, and equipped to save a preterm baby as a colleague in a regional or tertiary facility. Distinguished guests, ladies and gentlemen, the ministry remains committed to these principles through ongoing health infrastructure development, the expansion of neonatal care. It requires collaboration between policymakers, healthcare workers, community leaders, and families. It requires data-driven decision, making innovative technology and efficient referral systems that connect our rural communities to higher levels, to our nurses, midwives, doctors, pharmacists, physician assistants, biochemical engineers, and public health officers gathered here. You are the heartbeat of this effort. Your compassion, vigilance, and skill make the difference between loss and survival. Let us strengthen our trademark across disciplines. Pharmacists ensuring the safe use of medicines, biochemical engineers maintaining life-saving equipment, midwives identifying danger signs early enough, and doctors leading care with empathy and evidence. Together, you represent the best of Ghana's health system. Conferences like this one, provide a space to exchange knowledge, share innovations, and inspire new solutions. The Ministry of Health is fully supportive. Such professional platforms that advance continuous learning. We encourage you to document your experiences, research your interventions, and share your findings as evidence in the Foundation for Progress. Distinguished guests, ladies and gentlemen, again, we must continue to invest in appropriate technologies, from affordable incubators to reliable oxygen supply system, and in training the next generation of neonatal specialists who will carry this work forward. Distinguished ladies and gentlemen, equitable care for every preterm baby is not just a slogan. It's a social contract. It calls on each of us policymakers, practitioners, educators, and advocates to do our part. Let us renew our commitment to reducing preventable neonatal deaths. Let us support mothers through compassionate maternity and newborn services. Let us ensure that every health facility, regardless of size or location, has the tools, training, and system to care for our small citizens. Investment in the survival of preterm babies means investment in future of Ghana. Each life saved strengthens the fabric of our nation. As we open this maiden Prematurity Conference, let us do so with gratitude, hope, and determination. I applaud the Pediatric Society of Ghana for your leadership and foresightness. May the discussions that we are holding today lead to stronger policies, better practices, and renewed energy in our collective decision and mission. Together, we can make vision of equitable care for every preterm baby a reality. Thank you for your attention, and may God bless us all and bless our mothers, our babies, and our nation. Thank you for your attention.
Thank you very much, Dr. Hafiz Adam. Another round of applause for him. We've all been talking about preterms, taking care of preterms, and we all want to do better. But we have our friends are dedicated ones who help these preterms to come into the world. If they are not there, the pediatricians, we don't get to see these babies. So representing the Society of Obstetricians and Gynecologists of Ghana, we have Dr. Atta Owusu Bempa, who is a fetal maternal consultant. If he says this baby won't come out, what work do we have to do? So we need to let them speak first. When the baby comes out, even if it's 34 weeks gestation like our conference, we can take care of them. Dr. Bempa, please, the floor is yours.
Thank you, Dr. Mrs. I wouldn't attempt to mention your name. And we are happy to be here. I wanted to express our gratitude to the chairperson before she left. I mean, this week is a very busy, she has a very busy schedule, but she made time to be here. So we are happy Professor Dixon was able to make it. And then we're also happy about the good work that our special guest of honor, Mr. Kwame Sefakai, has been doing. I think we are not in doubt about a group of healthcare professionals who are responsible for delivering preterm babies. And as members of the Society of Obstetricians and Gynecologists of Ghana, we are delighted that you are not angry with us. Rather, you want to partner so that we'll be able to optimize the outcomes of these preterm births. Our president, Dr. Ali Samba, couldn't be here physically, so I was tasked to represent SOGOG, probably because they know I have so many friends and collaborators from the Pediatric Society of Ghana. I mean, left to me, I would have given a very long speech, but he wrote his own pediatric speech that I should present, so I think I will stick to that. On behalf of the Society of Obstetricians and Gynecologists of Ghana, it is a great honor to join you in commemorating World Prematurity Awareness Month and to express our profound solidarity with the Pediatric Society of Ghana on this important occasion. The theme for this occasion, equitable care for every preterm, speaks directly to our shared mission and responsibility. Preterm birth remains one of the leading causes of neonatal morbidity and mortality in Ghana and globally. Yet behind every statistic is a mother, a family, and a newborn whose survival and long-term well-being depend on the quality of care that's received across the entire continuum, from preconception, pregnancy, intrapartum, childbirth, to neonatal and pediatric care. As obstetricians and gynecologists, we recognize that preventing preterm birth begins long before labor. And I felt Professor Dixon appealing to me directly when she said we should prevent preterm birth as much as possible so that we reduce the numbers. And I think that's a very good call, because at times we are forced to deliver pregnant women just around 28 weeks. And one of the means to try and prevent this is to optimize women of medical conditions before they get pregnant, so that they don't get complications that will warrant early delivery. So as obstetricians, strengthen antenatal care, improving identification and management of high-risk pregnancies, expanding access to evidence-based interventions, and ensuring safe, respectful, and timely intrapartum care are essential commitments that SOGOG upholds. But our efforts can only be truly impactful when complemented by the exceptional work of pediatricians and neonatologists who tirelessly nurture preterm infants through their most vulnerable days. This partnership between yourself and obstetricians is not optional, it is fundamental. Together, we must champion policies, systems, and clinical practices that ensure every preterm baby, regardless of geography or socioeconomic status, has an equal chance of life. SOGOG is committed to strengthening this collaboration through clinical guidelines, multidisciplinary training, advocacy, and research that will support improved outcomes for our mothers and newborns alike. We stand firmly with Pediatric Society of Ghana in advancing national efforts to reduce preterm births and to provide equitable, high-quality care for all who are born too soon. As we mark this event, let's renew our collective commitment to building a health system where no preterm baby is left behind and where every mother receives the care she needs to give her baby the best possible start in life. And we wish you a very successful conference, and SOGOG would go with you in this noble cause. Thank you very much.
Thank you very much, Dr. Bimpa. We are reminded and thankful for our sponsors, VIU, FFARM, Novartis, and we should all make sure that we find time to visit their stands. Next on our list to give us a message from our HOD, Dr. Enima Safo, is our very own chief resident, Anna Keris's father, our own photographer for the department. He's in the person of Dr. Michael Ecole Mensah.
Thank you all so much and a warm welcome. Yes, so today I have been elevated. So I stand here in the stead of the head of the Directorate of Child Health, Konfanochi Teaching Hospital, in the person of Dr. Enima Safo. I'm Dr. Komensa and I'm a pediatrician. And I am here because I am chief resident of the direct. So I'll be reading the message from her as she had written and edited with no additions. So goodwill message from HOD, the Child Health Directorate, CATH. It is an honor to extend my warmest greetings to all attendees of this Prematurity Conference. As we gather to address one of the most critical challenges in neonatal and child health, I commend every clinician, researcher, nurse, advocate, and parent whose dedication continues to shape the future of premature infants. Prematurity remains a leading cause of neonatal morbidity and mortality, and yet it is also an area filled with extraordinary progress, innovation, and hope. Through collaborative efforts, rigorous science, and compassionate care, we are steadily transforming outcomes for our smallest and most vulnerable patients. The theme, equitable care for every preterm, resonates deeply with our shared mission in pediatrics, which is to ensure that every newborn, regardless of birthplace, socioeconomic background, or medical complexity, receives the highest standard of compassionate and evidence-based care. I applaud the organizers of this conference for creating a platform that fosters shared learning and multidisciplinary dialogue. May the ideas exchanged here strengthen our collective resolve, inspire new pathways of research, and ultimately translate into improved survival and long-term well-being of preterm babies across all our region and beyond. On behalf of the Directorate of Child Health, I wish all participants a productive, insightful, and inspiring conference. Together, we can continue to change the narrative for prematurity, one newborn at a time. Thank you very much.
Thank you very much, Chief Resident. Please still clap for him. He likes the fans. He likes the fans. Thank you so much. So you've realized we have two MCs. So I'm the co-MC, a senior MC. You can tell she's a senior when she slangs. I can't do that. And also be looking at her skin as it goes along. I'll tell you more about why she has that skin. So in all these, we need research. in all these, we need to be doing some work to see whether we are doing well, how best we can help the preterm. So we have our own Professor Eric Tutu Chow from the Dipper Lab, who's also going to give us his goodwill message. Please, a warm up.
Good morning, everyone. So I lead a lab called the Distributed IoT Platforms, Privacy and Edge Intelligence Research Lab, but we call it the DIPA Lab. In fact, when we had an interaction with your society sometime this year, a proposal was given for us to change our name from DIPA Lab to DIPA Lab because we have a team on child health and innovation that is very dear to us. And after having the interactions, we are considering changing the name. But that is still under discussion. I want to make it short. So I stand here to extend warm greetings from the lab, and then the theme of this year's your conference, the equitable childcare for every preterm, aligns very well with what we do as a lab. You see, as a lab, we recognize that for us to achieve equity, the research that we do and the innovations that we develop in the lab should be grounded in local context. Mr. Kwame Sefa kindly say that an incubator, I didn't know, costs about $10,000. So $10,000, how many mothers can afford this? So within the context of the lab led by Dr. Odame, we are developing local solutions. We choose our words carefully. So instead of saying low cost, we say affordable solutions. So affordable solutions, that is being led by Dr. Odame and then Dr. Mrs. Aduma. So low cost incubators that can be used by mothers from local solutions. This one will cost less than 10,000 cedis. So from $10,000 to 10,000 cedis. So we believe that for this equity to be achieved, there should be local context. And this, we see that is the way to go. Within the context of the lab, our mandate or our core theme is why when we think technology, we think about the needs of people. So this is what guides us. And looking at what the society stands for, we thank the organizing committee's unwavering dedication to improving pediatric care standards and its role as a unifying body for healthcare professionals. And we see this as a critical force, the critical force that would translate our innovations that we do in the lab to tangible impact. Within the context of the lab, we've been thinking, what does impact looks like, right? We do worldwide research in AI, in IoT, blockchain, sensors. We publish in very good journals. But they remain up. I'm not sure any of you have read our publications on IoT or blockchain, or nobody has read it. But so we thought and we said impact really for us will be when people, now the research we've done in IoT blockchain translates into the lives of others. So now we are using IoTs and blockchain in these incubators, in these neonatal transfusion devices to solve local problems. So, and without this collaboration with the society, I'm not sure our solutions will reach the market and will not achieve the impact. So I think that the journey for us as a lab has just started, and we look forward to a fruitful deliberation. We commend this vital initiative and wish you a profound, successful, and collaborative conference. Thank you very much.
Thank you very much, Professor Chow. Before we have, now we will start our lectures. Before we have our lectures, if our LOC members will kindly please, if you're not engaged in the back, please kindly please come and fill the seats up front. Thank you very much, LOC. So acknowledging some of our sponsors, Panacea, Ghana Health Service, Confanote Teaching Hospital. Our first lecture is, well, before we go to our first lecture, I would like to acknowledge the presence of Professor Mrs. Planju, who is not here in person with us, but is online. I'm sure all of us are looking around, looking for her, because her wisdom and guidance has shaped so many of us as pediatricians. Please give her a round of applause. She's online. Good morning, Prof. Our first lecture is by Dr. Nana Rekubrobe. She's a very experienced neonatologist, very well published. He is going to give us our first lecture titled The Preterm Care Bundle, Practical Strategies for LMICs and Surfactant Administration. Dr. Nana Rekubrobe, if you are ready, please kindly. She says we should give her some 5 minutes. So before then, we can just stretch, get up straight, meet a neighbor, interact just a little bit for about 5 minutes. No moving outside the auditorium, please. Just a few minutes and we'll get the next lecture started.
Please try and slang. No moving, no moving.
Hello. Please kindly scan for the brochure. Can we have our facilitators also moving up to the front? My sweet boss, looking right at you. Lady Rev said I should continue, but I want Lady Rev in the front. If anybody would like a bottle of water, they can step to the side and grab a bottle of water.
Good morning, everyone. My apologies. Sometimes technology can disgrace you at the most inconvenient time. So this morning, we're going to discuss the preterm bundle. Okay. Basically, we're looking at a set of evidence-based practices that is supposed to help what? Improve the outcome of our premature infants. Okay. Now, sorry. So, the topic for my presentation this morning is on the preterm care bundle, like I said, practical strategies for low and middle income countries and surfactant administration in resource limited settings. So these are the objectives. Okay, that's much better. Thank you. And then this will be the outline. Then, as usual, we'll do some small true or false questions. Okay, just to wake you up. Because of the small break, some of you have started dozing already. Delayed cord clamping is primarily recommended for term infants and is generally excluded from the essential preterm care bundle due to the risk of hypothermia. True or false? Antenatal corticosteroid administration is the costliest and resource-intensive component of the preterm care bundle, creating a major financial barrier in most low and middle income countries. True or false? Okay. The critical time frame, known as the golden hour in preterm care, focuses primarily on stabilizing blood glucose and administering prophylactic antibiotics. True or false? The Insure technique for surfactant administration requires brief mechanical ventilation and is therefore considered the gold standard over the less invasive surfactant administration method. True or false? That one there is like the confidence level has gone down. Okay. All right, I'll skip the next one. So what is a care bundle? We're talking about a set of small, straightforward, evidence-based practices, like I said, that when performed collectively and reliably have proven to improve patient outcomes. Now, the key to a bundle, a care bundle, is that it's all or nothing. You do not decide that I will do 2 of them and leave the other one, okay? It has a multiplier effect. If you do all, then the outcome is what? Much better. So you don't choose and select which ones you want. Now, considering the fact that in our part of the world, we have about 80% of the premature babies, okay? We must be what? Scrambling to think of innovative and cost-effective ways of saving our babies. Okay, we are not boasting to be having Western nickels and all that, but we should be able to embrace the little things that have been proven to help improve the outcomes of our babies. And one such method is the use of the structured care approach, that is the bundle. So this basically covers most of the things that we're supposed to do for our preterm babies. You have your antenatal steroids, magnesium sulfate. I'm sure the obstetricians are happy with that. Then you have your delayed cord clamping. Now that is something that they are not usually happy with because they're always in a hurry. Then infection prevention, which cuts across everything, thermal care. Then caffeine citrate, respiratory support, early feeding and nutrition, proper transport and referral, and then follow-up and monitoring. So the first one is what? You have your antenatal steroids and max sulfate. The whole objective is to reduce what? Mortality. Okay, but studies have proven that it helps reduce respiratory distress syndrome, which invariably would reduce what's the incidence of BPD, chronic lung disease. Then bleeding in the brain as well has been found to be what? An advantage, a benefit. Some studies have even found that it helps reduce the risk of necrotizing enterocolitis. That is something that the obstetricians do. The baby hasn't even gotten to us yet. Okay. So the whole idea is to administer the betamethasone or dexamethasone. The betamethasone I know is more expensive than the dexa. Dr. Cantum, right? Yes, so that one is more costly. So dexa is the most popular one that is given. And you want the woman to receive it at least 24 hours. Okay. Some say 24 hours to even 1 week. It would make a difference. Okay. So you're giving it to the woman who's suspected to have an imminent preterm delivery between 24 and 34 weeks gestation. Okay. Then the magnesium sulfate basically is what? A cerebral palsy preventer. Let me put it that way. It provides what? Protection for the brain. Okay. And is given as close to the delivery as possible. Again, pregnant women with imminent preterm delivery between 24 and 34 weeks. So we realize that DEXA magnesium sulfate, they are not so expensive that it would have to what? Inhibit you giving it. And ideally, the DEXA especially, you have a mother that you want to what? Refer with the baby in utero. The recommendation is that at least give the first dose before you send them off to the receiving end. Okay, it will definitely make a difference. Then delayed cord clamping. Objective is to increase blood volume, improve hemodynamics, and improved cardiovascular stability in the newborn. It says that you're supposed to wait for at least 1 to 3 minutes, actually, before clamping and cutting the cord. Some studies actually reveal that in the first minute of not clamping, the baby can get what? 100 mils of blood. This is a free blood transfusion. As opposed to the baby coming out, you realizing the baby is anemic. Now you have to take a sample, send to the blood bank. They'll do grouping and cross matching. Mother will pay for that before we give it to the baby. This one, free blood transfusion. Okay, so most times you see that the baby has come out and then they're already ready to what? Clamp the cord. The obstetricians especially. Dr. Cantum, I'm apologizing in advance. So they're already ready to what? Clamp the cord. And then you're like, wait, okay. Then I'm standing there, I'm looking at the clock second hand. And then they're all standing there and they're doing this. Do you get? Some will be asking, time as one now, time as one now, time as one now. Then sometimes just out of frustration, you say, you chat. Do you get? But the baby is basically what? Getting a free blood transfusion. It's been found that it helps with what? Regulation of blood pressure in the preterm's brain. When the baby benefits, when the baby gets the what? The extra blood from the delayed cord clamping. It reduces the chances that they would get what? Blood transfusions, okay? And then it also what? Increases the iron stores for the baby. So you realize that what? It makes a huge difference. And it's at what? Zero cost. Zero cost. How? 30 seconds to 1 minute. Okay, it doesn't really take much. If the baby is not breathing, that's different. Now, some studies are even advocating that the initial steps of resuscitation, you do it with the cord what? Attached. You haven't clamped and cut it yet. For some studies, they've noticed that if you wait until the baby needs chest compressions, that is when you cut the cord and separate the mother. Okay. Or if the mother is in what? Dire danger. Maybe she's what? Bleeding profusely or something. That's understandable. But for a normal delivery, and most times the CS is on account of what? Preeclampsia with severe features. It's a maternal indication, not even the what? For the fetus. Okay. So you take the baby out. Just 30 seconds to 1 minute can make a huge difference in the outcome of the baby. Then we come to thermal care. I always say that what hypothermia is a silent killer. It's an invisible killer, especially for the preterm infants. Okay, technically, most of us are even more afraid of hypothermia than fever in the preterm baby. Okay, because it can silently what? Kill the baby. And it's the first and most continuous part of the care bundle. Every degree drop increases mortality and morbidity. I always say this. For every 1 degree drop less than 36 degrees Celsius, it increases the baby's chances of dying by what? 28%. So if it's 35 degrees on admission, 28% chance of dying. 34 degrees, 56% chance of dying. Okay, so you see that keeping the baby warm is a huge part of the baby's link to survival. So because they have a large surface area to volume ratio and poor brown fat, okay, so brown fat is supposed to what? Generate some kind of shivering mechanism, non-shivering mechanism, generates heat via non-shivering mechanism. And once a baby is cold, a baby who is hypothermic is likely to become hypoxic and hypoglycemic. So those 3 tend to go together. Okay, baby is cold, SpO2 will go down, RBS will also what? Go down as well. So we all know the target temperature range between 36.5 and 37.5. Then we all know about what? The warm chain, preventing heat loss at the time of birth. So warm delivery room, at least what? 25 to 26 degrees Celsius. Sometimes when I enter and I put it at 26, and say, because of the gowns, when we are sweating, one anesthetist even told me that what? I'm destroying his sperms because I've made the place too warm. Do you understand? But I always say that it is just for about what? Less than 30 minutes. I take the baby out. You can put the temperature to 0 for all I care. But once the baby will be coming out into that environment, you don't want to create a steep gradient. Who knows the temperature in the uterus? Sometimes when you can't sleep at night, you Google all kinds of things. Temperature in the uterus, do cows have quadruplets? All these weird things. Who knows the temperature in the uterus? It's about 37 degrees Celsius. So now you have a fetus coming out. Mind you, naked, but naked. Okay, so your baby is coming out from this cozy 37 degrees Celsius, and suddenly is brought into this harsh Kumasi, wherever Ghanaian world. Okay, the least we can do is to make the place what? Warm. Okay, because if the place is very cold, because of what? Like I said, the gradients, they're likely to lose more. And you work and sweat more when the baby is cold. Is that what you want? And you be bagging, and under the radiant warmer, you can feel the sweat going down and all that. You can prevent all that just by making the delivery room what? Warm. As soon as the baby comes out, you take the baby out. Then the rest there can do whatever they want with the AC. Then immediate drying, skin to skin contact, breastfeeding, bathing, and weighing postponed. Sometimes it's not even the mother who is asking you, it's the grandmother. Dr. Nadabeni beats me no. Nam say ade mucha adobe manana. Okoye ejuma no watin fifre. Do you get? Bathing should be postponed. Generally, WHO says after what? 24 hours. Okay. But even with a preterm infant, what are you in a hurry for? Okay. Then weighing the baby. Sometimes you enter a delivery room and the weighing scale is directly underneath the AC. That is the permanent location for the weighing scale. And then when the baby comes out, then we just what? Plop the baby on the chilled weighing scale. Okay, before you wrap up the baby. All these will what? End up contributing to mortality. Warm transportation, warm resuscitation, training and awareness raising. So I've already spoken about prevailing room temperature. So in babies who are less than 32 weeks, the general recommendation is that you can actually deliver them into a plastic bag. You do not need to wipe them first. So if you put them in the plastic bag and then you enclose them in it, okay, even when the baby is losing the bodily fluids, okay, it creates what? A humid environment in there for the baby, and it's all kept there. So for the first hour or so, when you're setting a line, you can poke a hole, bring the hand out, set a line, do whatever it's needed. Okay, under the radiant warmer, eventually you take it out when the baby has been what? Stabilized. Otherwise, you immediately dry and cover the head and place under a preheated radiant warmer. Okay, sometimes you forget to what? Switch it on. Even the most modern radiant warmers, they do not immediately become what? Heated when you switch it on. So you need some time to what? Place them there. Then KMC. We all know about KMC. Okay, what could I possibly say about KMC that is new here? Now, WHO is saying that what we should do immediate KMC. Of course, that one comes with its own technical challenges as well. Okay, mother and baby being together, infrastructure-wise, all that. But the key thing is that as much as possible, baby should be placed there. At least that should be the takeaway. Sometimes a mother can just be what? Lying there, and then the baby too is lying there like they're fighting. Place the baby there. Okay, so as much what? Skin to skin contact as possible. Benefits: 40% reduction in mortality, improved breastfeeding, thermal stability, reduced infection, etc. I don't know why my slides are cutting like that. So this is from the WHO recommendations for the care of the preterm and low birth weight baby. So this is the updated recommendation. They said that what? KMC is recommended as routine care for all preterm or low birth weight babies, should be initiated in the healthcare facility or at home, and should be given for what? 8 to 24 hours per day. But basically what? As many hours in the day as possible. Okay, these are some of the benefits. Hypothermia is the biggest benefit for KMC. Okay, 80%. Higher rates of exclusive breastfeeding, better weight gain, earlier hospital discharge, reduces rates of infection, reduction in apneic episodes, reduces crying and serves as pain relief. All these are what? Benefits of the KMC. So from thermal care, we move to what? Respiratory support. Okay, CPAP. I mean, when you hear prematurity, you should hear CPAP. Okay, sometimes I get questions like, oh, Dr. Nana, I had this baby, was born at 33 weeks. When the baby came out, initially the baby wasn't showing any signs of distress. So I just put on INO2. Then I came back later and now the baby is working very hard. Usually I would say, you know what? When the baby comes, so long as the baby is premature, especially those who are less than 34 weeks, put on CPAP. Put on CPAP. Remember, they come with very little surfactant. So when the baby comes out and the baby is all chilled and laid back, not working hard, that means that the baby is relying on what? The little surfactants that he came with. And then eventually the baby will what? Run out. And that is when you'd be in trouble. Okay, because you didn't see it coming. Okay, so it prevents atelectasis, reduces incidence of mixed and obstructive apnea. The benefits are what? Numerous, okay, especially in our setting here. Now, I cannot talk about respiratory distress without talking about what? Apnea of prematurity. So caffeine is what? A low-cost, high-impact drug in our setting here. Okay, they always go hand in hand. The role of caffeine cannot be what? Overstated. Okay. Also, you're putting your baby on the CPAP. then you're also giving your baby what? Caffeine citrate. It's been found to reduce what? Bronchopulmonary dysplasia. Okay. Whenever you hear about caffeine, you should know about what? The CAP trial. Caffeine citrate for apnea of prematurity. So they looked at what? More than 2,000 premature infants and followed them up till they were about 11 years or so. Okay. And when the babies were about 1.5 years old, about 18 months, they noticed that those who were on caffeine reduced incidence of what? Mortality, reduced incidence of cerebral palsy, okay, and then BPD as well. When they were 11 years old, they noticed that what? They had better mental outcomes as well. And then better respiratory outcomes too. So caffeine, even though caffeine, quote and unquote, is a cheap drug, okay, it's a very what? Good drug. Okay, it's been seen as what? A silver bullet in newborn care. Okay, you might not respect caffeine, okay, but it does a lot of what? Wonders for the preterm baby. Then, of course, once you have a baby on the CPAP, then your oxygen saturation comes in. Okay, I always say that a baby on supplemental oxygen should not be saturating at 100%. There's nothing to boast about. Okay, invariably what? You're sort of what? Having a negative impact on the baby's long-term outcome. Okay, so you always need to have what? A target range. We're aiming at what? 90 to 95%. Okay, because you do not want the baby to end up with what? Eye problems. Dr. Ahmed is here. He'll talk about it. You don't want the baby to end up with what? Intraventricular hemorrhage. Okay, necrotizing enterocolitis, chronic lung disease. All these things are what can be as a result of our bad habits. Oh, since morning, the baby has been saturating at 99%, so he's cool. No, he's not cool. You are killing the eyes. Okay, so always watch your oxygen. So now we move to early feeding. Okay, you want to establish enteral feeds early. There's no rule that the preterm infant cannot start feeding within the first 24 hours of life. The earlier the baby starts feeding, the better the outcome. Okay, we'll talk about feeding later on. But the whole idea is to what? Initiate trophic feeds, minimal transport vehicle. Okay, so it's important that you have a healthcare person inside who appreciates these things. She's the one who will tell the driver that, hey, driver, baby, wait, do you premature? You want to move, obey den, obey pra. Okay. All right. Then, of course, I cannot talk about this without talking about what infection prevention and control. Healthcare workers have been found to be the worst culprits. One study revealed that 49% of healthcare workers do not practice hand hygiene properly. Okay, it's hard, isn't it? Very, very sad. And I always tell my people, IPC is not about you only protecting the baby. It's about you protecting yourself as well. Because you don't know what you are touching and taking home. So look at it, be selfish about it. Always wash your hands. You touch a baby, you don't wash your hands, your phone rings, you pick it, you receive the call, you put the phone back into your pocket. I always use the example. You get home, your little child wants to watch something on YouTube. You give the phone to her. What's the next thing that will happen? Exactly. Then like 3-5 days later, you bring your child to the hospital. This one is you. Your IPC measures. Okay, so always be selfish about infection prevention and control. Look at it that way. Always wash your hands in between babies, in between even if you're just going to touch, you're not going to touch the baby. Some will say, hey, I'm just touching the incubator. No. Do you get the incubator, that micro environment around that baby? Okay, assume it is infected. Proper use of antibiotics, appropriate and hygienic cord care, minimal handling. Okay, if it's not absolutely necessary that you must touch the baby, leave the baby alone. Okay, if you need to do RBS, you need to take a blood sample, you need to set a line. Organize yourselves and do it all at the same time. Not that you do the RBS, then you go, then you come back, then you come and set a line. You're disturbing the baby. Remember, the baby is supposed to be what? The more sleep the baby gets, the better the brain growth and development. So if you're always waking the baby up, okay, it'll affect the brain growth. So IPC bundle for preterm infants, aseptic technique for all invasive procedures, chlorhexidine cord care according to national unit policy. Okay. And I know the Ghana Health Service still uses chlorhexidine a lot, right? Or, okay. Environmental cleaning. Okay. The cords, the radiant warmers, and all that in between patients. How often do you clean them? And how deep do you clean them? Then your antibiotic use. So now post-discharge, our work does not end with discharging the baby. In fact, it's been found that the first year after discharge of the preterm baby is when the baby has a lot of changes. There's a lot of impact. So depending on how you follow up on the baby, okay, the outcome can be different. Okay, so you need to monitor for catch-up growth. They can become anemic, especially for the extreme preterm babies, those born at less than 28 weeks. It's been found that on the average, in the first 3 to 4 months of life, they can get like 3 to 4 blood transfusions during that period. Okay, then screening for the eye, hearing, and then chronic lung disease. So there's the need to have a clinic for these visits. You need a dedicated follow-up system to catch treatable conditions like anemia and ROP before they cause permanent damage. Then you have KMC, immunizations. Okay, so many a time we say that the baby is too small. That's why we don't want to give the immunizations. But you see, the irony is that it's a preterm infant who needs the vaccines the most because they didn't wait to even get the maternal antibodies from the mother. So here's a baby who's come out, has no immune defense, no means of protecting him or herself. And then we deny the baby the vaccines because what? One vaccination nurse told me that the baby doesn't have any thigh fat, so she cannot give the injection. I mean, can you imagine? Okay, so the preterm babies, they are the ones who what? Need it the most. The recommendation is that when it comes to nutrition, you need to track the growth until corrected age of 2 years. So just want to say something small about the golden hour. Okay. Now, the preterm birth, because all their organs are underdeveloped. Okay. You know, the concept of the golden hour is most popular in, I think, trauma and emergency medicine. Okay, that is where this was also derived. The whole idea is that within that hour, you want to put measures in place that will prevent what? Irreversible harm and reduce the chances of mortality. Okay, so antenatal preparation, here's where the obstetricians come in, identifying at-risk mothers, giving your steroids and magnesium sulfate. Then the delivery room setup, we've spoken about the temperature, getting your resuscitation equipment ready, ensuring that it's all functional. Then at birth, what happens? Okay, is there a need for resuscitation, etc., etc.? So this is a checklist. Ongoing respiratory support. So CPAP, early CPAP to prevent lung collapse, target oxygen range. Then if you're struggling to get peripheral line, you can immediately do your umbilical venous catheter. Then your IV fluids, ensuring that the RBS is within normal range. And then all the while maintaining the temperature within 36.5 and 37.5. Then of course, strict hand hygiene, communication, informing the parents. You need to tell them what is happening. Everything needs to be discussed with them. Okay. When it turns sour, maybe the baby deteriorates or the baby dies and all that. If you've been updating them consistently, okay, they accept it better. But if you shroud the whole process in mystery, the baby comes out, then you immediately carry the baby. Inside be, then the father will be pacing outside. He comes in and Pachome, but Papa is serious. Do you get? You don't say anything to the father. Do you get? And then suddenly the baby dies. Then you go, Papa, so him say nyame nema. No answer no thing. Oji. Do you understand? God gives and God takes away. Meanwhile, you didn't say anything to him. Do you get? From the very beginning, you tell him, oh, your baby was born at, say, 26 weeks. Even in Ghana, the cutoff is 28. But your baby is showing signs of life. So we are what? Taking the baby to the neonatal unit. We're going to do what? All we can for the baby. Do you get? So at the back of his mind, he knows that the chances are not so good, but they are going to try. So if you come out and you say, you know, I told you that 26 weeks, do you get? That one is more acceptable than you immediately carry the baby. Papa, Charlie, she gave birth too early. You let me take the baby. And then he's standing outside, then he's pacing. Everybody is passing. He attempts to get some information. It's like some secrets, World Bank, AEB, nobody wants to open up to the father. Then when there's bad news, dear, you come and then you expect him to accept it. Okay, communication is key, very key in newborn care. Sometimes the baby even comes out, baby is fine, oh, everything is okay. And like I said, within a minute, baby has suddenly turned and you are bagging the baby. Okay, so sometimes you've even spoken to the parents, they've come to see the baby. So then they come and they're like, but what happened? But because you've spoken to them earlier, sometimes you can just tell them, honestly, I have no idea. Okay, so that is when you go explain tire. Maybe it's the heart, maybe it's this. Do you get? But when you haven't said anything to them, no matter what you say, okay, they struggle to accept it. So with regards to the golden hour, anticipate and prepare. Once they say preterm delivery, then your mind should start racing. Temperature, temperature, temperature. Do you get glucose, respiratory support? Because all their organs are what? How can I support these immature organs within the first hour? Because what you do in the first hour will what? Dictate how the baby will go from there. Then teamwork. Okay, because you don't want a situation. So if ONG comes to say, oh, we have this baby, 29 weeks, bad obstetric history, what, then I'll say, Monica, yempe incubator. Even when there isn't an incubator, then we are going around, which baby can we remove from the incubator? Because the one coming is expected to be worse than the one in there now. Okay, so you prepare the incubator, you pre-warm it, you bring your CPAP. Then she say, debut. Okay, mommy, has makes me you be a CPAP this one. Do you get? That's the stark reality. But at least you are what? Preparing. So you put things in place. Not that the baby comes and there's no place. Then, okay, so what do we do? Meanwhile, the baby is what? Getting cold. Okay, so you see that preparation makes a huge difference. With thermoregulation, then gentle resuscitation. Okay, I appreciate the enthusiasm behind you resuscitating a baby, but sometimes it's too aggressive. So sometimes it's like the resuscitation, the baby cry is like, you let me go cry. Now this one dear. Okay, remember they are very what? Fragile. All the texts, when you do your research, they would say gentle resuscitation. Resuscitation with steez. Do you understand? Oh, boom, 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 boom. Then the next thing you see, there's blood coming from the nostrils. What is it? We all have problems, but don't vent it, what? On the baby. Okay, gentle resuscitation. Okay, all right. So this is the last part. I'll be done soon, I promise. Surfactant therapy. So we realize that the preterm care bundle is basically in line with what WHO recommends for the low birth weight and premature infants. Okay, thermal care, breastfeeding, IPC, respiratory support, caffeine, CPAP. Okay, surfactant is not part. Okay, but gradually what? We are getting there. Okay, maybe by the end of Mohammed's term, surfactant will be free. Okay, so basically surfactant, remember I said that caffeine is a low cost, high impact intervention. Surfactant is usually referred to as what? High cost, high impact intervention. Okay, so it's a high cost that usually removes us from the equation. Okay, but it shall be well. So the whole idea is that the preterm baby is born with very little surfactant. Okay, so they come out and they're working very, very hard to breathe. Basically, it helps to what? Improve oxygenation, reduces the risk of pneumothorax, and reduces mortality. Now, the teaching is that if a baby comes out, for our setting here, okay, you want to assess and see whether the baby is in severe respiratory distress. Okay, most centers in even high income countries, what they do is that they would give a unit protocol. If the FiO2 requirement is more than 40%, okay, then you give the surfactant. But the cutoff for the qualification, the gestational age is different. So maybe South Africa would say if a baby is at least 26 weeks, you can give the surfactant. Okay. Norway would say if the baby is at least 23 weeks, you can give the surfactant. So you see that it's no biani ni bottom, okay, because it depends on the chances of survival, okay, the viability in that country. So there are three modes of administering surfactant now. We have the first one is the insure. So intubation, surfactant, extubation. Okay, that is like the traditional means of administering surfactant. So that one, you're actually passing an endotracheal tube and you are instilling the surfactant through the endotracheal tube. Now, the limitation is that it requires skilled neonatal intubation. Okay, so then the person has to be able to what? Intubate. Okay, and that one also comes with what? Risks of airway trauma, infection. Sometimes a baby will suddenly what? Desaturate. So that means that you also have to be what? Skilled in resuscitation and all that. Okay, so that's you intubate, you give the surfactant, then you extubate. That is insure for you. Then along came Lisa. In fact, Lisa came together with MIST. Lisa is less invasive surfactant administration. MIST is minimally invasive surfactant treatment. One originated in Germany and the other in Austria. I've forgotten which one. But Lisa happens to be more popular. So the process involves what? Using a thin catheter. Here, you're also intubating, but you're not using the endotracheal tube. You're just using the thin catheter, and then you instill the surfactant through it. Okay. Now, the difference is that it is not expected that, when you use the endotracheal tube, if let's say the baby is desaturating, you can connect an ambu bag and bag. So there are somewhat inflations. But with this one, you cannot do that. So the advantage of this is that you do not artificially push in what air into the lungs, because that was one of the concerns for insure. The concerns that when you are using the ambu bag to inflate the lungs, okay, you can be introducing high pressures into the lungs, which can cause what? Damage. So basically, it's the same process actually. A laryngoscope is used to visualize the cord, surfactant is given, and then the catheter is removed. So no bagging, no endotracheal tube. The only limitation is that it requires a dedicated catheter. But in our setting here again, we're very good with improvising. Okay. Sometimes NG tube you can what? Use it. So that one wouldn't inhibit us. Then salsa. Salsa is a third one. That's the game changer. It's been called the game changer. Okay. So you're giving it via a laryngeal supraglottic airway. I had meant to add a picture, I forgot. So basically, it's like a conduit to deliver surfactant. Okay. Why is it ideal for low and middle income countries? Easier skill. Okay. You basically just push it through. Okay. You don't need a laryngoscope or anything. Okay. It requires a technique, and it's much faster and easier to train than intubation, and it's less invasive. No trauma. Okay. And the good news for our part of the world is that it's reusable. Okay. And you do it while the baby is what? Simultaneously breathing. Okay. So everyone can be trained to do it. Okay. If the surfactant is there, you don't have to call the pediatrician on duty to come and do it. The laryngeal mask airway, the nurse can pass it and then immediately give it. Okay. So you see that is very user friendly. Studies have shown that it's as effective as intubation for reducing the need for putting on a ventilator. It empowers more staff to do it, okay? And then it's much safer, okay, because there's no need for intubation attempt. So what you need is what? Training on the LMA, insertion skill, your CPAP, because as soon as you put it in, then you place a baby back on the CPAP machine. So we're almost there. Identifying barriers in resource-limited settings. Basically, there's just three main categories. Human resources. Okay. You need, I don't even know what the current ratio is, the current patient to doctor, patient to nurse ratio is. Okay. But you see that people are moving away in droves. Okay. Today you're on duty with somebody, tomorrow you call, it doesn't go, you do WhatsApp call. Away bus. Okay. So insufficient staffing, lack of specialized training, and high staff turnover. Okay. This one, there is more of the nurses, more of the nurses. You train someone, then the next thing you say, you say, yeah, the new male ward. Okay. And that can be what? Very, very discouraging, extremely discouraging. Okay. The material resources, erratic power, water. Okay. Stockouts of essential drugs, surfactants, antibiotics, caffeine. Okay. It's sad that there's still some parts in Ghana that are using aminophylline. Okay, instead of caffeine. Lack of equipment. So CPAP monitors, even radiant warmers, some places don't have it. Okay. Then, of course, systemic challenges, poor referral pathways. Poor referral pathways, lack of protocol, poor data collection. So I always say that you cannot manage what you do not measure. Okay, if you have no idea what is happening, how can you make what appropriate plans for that? So basically, the takeaway, the preterm care bundle is not about rigid rules. It's not a long list of checklists that you just be ticking. It's a tight package of interventions, and it's all or none, like I said. But everybody has to buy in. And remember that all these things are evidence-based interventions. Okay, they've been proven. So by grouping these practices into a non-negotiable bundle, we're able to what? Improve the outcome, okay, of our preterm babies. Then we cannot go forward without our obstetricians. It's a continuum of care. Whatever happens during the pregnancy, okay, it will affect us. Okay, so we need to what? Work hand in hand. Okay, when it comes to asphyxia, we cannot run away from them. When it comes to prematurity, we cannot run away from them. When it comes to sepsis, depending on how they handle the pregnancy, delivery, labor, we cannot. So you see that these are the top three causes of what? Admissions and deaths. Okay, so we need to what? Be able to work hand in hand with them. These are the whole recommendations. So basically, the new ones they're talking about immediate KMC, caffeine, family involvement, home visits, follow-up, then updated KMC, mother's own milk, early initiation of enteral feeding, duration of exclusive breastfeeding, iron supplementation, and then CPAP for RDS. Thank you very much.
Thank you very much, Dr. Nana. I was enjoying the lecture so much that we ran a bit over time. I know we're all itching for a short coffee break. Before, are there any? Let her get some water first. And then before I open the floor for questions, we'll take a short message from Dr. Rudolph Kantum, who is the president of the Fertility Society of Ghana and also the CEO of Ruma Fertility Specialist Hospital. We have just about 5 minutes. With a round of applause, please welcome Dr. Kantum.
Good morning, everyone. I'm very sorry to bring you back a little bit, but I had to be in this conference for two reasons. Number one, I'm a creator, one of the creators of iatrogenic prematurity, because I do IVF practice. In fact, before I came here, I did this, and I gave each of them 2 embryos. If they should all get pregnant with the 2, it means maturity is staring at our face. Number 2, I represent the Fertility Society of Ghana, and we are working very seriously to address the issue of number of embryos that we transfer. In fact, I've seen many faces here. We fought so many battles together. When we deliver, we send it to pediatricians. I said, Dr. Kanto, next time, put 1. The patient said, oh, I have 5 embryos. Why don't you put 3, 4? So it's a big, big, big challenge, but I'm sure we're going to overcome it. So I'll now go to my prepared talk from this is a solidarity message from the Fertility Society of Ghana. On behalf of the Executive Council of the Fertility Society of Ghana, FESOC, that's the short form of it, and the entire membership of FESOC, I bring you warm solidarity greetings and felicitations. First, FESOC thanks the leadership of the Pediatric Society of Ghana for the invitation to participate in this meeting, and warmly congratulate you, your society, for organizing this very important conference to mark World Prematurity Awareness Month. There is a huge global burden of prematurity. According to WHO, in 2020, approximately 13.4 million babies were born preterm. In 2022, it was estimated that about 1 million babies died from causes related to prematurity. As is always the case, these health statistics the low and middle income countries bear a disproportionately high burden of prematurity. About 90% of babies born before 32 weeks in high income countries are able to survive, whilst the rate is about 10% in our part of the world. Data from African Network and Registry for ART, that's the continental body that gathers data from all IVF clinics in Africa. That states that the whole of Africa shows the following disturbing realities of IVF practice on the continent. Babies born at 37 weeks or more occurred in 80% of singleton pregnancies. So it means that if you transfer 1 embryo, you are expecting 80% of it to reach 10. 40% in twin pregnancies, and only 6% in higher order triplet and high order pregnancies. Babies born extremely preterm, that's before 28 weeks. The prenatal mortality rate for prematurity for IVF cycle in Africa versus the rest of the world is also disturbing. If it's a singleton, other parts of the world, only 6% die. In our part of the world, 22%. If it's a twin pregnancy, 12% for the rest of the world, and 51% for Africa. If it's triplets or more, 81% per 1,000 live births for the rest of the world, and 147 per 1,000 live births for if there's triplets or more. So you can see the impact of transferring more embryos. According to the same ANARA data, in Africa, in 2022, single embryo transfer, only 30% of IVF cycle had single embryo transfer. Double embryo transfer was 41%, and triplet transferring 3 embryos or more was 36%. So collectively together, 78% of all the IVF cycles that we do in Africa, including Ghana, is multiple embryo transfer. That is where the multiple pregnancies are coming from and why we are having a lot of this preterm babies. So it is very clear from this data that governments and fertility practitioners must address the issue of number of embryos transferred in IVF cycles. The partnership between fertility specialists and pediatricians is a critical and special one. The ability of fertility specialists to create embryos in vitro and to determine how many embryos to transfer, if not regulated by law, has resulted in twin and high order pregnancies with disastrous consequences for both mothers and babies. Ghana has a fast-growing fertility landscape with new centers emerging every day. For instance, about 12 years ago, there was no fertility center in Kumasi. Now there are 7 centers, and across the country, we have more than 30 IVF centers. and they are all creating embryos every day. The Federal Society of Ghana, since the formation in 2016, saw the need to regulate ART practice in Ghana and initiate the process with the Minister of Health and other stakeholders in drafting the ART guidelines. ART is Assisted Reproductive Technology Guidelines for Ghana. The draft guidelines are far advanced, and hopefully by next year, the document will pass into law. Specific to the issue of prematurity in relation to IVF practice, the guidelines stipulate that not more than 2 embryos shall be transferred in any IVF cycle. So if a center does 3 embryos, you have to explain why you give the woman 3 embryos. I'm confident that with time, especially when the state begins to support fertility care, more emphasis will be put on elective single embryo transfer, just 1 embryo at a time. This will be a game changer, a true game changer in the iatrogenic cause of prematurity related to IVF practice. The theme of this conference, World Prematurity Awareness Month, Equitable Care for Every Preterm, is apt and timely. Despite our best efforts, we will not be able to prevent every case of prematurity. We must therefore invest in training of highly skilled pediatricians, neonatologists, accessible and affordable to all Ghanaians. I want to assure our pediatric colleagues that FESOC is taking very serious steps in partnership with HEFRA to regulate ART practice, whilst we keenly await the passage of the ART bill. I wish to suggest here that in partnership with the Pediatric Society of Ghana, let us come out with joint guidelines, evidence-based guidelines in the prevention and management of prematurity. FESOC's guideline committee can work with our pediatricians on such a project. On behalf of FESOC, I wish you very insightful and fruitful deliberations. We look forward to actionable recommendations at the end of this conference so that together we can reduce the burden of prematurity and improve the care of preterm babies. Thank you very much for your attention.
Thank you very much, Dr. Kantung. Hopefully from next year, 2 embryos, not 3. So Dr. Rekobobe and Dr. Inuvashiado, we won't be getting more preterms. At this juncture, please, do we have any questions for Dr. Nana Rekobobe? Dr. Geraldine Nana Rekobobe. Question.
Yes, I was so fascinated about her talk. But there's things that she has mentioned I've not heard before. And I was wondering, how can we take this knowledge over there to Bolgatanga, to places where they don't have what, in fact, we in Korea, we are blessed so much, we cry. Other places is just 0. So I'm suggesting that this high impact, impactful knowledge that you have, maybe the Pediatric Society of Ghana should come out with a program. But some of us are willing to support, such initiatives so that you can go around the country. I mean, get resource persons to go and organize these talks, at regional level so that they can begin to implement some of these simple but cost-effective things that, we talked about. Very insightful, President. Thank you.
But you need sponsorship, right? So first off, can do, yeah. Yeah, so thank you, Nana. That was a very insightful presentation. And I can assure you now, a lot of obstetricians do DCC, that's a delayed cord clamping when needed. And we've done cases with a lot of colleagues from pediatrics, and they will do the time out for us. And okay. My question has got to do with some worry some of us have concerning acute 2020 transfusion if it's got to do with monochorionic pair. And once you clamp the cord for the first one, the BP in that circulation in the placenta will drop, and we are afraid there will be shunting of blood into the placenta from the second one, which is undelivered. So I want to ask your views in terms of evidence, what you think those of us who still have issues of that should do when it comes to monochorionic and delayed cord clamping, because we are afraid of fetal castration.
I think that at the end of the day, it's supposed to be a physiological intervention. So long as there are any concerns that would affect the outcome or survival of the fetus, okay, you can decide not to do it. Okay, so if there are any concerns at all, when you've done your scan, you've confirmed that there's TTTS or anything you're worried about, the vascular anastomosis, whatever, but you can decide that no, this one I have to veto it. Yes, yes. So it always has to be individualized. Okay. Ajiman.
That's a difficult question. So I think now the current neonatal resuscitation program, the latest edition, they've included a fourth question for the pre-birth questions, and it's called care plan. And I think we rely on obstetricians. If we know it's monoclonal, we don't do it.
You see, yes.
Part of your regulation, I think it would be proper if you are to do if you're an IVF center, you should definitely have a neonatal unit. What do you think about that?
Absolutely, absolutely. I mean, my early years, I've been doing IVF for about 15 years now. My early years, you all agree that the headache I was giving you, now don't give you that headache. Sometimes we send baby to it. But first of all, every IVF center, knowing the problems that you are faced with, but we haven't reached a point where we'll do single embryo transfer, which will drastically reduce the number of multiples. So if you are doing even two, you should have a well-equipped ICU. In fact, if you ask Dr. Joe, she can attest to the fact that Ruma has a very, some of the babies 26 weeks were able to survive in our facility. So we are encouraging, it will be part of the guideline anyway, that in fact, it will be part of the guideline that every IVF center should have a certain minimum standard of things that should be present, including equipment, personnel, and all that. So, psychologists, everything. So the guideline is a very detailed one. I think the next time we are going to do the last round of stakeholder meetings, we have to involve the pediatricians. I don't know why it didn't occur to us, but we have to involve them. You make your input in the guideline so far as regulation is concerned. So thank you. No, see, no, the point, no. Oh, no, Dr. Bimpa, FESOC itself was born in 2016. 2016. We formed FESOC in 2016. Then COVID hit, 2019, 2020. In fact, we started the guidelines around 2018. We held a series of meetings, in fact, about 3 or 4 stakeholder meetings. Okay, then change your government came. We just had our annual conference last month in Tema, and the chairman of the Parliamentary Select Committee on Health, Dr. Maknawani, was there. Professor Bayu Tertis was there. The chief executive of HEFRA was there. We intentionally brought all these people inside. I'm not too sure about that, but so the guideline actually, in fact, if you look at regulation, Nigeria started IVF in 1985. Ghana's first IVF baby was born in 1995 at Provita. Nigeria is nowhere near Ghana when it comes to guideline development. It's the issues of surrogacy, egg donation, sperm donation, they are the key issues that is dragging this in, because some people, religious people, are against it. So we have to tread a fine line, So that is what is keeping the guideline. We want to make sure that all the stakeholders bring their input before it goes. It has to go to Attorney General for them to look at the wording, then it will go to Parliament for ratification. So it's not a simple process, and you have to fund it.
Thank you, Dr. Nana, for this beautiful presentation. Please, my question is on aminophylline. I heard you say it's so sad that some parts of the world they are still doing aminophylline, and I think it's true. So I want to know, is it about the availability of the caffeine citrate, or it's like aminophylline should be taken entirely out of the AOP, or it's what you have at your facility? Thank you very much.
You know, we're trying to get aminophylline, I don't know. Trying to get caffeine citrate on the NHIS list, right? But before you can do that, it has to be put in the standard treatment guidelines. Then from the standard treatment guidelines, it will go to the emergency essential medicines list before it can be considered for NHIS, right? And then one of the NHIS guys was like, so are we saying caffeine citrate is first line and aminophylline is second line? And we said no. It has to be just caffeine citrate. He said, okay. So should we take aminophylline out? And then we said, no, still keep it there. He said, what is it that you people want? Okay. I was saying that it's sad because even in parts of Ghana, okay, they use aminophylline. I mean, aminophylline does work, all right, but it's just that the disadvantage with aminophylline is that one, it has to be IV. Two, it has to be given 3 times in a day. And 3, ideally, you need to monitor serum levels. So every baby on aminophylline, you need to be taking samples of the blood and seeing the levels of the aminophylline in. Now, pied against caffeine is oral once a day. You don't need monitoring. You're not worried about adverse effects because it has what we call a wide therapeutic window, meaning that, I mean, even if human error comes in, they're supposed to give 10 milligram per kilo and you end up with 15 or even 20 milligram per kilo, you're not likely to see adverse effects. Do you get it? So you see that when you look at caffeine, the profile of caffeine, it's much easier to work with compared to aminophylline. Do you get? So I'm not sure how much aminophylline costs. I've forgotten, Ajima, do you know? But I doubt if it's to be honest, I'm not sure how much, but I'm thinking that do they even still use it for asthma? I think they still use it. They hardly use it. Yes. Oh, okay. So aminophylline, caffeine is much more friendly. Okay. It's much more friendly and it is affordable. And especially if they manage to put it on to have it covered by NHIS, then it would be easier to use. Now, Ghana has managed to come up with guidelines for apnea of prematurity. Okay, all in a bid to help with this caffeine issue, to make it available to all parts of the country. Okay, so it is available. If your facility wants to get it, it's now there's a company, Ethifarm, produces caffeine in Ghana. Not they produce, but they can get you caffeine. They are the ones that produce the caffeine IV and then the oral. So it's much easier and to access it now. Okay, pardon? I think they're even around for this conference. Yeah, you can talk to them.
Okay, please hold on with your questions. We need to go for the coffee break, 15 minutes. When we come back, 15 minutes. When we come back, we'll continue the questions because I think they also need to leave and serve some other guests. So please, on my right-hand side, let's get our coffee, interact, make new friends, get somebody who supply caffeine for your facility. Thank you.
For your hands upon the Lord, He will surely give you. He is faithful to his word. Never fail. There is nothing he can. Don't you worry, don't you fret, my brother. He is faithful to his word. He never lies, he never fails. There is nothing he can do. Guarantee you. Guarantee you. Yeah, baby. And sure, baby, she said, yeah, baby. And I hear you singing this place, and I get you. Yeah.
Hello. As we're taking our snack break, our sponsors have set up stands. Let's please kindly go and interact with them, learn more about the products that they have and how they are helping with this Prematurity Conference. And as always, we are grateful for the sponsorship, partnership with Ghana Health Services, sponsorship from Panacea, Farm, Novartis Ghana, Please kindly interact with our sponsors. Thank you.
Don't give up on God, 'cause He won't give up on you. He's able. Don't give up on God, 'cause He won't give up on you. He's able.
Good afternoon, everyone. Please, if you've already had your snack, in the adjoining conference room, we have our sponsors, pharmaceutical companies who have set up to interact with us. So please, if you are done with your snack, you can head to the next room for the next 10, 15 minutes and we'll be back. Thank you very much. If you are comfortable, you can carry your snack along and interact, socialize, have a chat with the sponsors.
My ears are hurt. But all my sisters till this very day, I have never ever heard of sin my Jesus paid. From before time began, he has never ever changed. He's the same today, just as he was yesterday.
As we bite on our snacks, let's not forget to go to the next auditorium and interact with our pharmaceutical reps. Thank you.
Hello. Please, if you see a car key with a PSG key holder and a phone, please, anybody who has seen that, please kindly give it to me. Thank you. And please, there's an exhibition in the next hall. Please, they are sponsors, so please let's interact with them. Thank you very much.
Hello. So we brought some sponsors to give you a lot of goodies. A lot of goodies. Please don't let them take all these good things back. Your facilities and your units will need these goodies. A lot of them, medications and other things. Please go for them. Go for them now. And don't come and complain that when you came for the conference, you didn't even get anything to take back to your facilities. There are a lot of goodies for you. All right. So go there and interact with the sponsors. All right. Okay. So I'm also told that there are extra pastries for you. So you can go for extra pastries. Okay. We really want you to enjoy this conference because we are going to spend a lot of time learning, doing hands-on. So please build up your energy now. Okay.
Oh, you waited. Came out your way. You sat down to speak to me. What amazing grace that you show so patiently, and you just want.
Please, can we all get seated? Please, can we all go and sit down so that we can continue? Please take your plates inside, we beg you. Betty. Please, can those of us outside kindly come in so that we continue? Thank you so much. Please, can we take our seats and continue with the program? We still have some more interesting topics, but time is not on our side, so we'd like to continue. Before we take a lecture from Dr. Chrissy Ahmed, we'd like to call on the Kumasi Metro Health Director of Health Services, Dr. Omari Sasu. Madam.
Good afternoon. I'm here on behalf of my Regional Director of Health Service, Dr. Fred Adomako Boateng. So he's asked me to deliver this address on his behalf. Distinguished ladies and gentlemen, guests and honored colleagues, dedicated health professionals, dear friends, I congratulate you on your maiden Pediatric Society of Ghana maiden Prematurity Conference. And it's on the theme, equitable care for every preterm baby. This is not simply a slogan. It is a moral commitment and a scientific imperative and a promise we must hold together. Every year, millions of babies are born too soon. Behind each number is a story, a family filled with hope and fear, a fragile new life fighting for a chance, and healthcare teams doing everything in their power to give that child the best possible start. But as we celebrate the remarkable progress in neonatal care, we must also confront a difficult truth. Not every preterm baby has equal access to the care that can save and transform their lives. The reality we must address across the world, whether in high-income cities or rural communities in low and middle-income countries, the disparities are stark. A baby's chance of survival can vary dramatically based on the geography, socioeconomic status, ethnicity, or simply the availability of trained professionals and equipment. And even within the same city, two families living only miles apart may face entirely different realities. This inequity is not inevitable. It is the result of systems that need strengthening, policies that need reimagining, and resources that must be more fairly distributed. The science exists, the solutions exist. It is our collective will that must rise to meet the challenges. Why equitable care matters? When we champion equitable care for every preterm baby, we are advocating for a far more than neonatal survival. We are fighting for a future of healthier children who grow into thriving adults, families empowered rather than broken by trauma, communities strengthened by the contributions of every child who survives and flourishes, health systems made more resilient and compassionate, and not just saving lives. It is creating conditions for human potential to be fully realized, regardless of where a child is born or the circumstances of their families. The pillars of equitable care. To make equitable care a reality, we must focus on 4 essential pillars. Access. Every mother and baby must have access to skilled care before birth, during birth, and after delivery. This means improving referral systems, expanding neonatal intensive care systems capacity, and ensuring trained healthcare workers are available where they are most needed. There are structures that exist in the health service. Our primary healthcare system, the CHIPS, the health centers, the district hospitals, secondary hospitals, and tertiary facilities. So we must work together and asset postings to places where our services are needed most. In terms of quality, access alone is not enough. Care must be evidence-based, respectful, and consistent. Quality improvement initiatives, standardized protocols, and continuous training can bridge gaps between what we know and what we practice. I know a number of trainings have been done and things have improved over the years, and I believe we can still do more as we go forward. Then family engagement. Parents are not visitors. They are partners in care. Supporting mothers with kangaroo mother care, breastfeeding services, and emotional and mental health resources uplifts both the baby and the entire family. And having equity-centered policy and investment is also needed. Equity must be designed into the system. Investment must intentionally target underserved populations. Data must be used to uncover disparities, guide interventions, and measure impact. This is a call for action, and we all must take a critical look and move forward. I invite every one of us, clinicians, policymakers, researchers, advocates, and parents to embrace the responsibility that equity demands. Let us innovate with purpose. Let us collaborate across disciplines and borders, and let us elevate unheard voices, especially those of families whose journeys through preterm birth have been marked by struggle. Let us refuse to accept that where a baby is born determines whether they survive. Every preterm baby, no matter their background, deserves a fighting chance. They deserve warmth, safety, skilled hands, and systems designed to protect them. They deserve equity, not as an aspiration, but as a guarantee. Today, as we commit ourselves to this cause, let us remember the measure of our healthcare systems is reflected not in the experiences of the most privileged, but in the lives of the most vulnerable. And few are more vulnerable than a baby born too soon. By championing equitable care of every preterm baby, we are shaping a future where compassion and science work hand in hand, where potential is nurtured rather than lost, and where every child has opportunity to survive, to thrive, and to shine. Thank you very much.
Thank you very much, Dr. Marisa. So, and as you said, we are happy that the policymakers are here with us. So you are going to carry it around. As we heard from Dr. Nana Rekubobe, you shouldn't always be happy. No, not always. You shouldn't be happy when you see the preterm reading 100%, 100%. What do we do to their eyes? So to give us an in-depth knowledge into it, an insight, we'd like to call on Dr. Akesia Jaman Ahmed, a seasoned ophthalmologist at Komfanoche, to talk to us about retinopathy of prematurity. How do you recognize it? How do you prevent it?
Thank you very much. My namesake, Anna Ikia Ajaban. As we wait to get it set up, I just want to say that I'm so happy. Last year, I was invited to give a talk on retinopathy of prematurity at this conference. I think there was a session on prematurity. And for me, it told me how far neonatal care in Ghana has improved. When I was in medical school, I remember Dr. Jikwa Planjru will talk about ROP and say, oh, it's not very common, because we don't see it. Because at that time, the babies were not surviving. And then fast forward, maybe 5 years ago, we would have Dr. Nana Rekubrobe who come to the eye unit. And then she's saying, we want ophthalmology to come and screen because we are seeing a lot of ROP. I'm like, how can we come and screen? How many ophthalmologists are in Ghana? In addition to our busy clinics, come to screen all these babies. It was virtually impossible. But I'm happy to say that today it is possible. And a lot of intervention have been made, hence my being here. So, who is this guy? Who knows who he is? We all know he's Steve Wonder, but I'm sure not many of us know that he's blind from ROP. ROP stands for retinopathy of prematurity. What is it? It is essentially a condition that develops in preterms, right? Because the vessels in their eyes do not develop properly. Okay, and it happens because of preterm, low birth weight, as well as other risk factors. Dr. Nana mentioned exposing them to 100% oxygen. Usually we aim for 90 to 95, and I'll delve a little bit more into it. The problem in sub-Saharan Africa, ROP is becoming extremely worse, okay, because of increased survival rates. Dr. Kantum has talked about multiple deliveries and plantations. In Ghana, we have about 2.5 ophthalmologists per 1 million. 4 million and there are 4 million babies born preterm. Half of the babies born are in low middle income countries. In the 1940s, there was a high incidence of ROP in the Western world. And it was because it was discovered that they were not monitoring the amount of oxygen that was being given to the babies. They put in measures, and then ROP in the 1940s disappeared. In the 1970s, there was a second wave of ROP because preterms were surviving because of better neonatal intensive care. And then we found a third wave in the 1990s and was found to be mostly in sub-Saharan Africa, South America, Asia, and co. And I think that gradually and steadily, we are making waves to try and prevent it. We need to prevent. Just this afternoon, one of our colleagues walked up to me. I was chatting and says, oh, ROP is probably, when it comes to neonatal intensive care, is probably one of the ROP intervention is one of the biggest interventions so far. And then some time ago, he was almost sued because you're a pediatrician, you are taking care of a baby, and then the baby survives, and then the next thing you know, the baby is blind. I mean, how do you explain it? In the US now, when a baby gets blind, the institution is sued 40 million USD. So it is impossible for a baby to get blind from ROP. Here, I see some babies, 3 years old, they come to the clinic and they are blind. And I tell the parents that if your baby had been born today, maybe they wouldn't have been blind. Or they have been born at Cath or some of these places where screening happens. They wouldn't have been blind. Dr. Kantum is here. I'm happy that we screen a lot of babies from Ruma as well. So it means that there's a lot happening. How do we recognize it? Apart from the birth weight, we know that babies that are less than 1,500 grams and less than 30 weeks gestation are at risk. But there are some other ones. Neonatal respiratory distress syndrome. There are a lot of asphyxia, presumed sepsis, IUGR, a whole lot of them. Okay, and this is how majority of the babies receive oxygen, either room air, bottle CPAP, VIU CPAP, the diamedica, and nasal cannula, amongst a few. So this is the screening criteria. Here, so I work with an organization called Africa Eye, and we are working with Cath, and we've instituted a screening program at Cath for the past over 1 year. And currently we have extended this ROP screening program to Ridge Hospital, and Dr. Ajumain is here, and then the Tamale Teaching Hospital. What we found out that in Kumasi, we have bigger babies that can be at risk. So we increase our screening criteria to less than 2,000 grams and less than 32 weeks, so as to have a bigger pool of patients to screen from. I'll not go too much into this, but this is how we recognize it. So in the eye, when we look in the eye, we have what you call the zone. That's the retina, the area in which ROP can occur, the stage, and then what you call plus. Plus basically means that when you look in the eyes, the retinal vessels shouldn't be tortuous. They should be straight. But in ROP, you find out that they are very tortuous. Okay, so we look for that, and that is an intervention of early treatment. And then when it comes to stage, we have what you call the demarcation line, ridge. This is important to very important to ophthalmologists. I thought I have to mention it so that I'll be saying something you don't know. And ridge with extra retinal fibrovascular tissue. You have retinal detachment and all that. It is very important we catch them at this stage and maybe this stage. Okay, and the only way to do it is by doing screening. In Ghana, we have about 34 million people, 16 regions. In the whole country, about 230 NICUs. And Ashanti region has about 40 NICUs, 550 beds plus total. Okay, Konfanochi has about 155, if I'm correct, around that, right? And for the ophthalmologists, we can't manage ROP alone, as we've seen, because it is a systemic oxygen, problem that affects the eye. So we have to work closely with a pediatrician. So we look at prevention. How do we prevent? You look at oxygen management, okay? And there are studies to show that when there's good oxygen management, ROP can reduce from the reduction in stage 3 and 4 from 12.3 to 2.5%. And with the target is to keep the oxygen saturation around 90 to 95%. So this is what we did. So earlier this year in June, we got some donation and we donated $65,000 worth of equipment to the CATH MBU. Okay, and that's Dr. Nana receiving it. And not just CATH, but we also donated this CPAP and value blenders as well as monitors to all the districts, all the NICUs in the Ashanti region. Some of them have 5 beds. We're able to donate 4 or 3, but at least everybody got one. And almost everybody, some people didn't get some. I'll put myself in trouble, but you heard. Or if you didn't get some, to come. Okay, let me move on. And so the idea is to prevent. So we are preventing ROP by making sure that the babies are getting the right oxygen, right amount of oxygen they need. And how do we monitor? For ophthalmologists, we monitor by screening and looking at the retina. You see, ROP happens because from 14 weeks to about 22 weeks, you have what you call vasculogenesis. That's when the retinal vessels start developing in the eye, normally. And then they continue developing until about 38 to 40 weeks. In utero, the baby is in a state of hypoxia. When they come out into the world, and hopefully maybe they will find themselves in a good part of the world or a good part of Ghana, right? When they come into the world, they are not in that state of hypoxia. They are getting 100% oxygen. So that normal retinal growth or vascular growth stops. Okay, and now you have what you call angiogenesis. Okay, so there's abnormal new vessel formation, and that is what leads to this. So immediately the baby is born, you want to make sure they are getting 90 to 95% oxygen, and it will prevent ROP. So in as much as you are doing that, doing the CPAPs and all that, you want to also constantly monitor. Not all babies will develop ROP. Some, even with the 90, 95, can still develop. So you want to catch those. And we can either examine them by using, our devices. The doctor physically looks into the baby's eye, or we use a camera. And this is what we've currently deployed. We take pictures of the eye, upload the pictures onto a website, and then someone sitting behind the computer is able to grade in real time. So in a day, you can look at 200, 300 images. Okay, if you think this is suspicious, you can easily say, take another picture tomorrow. It's more difficult for a physical person to do because of the effort and everything that is involved. This is what a normal retina looks like. Okay, when you have ROP, you start getting these demarcation lines. This is the tortuous vessels. If you look at this, you see how this is tortuous versus this. Okay, and then it gets much worse. Why should we screen? If the disease is caught early, all it takes is a simple injection. A simple injection that costs 1,200 cedis for both eyes, and the baby is saved. The baby doesn't go blind. Okay, I'll talk about some statistics in the last 6 months. So it is important that everyone gets screened. Currently, what we've done is, at least in Ashanti region and in some of the places that we have set up, we are trying to have referral patterns so that Ruma gets the preterms, they will refer to NICU, Cath NICU, and then once you come, we screen. We are screening currently about 80 to 100 babies every week. 80 to 100, we are doing 80 to 100 examinations every week. Okay, 80 to 100, because some are repeats. The first injection was done in 2024. Okay, now the good thing about this is that when the babies are discharged, you don't keep the babies until they are 10, until they are 40 weeks. But with this camera, there's a lot of them that come back for screening on outpatients. And so we find out that on an outpatient, some people that maybe inpatients didn't have ROP will come and we catch it at that time. Okay. How do we treat? So I talked about it. So of all the babies that you screen, 5 to 10% will need treatment. It costs about 120 USD. That's an injection for both eyes. Okay, and if you think about the fact that just getting an injection, 1,300 or 1,400 at Cath will give the baby the rest of their sight life. Otherwise, this baby will be blind even before they start life. Okay. And so we try to institute this at places where there's treatment. So we know that in Rich Hospital and in Kolebu, there are ophthalmologists there that can treat. We know in Konfanoche, the people can treat. We know in TTH, there's an ophthalmologist that can treat. It's more difficult to institute it somewhere. You have a baby and then they need treatment and it's not available. Then there's no point in screening at all. So currently, these are some stats. So these are the babies in the last 6 months, not screenings. So if you look at Kolebu, at least every month, they are screening 48 new babies. Greater Accra Regional Hospital, about 45, Konfanoche, 80, Tamaliti, And then what do we need from you? We need counseling. So when you see these preterms, let the parents know that they need to get their baby size screened. And then you let them know where they should refer the babies to. At least if you're in Accra, you know that they can go to the Accra Regional Hospital, in Kumasi, Kath, and there's TTH. And then follow up. You educate the mothers on the importance of follow up. And then you take the mothers' phone numbers and let them know. I'll say that so far, loss to follow up is very few because of the kind of counseling that the mothers are given. When we take the photographs, we let them see and we show them the pictures of the abnormal ones so that they know that they are, and mothers will do anything for their babies, right? But I think for adults, we don't prioritize our health as much as our children. So these are a few photos of babies we have treated. A lot of them currently, we've treated about close to 40 since we started. And I'm happy to say that we have a lot of partners. So in the, at least neonatology at CATH, we have Dr. Nana, Dr. Ajiman. We have a few people at the eye department, and we have so many partners that have supported. Thank you very much.
Thank you so much, Dr. Akwesi Ajiman Ahmed. Please, do you have any questions for Ish? I'm Prema. Okay.
Thank you, Dr. Ahmed. In the district, I know for ROP, the screening, you have timelines and all. But those of us in the district, most of the time, by the time the baby is stable enough to come over to CATH, it'll be like 2 months, 3 months. And if there'll be any damage, it would have been caused. In fact, I have some babies who have gone blind after the screening because of the late presentation. What plans do you have to address this one? Thank you.
Thank you very much. And so you are perfectly right. So when the babies, sometimes you have 26-week-old babies. When they come, we actually don't start screening right then. We start screening from about 2 weeks when they're a little bit more stable, sometimes 4 weeks when they're a little bit more stable, because the data we have shows that ROP, like I said in the slide, will usually occur from 30 to 34 weeks, right? And we found out that is when they are usually discharged. So we usually will catch them on OPD. So yes, some babies might slip through, but I think that all the same, you should still refer them. We do laser when it's a bit late to do the injection. So some of them may still be able to be helped.
Yeah, thank you, Dr. Ahmed. In fact, you have educated me. I never thought that there was a problem at all. So thank you for your education. But there's something that perplexes me. You are doing this work at Confanoche. What is the role of management Confanoche? When you mentioned the partners, I didn't see CEO, I didn't see anybody. Such important work. Have you presented your findings to management of Confanoche so that they can take up this program and roll it out at a bigger level? That's the first question. The second question is that, do we have national data concerning ROP? Are you saying that Ministry of Health, they're not aware that this is a problem for Ghana? And what is the nation doing about it? Because you shouldn't be struggling with all this evidence to make Ghana the third country to have this program. You shouldn't be struggling like this because you've done the work already. So have you got any plans, if they don't know, to educate Ghana Health Service and MOH that this is a problem that is prevalent in Ghana? You've done some work about it, but you need to scale it up. Thank you.
Thank you very much, Dr. Kantum. Yes, so Confanoche, maybe I should have put CATH there. CATH, since we started, at least the previous management was very supportive. What we did was, our goal is to ensure that it gets on the essential treatments guidelines list, as in the Avastin. so that eventually will come on the national health insurance. What Cath has now done, at least for Cath NICU, and I think Dr. Ajaman is also working on it, if he hasn't already done, is someone has to pay for it. The group doing it is doing it for free, but to be able to get some reimbursement to the hospital, they found a way, or they were supposed to have found a way, so that they bill for the inpatients as part, because when you say the mother should pay 20 cedis for dilating drops or 30 cedis for ROP, sometimes it's a bit challenging. But if you can bill it as part of the admissions, those that are admitted, we found out that, and I think it's happening. It's happening, yes. And so for the hospital management, we are hoping that they could do the treatment for free. But what they said was that $120, 1,300 or 400, they are going to remove some charges so that eventually become cheaper. And I think it is, for us, it is they've shown good faith. So shall we give Confanoche rather? And we have a lot of data, As a matter of fact, sometimes too, it's credible because we have started in the last 2 years. We have a lot of data, a lot of publications, and we are working closely with the ICARE secretariats under the Ghana Health Service and the Ministry of Health, hoping that eventually we'll get there. So thank you very much.
Thank you so much. But I think where we've got into it will be advocacy. I think the Pediatric Society of Ghana and all involved, now that we have data, it's up to us to carry on the advocacy to the next level. I think probably next year, prematurity celebration, the topic should be ROP. And then off we go. What we've seen at RAGE, it's interesting that the smaller hospitals in Greater Accra who are caring for smaller babies, the burden of ROP is from there because they only put oxygen on these babies, and it's worrying. So if you are here and you are in Ashanti region, please take this opportunity to be sending your babies to Confanoche. Very genuine question about the outborn babies, when to send them for ROP. If you have a tiny baby, you think this baby has been on oxygen, has been sick, the earliest time the baby is stable, you can arrange to come to Cath for ROP and go back, but probably not wait to discharge. That would be my advice.
Thank you very much. Another round of applause for Dr. Ahmed. We have been really, really enlightened, and we are grateful to have you here. Our next presenter is in the person of Dr. Eno, the IC of MBU, and she's going to talk to us about sepsis in preterms. A round of applause. Thank you.
Thank you, everyone. For a moment, I was like, I don't recall this set of slides. All right, okay, good. So I'm going to do sepsis in the preterm baby. And Dr. Ahmed, happy theater day. He's going to theater. All right, okay, good. All right, so these are my objectives, but these objectives was given to me by PSG, you know. So I followed what they gave me. They gave me very elaborate objectives. So a bit of definition, epidemiology, risk factors, and then early clinical laboratory indicators, prevention strategies, which you have heard in other people's presentations, and then intervention protocols for management, prognosis, and then areas of improvement. Some of them, I just skipped over it and everything, but I put it there so that PSG will know that I'm a very obedient participant, isn't it? All right, so what's the definition? Well, I mean, there are a lot of definitions, but I took this one. And then it says that it's a systemic neonatal sepsis. It's a systemic inflammatory response syndrome in the presence of or as a result of a suspected or proven infection in a neonate, and in this particular situation, in a preterm child, okay? Because we know that it's only like 30% that you get a blood culture positive. The other 70% is what you think the child may have, clinical condition that you think the child may have an infection, isn't it? All right, so epidemiology. So recent systemic review meta-analysis say that globally, we have about 3,930 unital sepsis cases per 100,000 live births, okay? And of course, I mean, where is the burden? The burden is, we there here. We are inside, you understand, with Southeast Asia. Just we are the same. So nowadays I've been praying, God, if there's reincarnation, I'm a pastor, mom. In case that you are doing the world again, I beg you, Norway, Lord, Finland, Africa, you see, I'm not coming again. This is a very problematic area. And then 24% of neonatal death is caused by 25% of neonatal death is caused by neonatal sepsis. Okay, so this is from the Global Sepsis Alliance. Okay, and the rate of neonatal sepsis, if you are born in low, middle, and income country, is 40 times higher than if you are born in Switzerland. And Sub-Saharan Africa is at 35 neonatal deaths per 1,000 live births. Be mad. I'll come again. Okay. So nationally in Ghana, the 3 topmost causes of neonatal death, of course, prematurity is complication, and then intrapartum, birth asphyxia, and its complication is there. And then number 3 will be neonatal infections. Okay, so that's the Ghana statistics. And then Okran et al. So that's Dr. Okran et al. From Confanoche. She found out that 18.8% of all admissions are cath is due to neonatal sepsis. And then Kreman et al. In Cape Coast Tertiary Hospital showed that their neonatal sepsis prevalence, they have about 15%. Okay, and then Mumin et al. In TTH, in their 5-year retrospective study of neonatal deaths, found that neonatal infections, they were like 14.65. Okay, so like basically the same TTH and then Cape Coast Tertiary Hospital have something similar. And then Brown and Haffel, they had a higher prevalence of about 23.75% for neonatal sepsis by Wage et al. I was trying to get something for Greater Accra, and that's a then I stopped. You understand? So when I get it next year, when I come, you have some. Dr. Ajimai said they don't have sepsis. They don't even know that they have sepsis. All right, so why are preterm babies at risk having it? So let's do a bit of what is it? Is it molecular medicine? You thought you would meet it, you've met it here. So your first barrier to infection, which you have been taught, is your skin, isn't it? So your skin and the mucosa, they prevent you from getting infection. So the third trimester, during the third trimester, I've seen my obstetricians here, you know that fetal sebaceous gland, they produce this lipid-rich material that we call Venice caseosa. That cheesy vanish. You see it when you have your baby, you see it there, isn't it? And then if you don't take care, you don't meet a midwife who doesn't come for conferences, they'll be wiping it off. But it is one of the protective things that protect the child. You shouldn't take it off. Do you understand? So that's one of the things, okay? It contains antimicrobial proteins and peptides. Don't wipe it off. When we say dry the baby thoroughly, we don't mean that you should wipe the Venice caseosa off. Okay, good. So one to shake, you heard this, okay? And it acts locally and systemically to defend against infection, okay? And then there are layers in the skin. The stratum corneum is thinner, immature, and then most likely to have breaches. So you see that if you have a term baby, a post-term baby, and a preterm baby, especially a very immature one, when you put the brown plaster, have you seen the brown plaster? When you put it on the child and you take it off, what do you see? See this raw area, like, hey, the child is going to get an infection. And then when you take the one that is coming from somewhere else. Yes, so I mean, I think the brand that we have in cath would be what? Fusimol, isn't it? The white one. You see that one is a bit softer on their skin and it doesn't like take the first, take some of the skin off. Okay, so because of how it is, so preterm babies, they're easily bruised. Sometimes even when you hold them, like when the obstetricians, they have a difficult delivery and then they pull the baby out. When they come, you see that there's bruises on the babies. Have you seen it before? Yes. So you see, so you see that it's very difficult. So all of this predispose the child to get an infection, okay? And then the mucosal barrier, you know that there's some, as you are sitting here, anything that is going into your airway, the body has have a kind of like a ciliated action so that you bring it out. So sometimes you're there, you do that. But the preterm cannot do that. Because I mean, if you have a preterm who think, who say, hey, say, hey, I could just say one, what's up, baby? Okay. And then, of course, like the GIT, you know that Dr. Nana Rekubabi was telling you that by the third trimester, that's when the immunoglobulins are going to the child. And so if you are born before the third trimester, things like immunoglobulin A, that produces and protects your GIT mucosa, you're not going to get that. So you're going to have that, okay? Decreased complement activity. That can be as low as 10% of what the adults have, okay? All right, so we have come here again. So they generally have neutrophil, limited neutrophil store. So if a preterm has an infection, you are not going to get neutrophilia, okay? You're not going to get it, so you're going to see the neutrophil count is going to go up. If you have a 10-year-old who has an infection, and the neutrophil is bacteria, the neutrophil count will go up. But in the newborn, they have limited stores. So you are absolutely going to see, most likely going to see neutropenia. Do you understand? Where are my neonatal fellows? I've seen all of them here. I'm very happy. So neutropenia is what you're going to see. Okay, all right. And even the preterm neutrophils is also a bit deficient in function in chemotaxis, phagocytosis, and all the things that go with it. It's the same with monocytes, natural killer cells that they have. Okay, good. And then also white blood cell. I see people who say that, oh, we have the white blood cell count, the BBC count of like, what? The normal adult is like 4 to 10 times to the power 9 per milliliter, isn't it? Then they'll see that, oh, the preterm or the newborn one is like, is 15, it's 20. And then before I will answer, then one of my neonatal fellows will just go like, 20, go and sit down. It's up to 27. Then I'll be like, Charlie, I've taught you, you know. So they can go as early, as high as 9,000 to 30,000. It does not mean that 30,000, it does not mean that they have an infection, okay? So you know that certain values go with certain population. So just know that. And when we come to adaptive immunity, then you're talking about your T lymphocytes, okay? They are also like limited stores, limited response, limited function. And then, of course, the maternal one, we've talked about it. And remember that, with the exception of IgG, which can cross the placenta, the rest, IgA, MD, and sometimes they don't really cross the placenta. They are kind of like big molecules, so they don't really do it, okay? So they are low, and then if you're born preterm, most likely you'd even get a lot of the IgG, okay? All right. So what are the risk factors? The fact that you are born preterm itself, we talked about your innate, your cellular, and all of that. Then the lower the gestation, if you are 26 weeker, you have a less immunity than a 35 weeker baby. Do you understand? You're most likely, if you are 20, to get it. And then low birth weight. Obviously, if you are less than 2.5 kilos, if you are less than 1 kilo, you are at a higher risk. And then if you come and then we put all these central lines, and those ones are done by the PICU people, endotracheal tubes, and then low ABGAS scores, as Nana has come to talk about, which is attendant resuscitation, trying to save the baby. And then meconium staining. As we tell people, meconium is usually sterile. It causes a chemical pneumonitis. And then because it is causing a chemical pneumonitis, then you are likely to have what? A bacterial what? super infection. But what it comes when a child comes with meconium aspiration syndrome, sometimes you can just observe. You can see the child is okay. But a preterm child with meconium and everything, Charlie, the infection risk is high. Do you understand? And then poor hand hygiene, delayed enteral fees. Now I've talked about all of that. And then a child who has had a previous antibiotic use. Okay, good. And then maternal risk factors. I'm sure Dr. Jante, I've been bossing with him. The doctor I've been bossing with since I've been here. He will come and talk about all of that. Okay. But I mean, chorioamnionitis, we are all afraid. ONG is also afraid. Okay. Everybody is afraid of chorioamnionitis. Maternal fever during labor and then the delivery itself, or immediately after delivery, we are afraid of that. Maternal group B, prolonged rupture of membranes, more than when I was a resident, it used to be 24 hours, 18 hours. We want to catch it early. Is that what's happening? ONG, is that what's happening? Okay, good. And then poor prenatal care and nutrition. Obviously, we don't know what's even going. Okay, so good. So I put this one here because this one, I want to talk about it because like every time, I mean, I work in the same unit as Dr. And then she'll say the spontaneous preterm birth, like risk factor for thinking that the child may have neonatal infection. Then I'll be like, hey, and then antibiotics. But so I was on the other school of thought. But then when I read the literature, then when they tell you that 50%, 40 to 50% of preterm contractions is from unrecognized maternal infection. So it's your hand here saying. So now I've changed my mind. If I don't see preeclampsia, I don't see eclampsia or multiple pregnancy, because you say, well, ANC, no, okay, saying, how many times you attend ANC? They say minimum is 8. It used to be 4, now it's 8. If I see that it's 3, say, do black sepsis, no, they number. Do you understand? Because now literature is telling us that, yes, there's a high chance that if there's a mother, we all don't know, ONG has no reason why this mother is having preterm contractions and they can't get sepsis is one of the causes that can be. And if it's a preterm child, Charlie, you see that thing? That's why I put it there. So what organisms are we looking at? Early onset group B, group B strep has replaced Staph aureus as the most prevalent. E. coli, Klebsiella. We are very, I don't know where you are coming from, but those of you do blood cultures, Klebsiella E. coli is one of the things that we see. And then Listeria monocytogenes is in the books. Nobody has picked it before, but it's in the books. So I put it there. Okay. So group B, I wanted to put there because, you know, when I was working in England, look at them training you school abroad. So, sorry, I know my colleagues are here who don't speak Chi. I was saying, when I trained in England, so, I mean, that place, they have, I was talking to Dr. Jansen, they do what they call like maternal screening. And then group B was one of the organisms that were coming up, okay? So, but when I came back to Umofia, hey, we don't see it all. We don't see it. So me too, I was teaching. Then that someday I said, oh, I read literature. I didn't know, go and read, okay? So then I realized that Renu Lai et al., okay, they together with, Renu Lai is with a neonatal group in Kolebu, and then together with her colleagues in OBGY, they found out that in Kolebu, about 0.5% of women who were screened in third trimester had group B strep. And the reason why we were not picking it was because the regular lab has not been equipped enough for it to isolate group B strep. I said, okay. And then I said, okay, then let's come home. Then I realized that Turpin, Danso et al., has also done some in Confanoche, and they realized they had a rate of like 23.1%. It's just like our lab, no, it's a buga 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 buga. When you send it, it's not there. The thing is there. So Jante was like he's finding a way. So Jante is young obstetrician, so he's finding a way so that the lab would do it, and then they could come up with it. But then I also thought about it, even with the babies, when we send the blood cultures to the lab, I hardly see Group B. Doc, do you see it? You are coming from a different place. You see Group B in the blood cultures for the neonates. But whoa, Doc. Doc, what do you think?
It's been a heated debate about this, but other African countries, in South Africa, they were also not seeing it. When they revolutionized their cultures, they started seeing it. But now people are also saying it may be genetics, maybe it's here, but it's not as high as Europe.
It's not genetics. Hey, here, Doc, hey, here. Hey, here, hey, here. Okay, so you see that making the thing interactive. That means you have to give me more time because we are here.
I think because you mentioned South Africa, I've practiced in South Africa for over 2.5 years. In all cases here, when I went for my MFM trade, in all cases of prom, they administer ampicillin for Group B strep prophylaxis. So that would be the reason why they would not find Group B strep in the culture, blood cultures. Because the mothers actively, yes, all the mothers who have. All right. No more interactive.
All right, so I know OBGY will talk about it and everything. And then late onset neonatal sepsis, more gram-positive. And then I know that we always say coagulase negative stuff is a contaminant because it's on your hand, but it can also be pathogenic, you understand? It's not always a contaminant, okay? And then, of course, Staph aureus, they're more like late onset, but it does not prevent the other ones to also be here. So they are saying that you don't see a lot of gram negatives in late onset sepsis, which is 72 hours, beyond 72 hours of a baby's life. When you get an infection, it's late onset, okay? And then within the first 72 hours, it's early onset. There's another group of, so there's always some group of people who are different. One first week, early onset, second week, late onset, but I'm in the regular group, 3 days, and then after 3 days. Okay. So this is what you are likely to see. So you can see those of us who are able to do a bit of mechanical ventilation. Pseudomonas is one of the things that you would see if you do like a swab, endotracheal swab and things. Pseudomonas is one of the things that we do. And then do not forget about Candida, okay? It causes up to 18% of late onset neonatal sepsis, okay? Especially if you have like a preterm and then a preterm who has had prolonged antibiotic. And then think of Listeria monocytogenes, okay? I mean, I have never seen it anywhere. Has anybody seen it? In South Africa, were you seeing it? Because in England, I didn't see it, but it's in the books. You understand? And then herpes, we are thinking of viruses like herpes simplex. I mean, I also haven't seen really that. Clinical presentation. I mean, everything you can think of, clinical presentation, every system, okay? All systems are affected. Poor feeding, lethargy, temperature instability. None has talked about hypothermia, be more common, everything. Remember, all the systems, clinical manifestation can present in neonatal sepsis. Remember, sepsis in the preterm can develop gradually, and then it can also be very fulminant, okay? So have a very high sense of it, okay? Have a very, I put this one there. I mean, listen to the mother and then the midwife. You know, sometimes a midwife, I mean, when we used to be on the floor receiving babies and things, you know, there's a midwife who will come. Like usually to be an older midwife, not these Gen Z midwife. Gen Z midwife, Akre is having a seizure. I said, doctor, you're strong, baby. I said, this Akre is a strong baby. It's having a seizure. I'm going to knock your head. Okay. So these older midwives who are more experienced, they come and then they say, doctor, I don't know, this baby, like, I don't know, I can't really like pinpoint, but There's something. Say not something, bang. What is the something, my midwife? So I can't pinpoint something. I've learned through the hard way that I should take that midwife seriously. There's something she's seen in the child, she can't say it. But if you let this child go, this child will come back as a neonatal death or come back in seriously ill. So I just take it. Or the mother says that, hey, baby, don't get kind of. So then you say you're overwhelmed. You're like in comfort, you're overwhelmed. What you say, mommy, baby, in kind of ain't it? Would you you know, like because you're so overwhelmed. But that may be your first sign of a very for a child who's having sepsis, that the baby is not so active. Because the mother has been with the child, she knows how the child is. And all of a sudden today she took the child. The child is, that's why it's slow, bias economy na kanibisa. Hey, childhood doesn't work. How does this economy affect you? They say she has brought the child. You have to listen to these are subtle cues, okay? I just say that these are subtle cues. And then when people who are with the child say that I think there's something wrong with the child. Listen, this is a baby, no, a changey color. A baby, a changey color. Then you say that, oh, check the SPO2. They check the SPO2. It's like 91, it's normal. Say, mommy, midwife, come for training, you won't come. You will come say this baby has changed color. It's 92% in room A. Take the baby and go. You must be careful because before you realize something has happened to the baby, I would prefer that maybe that baby is observed for a couple of times and then with the mother, and then maybe even do some initial labs to make sure that baby is what? Is okay before you send home, okay? Because the preterms are dying. And you don't want this one to become a mortality, especially when they have come to show you what? The baby. Do you understand? All right. Okay, so I've talked about this. I'm moving on. Okay, so thrombocytopenia is often seen in sepsis in the newborn. And of course, it's not going to be different in the preterm child. Okay, so in this inflammatory markers, so residents here, so you know that CRP is one of the new-ish thing we do, isn't it? I would like to say it's CRP, we've done the CRP, it's less than 1, let the baby go. Remember that the CRP usually will rise within 6 to 8 hours of an infection. So a peak around 24 hours. So maybe because, you know, like when we have electrolytes in the newborn, we will say that the first 24 hours electrolyte is a reflection of more of the mother's profile than the baby. Do you understand? Maybe the CRP levels that we are getting, and maybe it's not really like it hasn't risen yet. Do you understand? Maybe if we give it some time, because immediately the child comes and we are taking the labs, we take the CRP. That's the common practice. Is it that we are taking it earlier than the time that it would have risen or something like that? Do you understand? I'm just postulating. Because sometimes you see a child has everything, then you just do the CRP and then the CRP is normal. And then you're like, it's not infection, BI is thinking. Or maybe sometimes it's just maybe we took it too early. It has not risen. And then talking about CRP, I mean, the literature says that if it is more than, we say that more than 10, we will do something about it. We take blood culture, we start antibiotic. But if it is more than 40%, then like it's more than 40 and above, the reason, literature says that it's specific for bacterial infection. So you have a CRP that's like 50. Just know that you are probably dealing with like a bacterial infection. Maybe if it's 12 and things, 13, you say that to some physiological stress. And even that one, you treat for infection. You not just let it go. And then procalcitonin is very expensive. CRP is how much now? How much is CRP? My neonatal fellows, you people have been doing the CRP like water. How much is it? Moses saying? Is it was 200, but I don't know the way we've been doing it, no. I think it may have gone down. Doc, do you do it a lot in your place? No, I think it used to be, it's 160. Yes, I know it's 200 and below, but but procalcitonin, who has done it before? How much is it? Share 600 to 800 Ghana. You say, yes. So if you're in the teaching hospital, they'll put one say, the ID team, where is the co? They'll say, go and do procalcitonin. I said, I won't even dear. So it's a good marker specificity for bacterial infection, but it's really expensive, okay? And then this one, it's in the book, so I put it here, interleukin 6 and serum amyloid. I have never seen anybody ask for it, but it will come in your exams for those who are going to do part 2. If they ask me, me the beba, what you say? Aha, good. But I've not seen it before. And of course, our usual blood cultures, and then PCR for DNA, viral DNA, and even sometimes bacterial DNA, okay? And then urine culture, CSF as indicated, okay? And then things to note. Lab results should always be interpreted in the context of the baby's clinical signs and symptoms. So the blood culture comes, it says that it's coagulase negative stuff. We are giving this child cefuroxime or ampicillin gentamicin, but the coagulase negative stuff is sensitive to amikacin and meropenem, vancomycin, and diabene. Okay. Oh, man. I have more time. Ah, nice. All of that. Okay. But the child is well on your ampicillin and gentamicin. What would you do? Who would like to answer the question? Blood culture says it's coagulase negative and sensitive to amikacin, ceftriaxone, cefotaxime, and then give me another drug. Meropenem. But you have given your child in your facility amp gentamicin, and the child is doing well. What would you do? Who would like to answer the question? You do what? How many say you continue? Raise your hand. How many say you change? You change. You are I was going to wait and see what Dr. Ajimai will say. If Dr. Ajimai is raising his hand, I say, you're an autologist, so raising his hand, let me also raise. That's what I say. But he said he didn't raise for both of them. Okay. So if the child is doing well, clinically and everything, we always say you treat the child and not necessarily what? The lab. Okay. That's one of the things that we do. And then as we said, CRP is serial tested. So even if you do a CRP and it's like 50, then maybe after about 3 to 4 days, you would like to repeat it and see whether it's coming down. Okay, so you can use it as a form of monitoring. Okay, good. So management, we've talked about the plenty blood workup you can do, which I've told you, and start empirical antibiotics. Look, there's Ghana Health Service antibiotic that is recommended. The first line is usually what? What's the Ghana Health Service first line? Ampengent. Ampengent, use it. We don't use Ampengent in cats before because we did a blood culture of cats, of all the pediatric patients. Then we realized that we were using it 15 years ago. We realized that it was one of the resistant drugs, so we dropped it. And then we did cefuroxime. Now in the newborn unit, we are doing a multi-site global study. So we haven't changed our antibiotic. We are waiting after the sample, then we'll see what will come up, and then we'll do our antibiotic thing. So please, I beg you, use what has been given. Because if you are bringing me a child from the district, and you say the child has fever, the child is lethargic, and the child is this, and then you have started meropenem. Meropenem, I'm not lying, I'm a pastor, I'm not lying. Meropenem. What I say? If you knew the Eno 10 years ago, we met from, I'm going to say, bra, would you mean no? What I say? But now I've seen the Lord, and Jesus is coming soon. So I just say that, oh, my darling, please don't start meropenem. Do you understand? My darling, my baby girl, oh, don't start. What I say? I say, oh, thank you, Holy Spirit. Thank you. See, you have started 2 weeks ago. Meropenem. Now meropenem cry nye juma. O see they bring to confanochi. Okay, so start slow and then we build up. Okay, we start little and then we build up. Okay, all right. And then we are a bit careful in the first 2 weeks of life of ceftriaxone. So even though it's a 3rd generation cephalosporin, ceftriaxone, it displaces the bilirubin from its albumin binding site. So it kind of potentiates neonatal jaundice. Okay, so we're talking about a preterm child, so, and even a neonate, we are kind of careful of this. Okay, so instead of if you want to give this, you can give what? Cefotaxime. Okay, It's also, they are in the same group, so you can give that. And then you maintain oxygenation, perfusion, hydration, feeding, and as talked about, do other labs when it's needed. And then family-centered care. As Nana has said, I'm not going to go over it. Involve the family in the care, okay? And then tell them what's going on. And then even sometimes when they are going, we can give some of the talk on how to recognize some of the danger signs in a newborn, okay? And then this one is from England people, but I just put it here so that you know that they recommend giving prophylaxis of oral nystatin to prevent fungal infection in babies who have been treated for late onset infection, especially if they weigh less than 1,500 grams or less than 30 weeks. But it's for them. In Ghana, I mean, we don't do it in cath. We don't do it in cath. Sometimes if we suspect, if we're given a child a neonate antibiotics, we've gone like 3 antibiotics, the child is not getting well, the blood culture is not working, then maybe we sit down with the ID team and like, should we consider fungal infection, since we have said that 18% of the neonatal sepsis can be fungal? Then we will give it, but we don't even give oral nystatin. I don't know if others give it. We will give what? Fluconazole, that's what we will give, okay? But I put it there. For those of you who be working in England, I've put it there. So prevention strategies, I'm sure OBGY will tell us because they are here and they are presenting straight after me. So during pregnancy, delivery, prenatal care, and all of that, advocacy to eat well. You know, and one morning, it's too much. It's too much. Eat vegetables. They be fufonia money. It's too much. Ube premature. Eat well. Advocacy. Eat vegetables. Do you understand? You buy your just snack. And so, can I have some salad? Can I have some salad? I never had anybody looking for salad. Only give me more pastries. Those people sitting here, I've said your issues. I told them. I didn't tell that. I told myself in my head, say, they've gone for extra. I'll say it here. All right. Okay. So like micronutrients are also important, not only just the macronutrients. We know that already. I know BGY will do all of that, and they are coming after me. And then a bit of screening, doc. They just ask our field visa. A bit of screening here. Oh, we didn't do it in Ghana. Oh, wow. Okay. All right. Okay, it's not routine practice. Okay. All right. I don't know. We may have to sit down and see how, yeah, 5 minutes. Okay. Okay. And then antibiotics, in England, if you will get intrapartum antibiotics if you are group B positive, if you had a child with group B infection, if you go into preterm labor, as I've talked about, and then prolonged rupture of membranes, and then this one, maternal fever. It's like these ones, we're okay. If we don't do this, then we miss a lot of mothers who have this, and then their babies are at risk of getting infection. Okay, so preterm, same things. Good hand hygiene, IPC, Nana's talked about that. Cord care by staff and parents, kangaroo mother care. Just kangaroo mother care is one of the low-cost, high-impact care, and it's known to reduce neonatal death by 25% overall. Neonatal sepsis, 36%, reduce neonatal sepsis by 36%, and then death from neonatal sepsis, 18%, okay? And then education, we can't stop advocating. As we have come here, I'm sure you have learned 1 or 2 things, isn't it? It's all part of the education that we need as we help to prevent preterm neonatal sepsis, okay? And then long-term outcomes, neurodevelopment, increased risks of cerebral palsy, cognitive delays, hearing and vision impairment. We've talked about vision impairment, and even the risk of you getting bronchopulmonary dysplasia higher, necrotizing enterocolitis. Abroad, it has a prognosis of 25 to 50%. So in our part, your guess is as good as mine. Prolonged hospital stays leading to increased healthcare cost and further application. There was this preterm child who was like 0.0 0.6, 0.7 kilos. And then I think I was a resident. And I became free with the mother. So every day we'll come, we'll bag the child. We could stand on the child there and bag, do intermittent ventilation of the child. 8 hours in, and then the child survived. And then I met the mother after about 10 years. She was like, Dog, one kind was like, oh, man, shut down, kind of. And she was like, oh, I'm the one you stood on this child. The child survived. I said, oh, good. How's far? I said, Doctor, oh, I can't born. Oh. Then I said, oh. I said, okay, we have to implement strategies. So doc strategies, baby. So, extra teacher. Oh, extra teacher. One church and kakra. Small. Kakra. And when I was going to say, yay, intraventricular hemorrhage. Akre nyadi obehuade. Wohuade. Mother, I was at the airport and she paid for my ticket. It's me. I'm so, oh, yes, extra teacher. Teacher, or you're conscious. Wobehu. But when I sat in the car, I said, Jesus, forgive my sin. Akure wo. All right. And these are my references. I'm not out of time. I have things to say, but I'm out of here. Thank you very much and have a good day.
Thank you very much, Dr. Eno. Another round of applause for her. I'm sure the people online really wish they were here. They're really missing out, aren't they? Yes. Who all are committed to returning to this program, God willing, next year? Say aye. Awesome. We'll take a question or two. We are really behind time, but I know we're really learning and having fun. Just a question. I think Dr. Bimpa wanted to comment.
Yeah, so thank you very much, Eno. I mean, your usual Eno, and we enjoyed the presentation. This is definitely for the obstetricians who may be online and leave after your presentation, because I need to make a comment about the 18 hours. Because now in most centers, we know there are risk of neurodevelopmental delays. So even in PROM, the evidence now is to deliver at 37 weeks. But then we cannot have measures in place. So for us, the risk of infection supersedes the other risk. That's why we are still delivering PROMs at 34. So their 18 hours actually refers to PROMs from 37 when it's more than 18 hours. So any PROM before 37, you have to give ampicillin as prophylaxis in intrapartum. So there's no consideration of duration of the PROM. Once you take the decision to deliver at 34 weeks, PROM that occurred before 37, then you definitely will have to give intrapartum antibiotics. I was happy to know, because one of our people went to Michigan recently, that they are, even in spite of the evidence, they are still delivering at 34. So it means that we are not too far afield from the abroad. So that's something I wanted to chip in before.
Thank you very much.
Yeah, thank you. Eno doesn't disappoint when it comes to mesmerize people. We battled with some triplet pregnancy some time ago. I don't know whether you remember. I think we lost the battle. The Eno was on the Uma. Next time, 2Y. Next time they should put 2. But if you look outside there, there's so much despondency outside. But when I come to forum like this, thank God Eno came from UK to practice here. I have hope in this country. We have people, we have good and intelligent people. So those who want to cross over the Atlantic, or please stay in Ghana, because we can make it. I also came from there, and it has not been a bad journey for me. You see, Eno came, it's not a bad journey for her. So please, the young ones, stay back here, okay?
Special message to our nurses. So, our nurses.
Thank you, Eno, and all our panel members, please, I want to ask if all labs has proved that the baby is not infectious, but you are suspecting that baby is infectious, so you treat you treat with antibiotics. Would there be any side effect? Thank you.
I don't know what you suspect. Is it from like maternal obstetric history? Or is there any clinical sign you are seeing in the child? Hey, clinical signs, they say it supersedes the, the lab. Hey, they say the baby is having temperature instability and the baby is breathing very fast and you suspect it's an infection and then you do the lab and the lab says no. No, I mean, believe what you are seeing. Do you understand? Believe the baby, okay? Yeah.
We always treat the patient and not the labs.
So please, mine will be a follow-up question to what my sister just asked. So will it be ideal for us to start a prophylactic antibiotic for every preterm baby, regardless of their gestational age? Thank you.
Okay, so a bit of clarity. You have to know, I mean, you have to assess every preterm baby. I mean, if it is a preeclampsia, it's a triplets, multiple gestation, they come early, or it's like an eclamptic mother or something, then obviously, I mean, sepsis is not really like a main trigger for this preterm delivery. Or antepartum hemorrhage, isn't it? So that's those babies will not really, but if we are just saying that those that, you see a mother, let me give you an example, a mother who has gone for antenatal care just twice, she's a teenager. I have a teenager about, is it a month ago, my people? Is it a month ago, a teenager who just delivered 9 months and she never went for any antenatal care. And I said, didn't you feel any quickening? So, me, I just thought, my tummy was hurting. So I was taking herbal medicine. I mean, if I have that such a history, and then I have that she just delivered preterm, and she comes. I mean, it's high index of infection being the cause of this baby being born preterm. If OBGY rule out all the other causes, but apart from that, maybe it's a case by case scenario. It's individualistic. Okay, thank you very much. Okay.
Quick one. So this is a very difficult area, and that's why these conferences are here. Of late, we've been seeing more babies born to mothers with severe preeclampsia, and blood positivity rate in these babies are high. So it's becoming quite evident that possibly the multifactorial components of preeclampsia, maybe infection, may be there. So what we do when we get these babies, preterm babies, all of them, we take blood culture and start antibiotics. We believe in the concept of start and stop. So if I get the first day we take our blood culture results come day 3, and these babies are very doing well, we stop. Because it's always a thin line between love and hate, right? And if you don't start antibiotics for these babies and deteriorate, it's always very, very difficult. So please remember the preterm babies. It's better to start and stop. We don't want a situation where you start and day 10, continue. This is what we don't want.
Like it's a very thin line. It's very thin line. But I mean, if it's a well baby, like, and they are like 34 weeks, 32 weeks, and they are all well, and the mother had preeclampsia, and they are well, I wouldn't really. But for us, it's easier if you are born in CAT, because like CRP is part of our protocols now. Because of our new neonatal fellows, they are really championing that, okay? So I have something to guide me. But if you're in your district and it's difficult, I would say, okay, start and stop. Because I also believe in starting, and then if you think the child is not septic, stop it. But then also look, as we are talking about starting and stopping, also think of antibiotic stewardship. It's a huge thing now, isn't it? Like the person who gave meropenem, yes, you've given antibiotic, but what is the stewardship with that? Okay, even in tertiary hospital, we wouldn't go that. Yeah, do you get it? So like, let's try and work within the system. And then you can call. Like, I don't sure, I'm not, I know you're a neonatal nurse. Me train you. So I say, So you could call. I mean, you have good relationships and everything. So let's maybe discuss with, I know Christy is there today. I saw all of you going to hug her and everything. Have that relationship. What do you think? What's the second I? What do you think? And then maybe you come to a better conclusion. Okay. All right. Thank you.
Thank you very much. We will pause here and continue. Otherwise, we'll close at 7 p.m. today. Our next topic promises to be intriguing and interesting as well. It's titled Shaping Tomorrow's Lives, Prenatal Interventions for Preterms and the Ethics of Reproduction. A very important one, especially in the age of IVF, right? It will be presented by our very own Dr. Iya Owusu Jante, obstetrician. A round of applause for him.
All right, thank you very much. I don't know why Eno was adding so much to my work. All right, so let me say good afternoon. And I thought I was going to present at 10:30. I've been sitting for quite some time, but I've learned a lot here. I think Dr. Rekubobe clearly emphasized the role of the obstetrician, let me add the midwife as well, in the survival. These days, we don't just talk about survival, we talk about quality of life of our preterm. So I was very happy when I got the invitation to talk on the prenatal interventions for preterms, as well as the last part, I don't think I like it so much, talk about the ethics of reproduction. So I was given these objectives, and for the flow of the presentation, I would like to start with the second objectives, where we identify risk factors contributing to preterm birth, right? The emphasis is on prevention. And if you are not able to prevent, then we look at the evidence-based antenatal interventions that are known to improve outcomes of preterm infants. Then we shall go into the ethics, especially in this era of IVF, and a bit on neonatal viability, or in relation to preterm birth. Then we see if we can recommend policies to ensure equitable access to reproductive health interventions. All right, so on our preventive strategies, what I say is for all disorders that have a complex nature with very huge burdens, especially for our part of the world, the emphasis should be on prevention, right? I think prevention is seen as a cost-effective way in minimizing the burden of some of these conditions, especially because we lack the resources to manage these conditions when they happen. So I always go for prevention. What can we do to prevent it? If we are preventing, we are reducing the incidence of the disorder, and our very limited resources can be able to manage them. What we do as obstetricians in trying to minimize the burden and improve the outcomes of preterm babies, we group them into primary, secondary, and tertiary, right? Normally, primary and secondary is preventive. Then if you are not able to prevent and the preterm labor or preterm delivery starts, then we come out with interventions to improve the outcomes. So I will start. All these are based on knowledge of the risk factors. We have lots of risk factors, and you should know these risk factors to be able to do your risk stratification and plan your intervention strategies accordingly. So in starting with primary prevention, I don't know why my slide is. In starting with primary prevention, these days, we are even targeting the women before pregnancy. So what we have here is preconception. We are targeting the women before they get pregnant. And though we don't have a separate preconception clinic at Comfanochi, we've integrated this into our antenatal clinic. So we are really pushing, advocating for women to present to us when they want to get pregnant, because some of these interventions can be instituted before pregnancy starts. So when they come, what we basically do is to do some risk stratification. We use history examination to identify very peculiar risk factors to preterm birth. And those that are modifiable, there are some risks that can be modified when the woman gets pregnant, and there are some that can be done. So those that are modifiable, we do that before the woman even gets pregnant. Most importantly is hypertension here. Now, I'm sure the MBU will attest to the fact that we are getting most of our iatrogenic preterm deliveries is coming from preeclampsia, right? And a very important risk factor for preeclampsia is chronic hypertension. So at preconception care, if we're able to get these women, then we optimize their care so that by the time they are starting pregnancy, they are in an optimal health to just prevent preeclampsia from happening, which is a very significant source of preterm delivery. So these are just a few tease out on what is done. If you look, this is for all women preventing to us. We know teenage pregnancy, adolescent pregnancy has a very high risk of preterm deliveries associated with them. So as part of our primary prevention, we empower the girl child. We educate them. The higher they go in education, the higher the age of first pregnancy. So these are some of the primary interventions that we do. Family planning becomes very important. We know unplanned pregnancies has a higher risk of preterm deliveries, decreased bed spacing, same, as well as unintended pregnancy. So with family planning, we're able to prevent unintended pregnancies, promote bed spacing, and all this will enhance, as in reduce preterm deliveries. Obesity is a significant source of preterm deliveries. And once somebody gets pregnant, the weight reducing program becomes very difficult to implement. So at preconception, when we pick these women, we're able to optimize their weight even before pregnancy. And Eno spoke of essential micronutrients, zinc, omega-3, folic acid are keen as in a very important micronutrients, which when deficient leads to preterm labor. So when we get these people at the preconception care, these are areas we explore to ensure that once pregnancy happens, rates of preterm deliveries will go down. This is for those at risk for preterm birth. We look for screen. This you think is not prevalent here, and it's simply because we are not looking for them. All right. If you do, we find them, and we've seen them to be associated with preterm labors. Infections becomes very important. If you don't get it, if you don't screen at preconception and manage, then they enter pregnancy with these baseline infections and are predisposed to preterm labor. Smoking is not really an issue with us, but we have a few times you may have these risks, and these smoking cessation strategies become very important, and most importantly, chronic diseases that are known to be associated with preterm labor. So once they get pregnant and they come antenatally, the risk stratification continues. So at booking, we do risk stratification, identify the risk factors, and the planning for the pregnancy, as in the antenatal care, largely depends on the risk factors we get. We shall come to see that if you find a history of preterm labor, there are specific things you should do antenatally to ensure that this doesn't occur again. Now we are doing a lot of screening. Our routine ANC care, we just check for urinary we are advocating for urine culture and sensitivity as well, because asymptomatic bacteria, which can only be picked when you request for urine culture, has been shown to be significantly associated with preterm labor. So once we get them, then we can treat them to minimize the risks. Other infections become important. Beyond these things, Eno spoke of group B. Currently, this is not featuring so much because at CAT, we are not screening for group B, strep, to be able to manage them. And as he said, we held a discussion on it, and we shall engage the microbiologists to see how best we can institute that. I wish my slides can be reduced a bit so that every aspect of the thing will come. I don't know. Maybe zoom out a bit. So secondary prevention largely focuses on two important risk factors. Is that? No, so open it, let me see. Is it okay? Should I go on? Okay. If you can be done. It's okay. Okay, so our secondary prevention largely focuses on these two important risk factors: a history of preterm birth and a short cervical length. So all we're doing at secondary prevention is to be looking for this. And we routinely screen women who has a history of preterm birth. So as soon as we get that history, then we institute these screening tools. At Confanochi, what we do is the cervical length assessment. Elsewhere, they do fetal fibronectin, but we do this. So once you come, we do our risk stratification, we pick a history of either a previous preterm birth or a mid-trimester miscarriage. Right from 16 weeks, every 2 weeks, you'll be having cervical length assessments done. And we say you have a short cervix if before 24 weeks, your cervical length is below 2.5 centimeters. So once we say you have a short cervix, we have evidence-based interventions that are known to minimize preterm deliveries before 34 weeks. And you know, it is the deliveries before 34 weeks that are a major burden, right? So once we have this, right, a lot of work that has gone into these things when you compare vaginal progesterone to cerclage, as in the cervical cerclage, proves both of them to be equally effective, especially when you are dealing with a singleton pregnancy in a woman with a short cervix, having had a previous spontaneous preterm birth, right? But once you consider cerclage to be a surgical procedure with its associated surgical risk, our first line largely becomes the vaginal progesterone, and we reserve cerclages for peculiar cases. This is just a tease out for the evidence for vaginal progesterone as well as the cervical cerclage. I think when we have it, we can have a look at it. So now we've attempted preventing preterm deliveries from happening, right? Yes, we are a bit successful. We've been able to reduce the incidence of preterm labor that we are having. There are few instances, no matter the efforts we put in, because of how complex the situation is, we are not able to prevent all preterm deliveries. And that is when our tertiary interventions set in. So our tertiary interventions is largely interventions that we put in when there is either a threatened preterm labor or an established preterm labor, or anytime we are dealing with any obstetric complication that we know the woman is at risk of preterm delivery, as listed here. So, okay, I think a part of the slide is missing, but I think we can deal with it. So I think, so once we have these obstetric implications that we know the woman can get into preterm labor in any time, these tertiary interventions become very important. This is a teaser from the FIGO PrEP intervention, which is a very effective, simple 5 approaches to improving the outcomes of preterm delivery. I think we, the obstetricians, 1 to 3 is for us, and it's been spoken about by the first presenter. So just to add to it, we recommend antenatal corticosteroids after viability before 34 weeks if you anticipated preterm delivery in 7 days. So a woman will come either in established preterm labor, threatened preterm labor, or comes to us where the conditions are listed that are highly associated with preterm labor. As soon as we see this, we check the gestational age, you see past viability. There are instances women at the threshold of viability, as in peri-viability, steroids may be considered, but this is the recommendation for steroids in reducing the burden of preterm labor. So what we do is that these people, okay. So what we do is that as soon as you come, we do the assessments, then we start our steroids. There are instances we give the steroids, the woman don't get into labor, or we don't deliver the, so we give the steroids, then we are doing maternal fetal monitoring whilst we prepare for preterm labor and neonatal care. So it's possible we give the steroids, and for like 2 weeks, 3 weeks, the woman hasn't gone to labor, or we haven't delivered, right? When it happens like that, anytime you are planning the delivery, and the last time you gave the steroid was 2 weeks ago, and you think in the next 7 days, delivery should happen, we are allowed a rescue dose, a second dose of the steroid, which is just like the first dose that we give. I get asked a lot of times when somebody presents in advanced preterm labor, should we still go ahead and give steroids? And the answer is yes, because we have lots of evidence to support that even just giving the first dose, right, provides benefit for the baby. On magnesium sulfate, which has been spoken about, we at Confanoche give it for all our preterms below 32 weeks. And we prefer the IV route, 4 grams, given slowly. And if you have the luxury of time, you can continue with 1 gram per hour via infusion up to 24 hours or delivery, whichever should happen first. If you don't have a line, you can give the loading dose as an intramuscular injection. And the next slide was supposed to show the evidence for the magnesium sulfate as a neuroprotective agent. On delayed cord clamping, yes, now there is no obstetrician who will fight the pediatrician on delayed cord clamping head during the presentation. We clearly appreciate the benefits. We clearly appreciate the benefits of delayed cord clamping, and we even institute it, right? The only time we may not allow this is when we think our newborn needs immediate resuscitation, or there is something of the mother that requires immediate attention. That is when we will not. But obstetricians are up for delayed cord clamping, and it's usually coming from us. I don't know what has happened to the slides. Okay, so there are a few notable mentions that are not, we don't have consensus on them globally, but depending on where you are coming from, we do some of these things. And these are, I just picked two, tocolytics and antibiotics. So currently at Confanochi, the key indication for giving tocolytic is just to prolong the time to delivery so that the very important interventions we've spoken about can act. So steroids, mark sulfate. And if you are in a facility without NICU services, we will give a tocolytic just to delay the delivery so that you can get to a facility with NICU facilities for optimal care. On antibiotics, we don't routinely give antibiotics for all preterm labors, especially with intact membranes. There's no evidence of improved neonatal outcomes. However, antibiotics may be indicated when you are having clear, either you are suspecting the infection or there is established infection. For prom below 34 weeks, when we are doing conservative management, antibiotic prophylaxis is known to prolong the latency period. So these are clearly the primary, secondary, and tertiary interventions we employ as OBGYNs in improving the outcome. Now, to an area I can claim to be very knowledgeable on, and I'm happy Dr. Kantum is here. I was tasked to look at the ethical issues on assisted reproduction, surrogacy, and neonatal viability with respect to preterm labor. So it's not just the broad topic, it's this in relation to preterm labor. So I looked them up and picked a few issues. We are very much aware, starting with assisted reproduction and preterm birth. Starting with ART, we know ART contributes a lot to multiple gestations, increased placenta abnormalities, as well as preeclampsia, which have shown you to significantly increase preterm birth. What we are seeing is that at the beginning of the ART journey, a counseling, we are picking that most women are not fully counseled on the very high risks of preterm birth. So there are instances we receive them at CAT when they are kept in the NICU for a long time. You could clearly tell the psychological stress on them. So ethically, we are pushing for a full counseling, right, on these risks and the increased risks of preterm birth so that these women are psychologically prepared when these emergencies happen. I was happy when the president of FESOC spoke about embryo transfer. This has become a significant, and my boss and I always talk about this because we receive a lot of triplets, quadruplets in threatened preterm labor, and we end up losing all of them, right? In other areas where the practice is guided by law, policy, right? Hardly will they even transfer more than one. There's a clear criteria for transferring more than one embryo. But for us, I'm glad to hear that latest by next year, we will have our policy so that the aim is to be pushing towards single embryo transfer, and this will significantly help. So this is another ethical area in assisted reproduction with preterm birth. The next thing is when parents come requesting for maximal resuscitation, even when prognosis appear very, very bad. And sometimes we understand them because they invest so much into getting a child, right? And once they've made those investments, when they come, especially these complications like extreme preterm labor happens, they will always want maximal resuscitation irrespective of the prognosis. So ethically, what we should be doing as clinicians is to balance realistic outcomes with parental wishes, what is in the best interest of the neonate, and the resources that are available to us. These patients are also psychologically very vulnerable. There are instances we are counseling a couple, right, or parents on prognosis. You can really hear them like they hear you, but they find it so difficult processing whatever you are talking about simply because of the investments they've made, right? So there are instances they refuse to withdraw care even when we think it's very futile, right? And they'll put a lot of pressure on clinicians to do everything possible to save their babies, irrespective of the quality of life of these babies. So the emphasis is to ensure we avoid false hope, but we shouldn't abandon these emotionally invested individuals as well. My question to maybe the neonatologist is, what disability or burden is acceptable, right? Most times, ethically, most patients, as in parents, feel very obliged to accept whatever burden they have, simply because they so much want a baby. So it's very important ethically we guide them to make very informed and realistic decisions, not to talk on resource allocation simply because I have money. I've invested a lot in IVF. I should have priority to maybe surfactants or CPAP, ventilator when it's available. I think these things have to be prioritized based on who can get the most benefit when we put on any of these interventions. The next is issues in surrogacy and preterm birth. I've come to see contractual agreements is very important. In fact, it's the bedrock for surrogacy, and providers take a keen interest in anticipating all the future conflicts. Then they draft contracts to try and resolve them. No matter what they do, in dying emergencies, there are always decision-making conflicts. You have surrogate autonomy, right, clashing with the combination parents' rights, as well as what we think should be in the best interest of the fetus. But this becomes secondary to this. The key areas is the conflict between surrogate autonomy and combination patients' rights. I try using 2 case scenarios to expand this. So you have a surrogate present with abdominal pain. We do a scan and we pick a reversed end-diastolic flow on the Doppler, say 27 weeks. So anytime you have something like this, reversed end-diastolic flow, vaginal delivery is precluded. That is if you want to optimize survival and quality of life of the baby, right? So the counseling will be 2 ways. Either we give this baby a chance by offering emergency cesarean section, or once we know at 27 weeks, survival is not assured, induce for vaginal delivery, and that means giving up on the baby. So what do you think? The surrogate, as in the combination parents, because they so much want this baby, will push for the CS, whilst some surrogates will decline. So when it happens, what do? Another case scenario, you have prom at 29 weeks. Normally when they come, what we do is, if there are no immediate threats, we want to prolong the pregnancy a bit for baby to mature so that chances of survival improves. And this is against the risks of maternal infections. After such counseling, you may have a surrogate who is scared of the risk of chorioamnionitis and will say, I want to be delivered now, as against combination parents who will want to just keep a bit so that they can have a baby. So I can see the giggling, and these are very practical, ethical considerations that happens in daily practice. So in analyzing this, what I found was that yes, you can prepare all the contracts there is to surrogacy, right? But when emergencies happen, right, the contracts cannot override those clinical emergencies. Autonomy, that is surrogate autonomy, is superior always to the commissioning parents' rights, then best interest may be there, but this is always secondary. And in all instances, documentation becomes very important. Let me try and finish with asking this question on neonatal viability. Do we know when we set our viability at 28 weeks? I can't tell. I don't know what existed at the time we set our viability at 28 weeks. But irrespective of when this was done, we all know how we arrive at these things, right? I'm sure when we're setting this viability, I don't know if you had, let me start from antenatal care. These days, we have maternal fetal medicine specialists. We have many obstetricians. We have sonographers, right, who can do very good prenatal assessments, as in well-being assessments. We have, my time is up. Give me 5 more minutes, I'll finish. Since you cut me waiting, right? So beyond that, we have neonatologists around, we have pediatricians. Even with respect to resources, we have surfactant now, we have CPAP, right? We have ventilators. So all these things were not present by the time we were setting our viability at 28 weeks. So do we think it's time to review our viability and maybe bring it down a bit? Can we do 26 weeks? And this is very important because it has ethical implications. Let's say I have a woman come to me losing liquor at 27 weeks. Technically, 27 weeks is an inevitable abortion, right? So if I counsel this woman on steroids, max sulfate, baby survives, ends up with cerebral palsy, and the woman takes me on, will I be cleared in the law courts? What I'm saying happened in the UK. A woman presented at 23 weeks with losing liquor. She was counseled. They gave steroids, gave max sulfate, delivered in 5 days, was kept in the NICU for a very long time. Baby survived and had cerebral palsy. After so many years, this mother takes the hospital and the clinician to court when she read about viability and asked the question that if you yourself set your viability at 24 weeks, why did you keep my baby who was at 23 weeks and now I have all these issues? So these are the things, and I'm very open. You know, we can't just change it to 26 weeks. We need evidence to be able to make the change, right? I know we have a lot of babies surviving in my interactions with neonatology, pediatricians, and personally, we've had babies delivered at 26, 27 weeks and surviving. Where is the evidence? So to be able to change this, I think now we can collaborate in following up all the preterm babies delivered below 28 weeks. And if we think we are now able to save them, we can call for a change in our viability. At least that can come from Confanoche for a national adoption. So these are just a few, this is my last slide. These are just a few policies that I think will ensure equitable access to reproductive health interventions. Right? I feel we should strengthen universal access to reproductive care. Family planning, very important. It saves a lot. Antenatal care as well. I'm hoping we integrate these ethical protocols into our clinical guidelines, develop national policies. I think we've overemphasized this, and maybe next time we do this, we will talk about Ghana's policies on ART and surrogacy. We should review our viability, as I've just said, then make sure we invest in maternal health systems with emphasis on prevention. So let me conclude by saying a key aspect in shaping tomorrow's life as we have is the survival and quality of life underlined of our preterms. when we adopt strong equity-driven policies, we give every preterm baby the chance not only to live, but to thrive. Thank you.
Thank you very much, Yao. We'll be dancing very soon. Who all have seen some of our videos online on TikTok about, yeah, we're going to be dancing very soon. I hope to stretch ourselves, to get a little bit of exercise, and I hope everybody participates. Before then, if we have any questions for Dr. Jante, any questions for Dr. Jante?
Yeah, I guess when it came to surrogacy and ART-related issues, I'm expected to react. So I will react. Yeah, so as he rightly said, currently we don't have national guidelines for ART practice. We are at the tail end of it, as I said earlier on. Next year in Accra, we are going to have our annual general meeting. We have already decided on the topic. It's going to be on third-party reproduction in Ghana. Third-party reproduction in Ghana. All issues concerning surrogacy, sperm and egg donation will be analyzed because this is the area that is very, very topical in ART practice. For the embryo transfer, I'm assuring you, because we don't like it, all the practitioners, except the quack ones, which we are trying to weed out, know that the evidence is there. Transferring many embryos doesn't give you more pregnancy. It gives more troubles and more headache. All these pediatricians here, we've gone through all that phase, so don't want this. But normally it has to do with the young practitioners. They think that if they put more embryos, they'll get more pregnant, which is not true. Okay, so we are working on that. Single embryo transfer is very difficult now. I do single embryo transfer in some cases because we do genetic testing. So when you test the embryo, you can put one like with a high degree that they can get pregnant. But if you're not testing the embryos, see the people who come to us, they are so desperate. They are so desperate. Even if you ought to give them 10 embryos, they'll collect because the society is mocking them. They don't see any worth in their lives. So many issues. So the clinician is also push the wall. But I always say that if you talk to them well, they will agree to at least 2 embryo transfer. Don't go more than that because it's counterproductive to put more. You put 3, as you say, they end up losing all the babies, or they end up with children with health problems in future. So we are working on that. My other concern, we are confidential together, primary prevention. That is the area that we are not doing well as a country. These things that he talked about, we talked about them more than 10, 20 years ago. You see, people, in fact, those of you sitting here, I see many people of reproductive age, even including doctors. When you want to get pregnant, do you go and see a doctor? You don't go. Well, you know that to optimize your outcome of pregnancy, you have to go and see a doctor. So if you're overweight, lose weight. If you have got hypertension, do this. Diabetes will treat you. They then go. So how can you, the general population? So that is the biggest problem. We are not proactive about our health. Obesity is one area. I did a research in my hospital for the women who come for fertility care. The overweight and obesity was like 80% of that population. I invested heavily in a weight loss program. Nobody is patronizing it because the society thinks that if you have got weight, wait a year. So they glorify weight despite all the health problems with this. The last thing I want to talk about is that, you see, people don't have knowledge about decline of fertility with age. People think that they can get pregnant at any time, which is a fallacy. From 35 years old, it becomes very difficult to get good eggs from a woman to do it. And now people wait, they go to the pastors, the churches, everywhere. By the time they come to us, most of them are over what? 40 years with no eggs, have fibroids, have diabetes, hypertension. That increases the risk of preterm deliveries because those conditions are risk themselves. Then you put more embryos, then you double or triple the risk. So we know all these issues, but I think that Ghanaians need education on the primary prevention issue because that's our best bet. So when people are getting married, tell them, if 1 year, 2 years not getting pregnant, go to a good place, That's the best time you can get treatment, easily and cheaper. Because if you wait and get to 40 years old, you need donor eggs, which you pay for. You have fibroids, you have to do surgery. You have so many things. So let us all be ambassadors to our clients. Tell them when they come for some medical condition, tell them that, look, this can happen, this can happen. If you are married for 1 year, 2 years, your charges, educate them. Go and see a doctor. Because if you wait, the consequences of waiting are so dire when you reach a certain age. Thank you.
Thank you very much. Okay, thank you very much. Advocacy, advocacy, advocacy. Primary prevention. Thank you.
Thank you very much. To add to what Doctor said, I would want to ask about the accessibility when it comes to the primary prevention with regards to the preconceptional care. We've been talking about this over years, but we as health workers, are we ready? Is it that we are going to create a special clinic for preconceptional care, or we are going to combine with our ONG clinics? Because the public are now becoming aware of preconceptional care, and some of them are willing to access preconceptional care. But the question is, who did they go to? Where exactly do they go to the facility to seek for preconceptional care? Because I strongly believe that if we're able to implement it well, we are going to reduce the preterm births that we are having. So I think it's high time we start the implementation. Thank you.
Thank you very much. A very laudable idea. As for the weight loss, Dr. Canton, easy, sir.
All right, so as I said, currently we don't have a separate space or room to go for preconception care, though we are working on it. But you can always show up at consulting room 8, as in the specialist consulting room, and there is maternal fetal medicine there that does preconception clinics, right? So once you come and you request for the service, you will be brought to any of the maternal fetal medicine special. I'm here, Dr. Bempa is here. We have many residents under us who do this. What we are trying to do, especially, it goes beyond preterm labor. We are trying to liaise with all doctors, right? All the clinics attending to reproductive age women. Let's take sickle cell, let's take diabetics, let's take asthma clinic, hypertension clinic, all the clinics where reproductive age women are seen. We want to make the talk on contraception a key component for the care of all these women. It is only when you are on contraception that when you think of getting pregnant, you will report, right, for the contraception to be stopped. And by that, we will take you through the preconception process and optimize your health so that most of these conditions we have can be resolved. I hope I answered your question.
Dr. Bimpa has a follow-up.
In the incubator, I thought it was lunch. Yeah, because we may have obstetricians who are joining us virtually. I mean, Dr. Jante made some comments on the DEXA, but they were not explicit. So I want to be clear so that they get it right. He said you are allowed a rescue dose of DEXA a second time. And there's no evidence that if you repeat a third cycle, there's evidence, there's benefit. Rather, there will be harm to the baby because it can cause brain atrophy of the fetus. So that's why you cannot give more than 2 cycles, even if after second cycle, the pregnancy is below 34 weeks. The other point I want to add is that even if you've taken the decision to deliver the woman the same day and the pregnancy is less than 34, please start DEXA because the single dose may have some benefit, even though the magnitude effect is lower in terms of reducing RDS and the rest. So you may admit a case of severe preeclampsia or severe features, and you are stabilizing for delivery in 4 hours, 2 hours, 6 hours. Still start your 6 milligram dexamethasone and deliver. don't say that because you are not going to complete it, you are not going to start. Then the third point about the DEXA is that there is no benefit of accelerated dosing. So if you are giving betamethasone, you can give 12 milligrams. But if you are giving DEXA, it's 6 milligrams. Some people or institutions are still giving 12 milligrams. When it can cause maternal hyperglycemia, and then if the woman delivers within a short time or within 48 hours, because that baby has hyperinsulinemia, and you are at a facility where you cannot even monitor and manage the hypoglycemia in the newborn, you are going to have bad outcome. And again, if you give higher doses, you are going to have HPA, that's hypothalamic pituitary adrenal complications in the newborn, and also long-term neurodevelopmental delays in the newborn. So that is why we do not advocate for higher dosing in there. So let me just end on the 28-week viability 10. I mean, now we know with improvement and availability of facilities, we have to reduce it. And I think South Africa is still doing 27, right? South Africa, their viability 26. And their weight is 0.8. There was a study in Cape Coast Teaching Hospital where they thought that the survivor, even at 26 weeks, was good. So they were advocating that it should come to 26. But then the limitation of their study was that they didn't do long-term follow-up. And that is what was contributing to the legal suit Dr. Jante cited in UK. Because if I'm doing counseling and I tell you the baby may survive at 23 weeks, but then these are the percentages for neurodevelopmental abnormalities, then that one you can see why you won't win. So what I'm trying to say is that in our attempt to do studies to determine what gestational age viability should be appropriate for us, we should aim at long-term follow-up, up to 2 years. So that it's not just survivor, but then when we are counseling the clients, we will include effects of neurodevelopmental abnormalities. But if I include and say these are the proportions that will develop learning disabilities, MRs, autisms, attention deficit hyperactivity, and then you still say, because in the heat of it, they will say, I want survivor. But if you don't tell them about percentages of neurodevelopmental delays, they will come back in the future to sue you. So I think we should aim at a long-term follow-up up to 2 years so that we will be able to give comprehensive counseling. Thank you.
Thank you very much. We have a very lovely skit. This conference day, we do all, right? Yeah. If you didn't come, you've missed out. If my people are ready. Okay.
Doc.
Doc, I see you, Kipo.
Yeah, I do. I've been busy with work and all that.
Okay,
Yeah.
I see.
Yeah, so we are about to perform an emergency cesarean session for a 28-week pregnant woman.
Cool. What's the indication?
Okay, preeclampsia with severe fetal distress.
I see. Then I'll let the nurses prepare the MBU.
All right, sure.
Yeah, no
Thank you very
problem.
much. All right, yeah.
Hey, Nurse Lindy. Good morning. I have a case for you today. So we have a 28-week baby, preterm baby, coming to the MBU. So I like to prepare the incubator to receive the baby. Yeah.
Let's get a resuscitation tray so that when baby comes, we are all set. So please bring the ambu bag, please. Yeah, and the nasal pumps. Let me bring the monitor. Bring the monitor. We will need an NG tube too. And our gloves. All right. The penguin sucker. Let me switch on the incubator so that by the time baby comes, the incubator is already warm. All right. All right. We have our gloves here too. Everything is set. Our weighing scale. All right. When baby comes, we are ready to receive our baby. Come very soon.
Good morning, Nurse Issy. How are you?
We are fine.
Oh, this is the 28-week.
The pregnant baby.
Yeah.
It's okay. Okay. Please, I'm coming. Talk to us.
Okay, the baby was delivered about 15 minutes ago. She cried weakly at bed. She was suctioned and kept warm. Oxygen was begun in theater too.
She's getting ready to put the baby in the incubator.
All right. This is the head.
The hair ticket. Okay. Let me take baby out. And better it. You are checking the Bible. We'll take a back from here. You can go. The temperature says 6.6. Please, the RBS is 5.4. Yeah. The heart rate is 155 beats per minute. And the SpO2 is 75. Oh. Yeah, 75. Baby has even ceased breathing. Oh. Boss, it's good you are here. Please.
Is it connected to oxygen?
Yes, please. It's connected to the oxygen.
Oh, okay, he's breathing now.
Yes, baby is breathing now. The SpO2 is fine. Yeah, it's fine. It's 90, 95 now.
So we'll just wait for Dr. Boateng.
All right.
That's that case, the KCPAP. And then maintain on full 10% dextrose. Okay, so then we need an NG tube to start oral caffeine citrate.
Hello, boss. Morning. How are you doing?
Oh, boss.
You guys are glowing.
I just got married. You just got married.
Just got married. Oh, that's good. I can see that a new baby. Fine. All right, Dr. Usu, kindly talk to me.
Okay, so this is a 28-week baby.
Okay.
Born via CS on account of preeclampsia and fetal distress.
Good.
To a 34-year-old mother. Gravida 1 power 1 plus 0.
All
Net
right.
weight is 1.4 kilograms.
Okay.
With ABGA scores of 5 and 7 respectively.
Good.
The baby just has severe respiratory distress from which we had to bag.
So okay.
But the vitals are now stable.
The vitals are stable.
Okay, so my impression is very preterm baby with very low birth weight and severe respiratory distress.
Ah,
So we
that's
keep the
good.
baby on KCPAP, start baseline full black count, and then we started at 10% dextrose full maintenance, and we're just about to pass an NG2 for oral caffeine citrate.
You are good. That's my boy. I have trained you well. Good. I like that. When you do this, you make me happy. You understand? Yes.
Yes, boss.
Okay. Also,
When the mother comes, we can start trophic feet. We start gradually, then we increase. You understand?
Yes, boss.
That's good. And then we have to pay close attention. Preterm babies, they are risks of attracting infections. So you have to make sure that whenever you are coming close to the preterm, the hygiene, hand washing, wash thy hand.
Yes, boss.
You understand? The Bible says that cleanliness is next to godliness. So whenever you are coming to the baby, you have to make sure that the hygiene is on point. Also, there are tricks of hypoglycemia. Monitor their RBS and everything. You understand? Then jaundice, seriously, necrotizing enterocolitis. So you have to monitor them. You get it? Yes, that's very good. All right. So I will leave you. You guys are doing well. You are glowing. I can see. I've not forgotten your lunch. You understand? I said, boss, I need to wire you so that you enjoy yourself because you are working hard. You are working hard. Good, good, good. I'll take my leave. I'll take my leave. Let me eyeball it. Oh, good. Oh, it's just a small distress, but he'll be fine. You've kept him on KC pap. He's breathe. You'll be fine. You'll be fine. All right. So I'll take my leave. Okay. All right. Bye.
Hey, Nesama. I'm good and you? Okay, I see. I see your baby. Oh, he's doing very well today. Let's go and see him. No problem. Hey, Nestle, you are back again. Oh.
Efia nya abotre.
Pacha,
Is this my child?
Madam Veronica, yes, please, your baby.
Hey.
But it's not the baby I thought you'd give birth to.
Oh.
This baby is quite small and
Efia, we fuka kaka nyina we ya.
Oh, mommy.
You do be ye. Kete sakotre. Ya mrani ya wa kasia mo mereke.
Oh, madam, calm down. See, preterm babies, when they are born, usually are small and fragile. But with proper care, they grow and survive just as well.
So, doc, I mean, what can we do to help? Because I don't like, in fact, what can we do to help?
So right now, we need to keep visiting and stay positive. What the baby needs right now is warmth, milk, and love. And with God on our side, we hope everything will be fine.
Kwaku papa yanko bompaye.
So please, Madam Vero, you come every 2 hours to feed your baby. We have an NG2 in C2, so please. Mommy. Grandma, baby body di pa. Si mommy mpo just say da homa kakra hye. Ni hini makosi ni yem. They say ni ma ne nnum no fo. Ti oba obechim no fo na ba. Ne de kakra fa tube no. Oh mommy, ah obey me ti ase. Bye.
Mommy, yeah.
Yeah, I'm coming.
Good afternoon, good afternoon. How's the mother of the baby doing today? And how's the baby? Have you checked vitals today? Let me assess him. Madam, your baby is doing really well today. Okay, so we'll wean him off oxygen and start kangaroo mother care, also known as KMC. So our dear nurses are here to take you through.
Okay, so kangaroo. Okay. Okay, so kangaroo mother care. I'm going to show you how it's done. It's basically a caring method we do for preterm babies or babies who are low weight. Okay, so as I say, she's going to demonstrate. Okay, so first of all, you have to put your baby direct skin to skin contact in between your breast. Hold the cloth. All right. Okay. So direct skin to skin contact in between your breast. Oh. Privacy. All right. So you have to flex the limbs of the baby in a frog-like position. All right. Then you tilt the head to block breathing so that the breathing won't be blocked. Thing. Then we tie the cloth behind. All right. Then we tie the cloth behind. Oh, so far as you are comfortable, we prefer so many hours a day. So every time you come to feed, this is what you'll be doing. You can even sleep like this if you are comfortable. Do you get it? It will make the baby bigger. It will improve bonding too.
Okay, I'll try my best.
Yeah, you're already doing so well. So remember, your love, your warmth, and milk is what the baby needs to get bigger. You want the baby to
you
be
said
overlooked.
something about KMC. Do you have KFC too? Oh, KFC, kangaroo father K. That's what I'm saying. Not
Papa Yankasa, oh. But not officially, but yes, the father and even the grandmother can take part in this.
Okay, then I think I will do that for my lovely wife here so that she can have her.
Thank you.
Yeah, I mean, that's the least I could do for you, my love. Right.
Yeah.
Madam Vero, you've done well. I like you. The way you are, the way you adhere to the time and all. Oh, I know. You've done well. That's why I'm coming to take baby off. You've done well. You've put in baby there for hours now. So I'm coming to take baby out and then check vital. Madam Vero, today baby is doing perfectly well. You see, when baby is there, when baby was on your chest, you were taking. Good morning, boss.
Today.
Please, we are fine.
And how's our little fighter
The
today?
little fighter is doing perfectly well.
Have you checked the vitals?
Yes,
What about the weight? Oh. I didn't come back. Can I check you?
Oh, doc. Yeah.
Come back, you be show.
Oh, doc, please, the weight is 1.8. 1.8. Yes.
Oh, that's good. That's good. That's good for today. That's good.
Yes, boss.
1.8. Yeah. Dr. Owusu.
Oh, today we are fine, boss. The baby is 7 weeks old, and as you just heard, he weighs 1.8 kilograms. He's breastfeeding and is taking 35 mils by cup. And he's also on iron supplementation. But boss, we're hoping if you could be discharged today.
The baby is doing well. Oh, she's breathing well. He said the weight is 1.8. See, the baby has gained weight. Oh, good. And it's feeding cup. Good. She's also breastfeeding. Hey, mommy, when you answer now to Tom say, oh, sorry, but you have done well. You've done well, okay? So you go home. I agree with you. You can discharge the baby, all right? So you can go home. You've done well. You've done well. And then when you go, come for the review. Don't forget. I know that they've taught you the KMC and everything. Adhere to it, all right? Make sure the personal hygiene, everything, the hand washing on point. Don't allow people to be touching like that too, okay? That's very good. All right. You've done well. So I will leave you and then, yeah.
Hey, I'm now what to say. Hey, when you're at home, now, Patron, Benny. Abo friend any day. Hey, I don't go to phone and nurse for. And I be doing them the man. Into a dia. No funcio. No funcio. Hey, me nana. Yes. Hey.
Enti mami, on say ubaye ne yekan. Na meti ase. Ena nufusuo ne KMC na chere no hygiene ni na aboa. Enti pretem for hwe de. Hey, mi so me komachi. Pretem for hwe de abotire. Odo ne tema nufusuo no ne abotire ebrewom. Nso madam very de bia me kana asem se KMC ne ba na waba ne kunu no. Ono kura be KMC. Okata time so kura se da. Ni kunu waya ade waboa wo kire se waya ade. Nti mame yesre mo. Sesi a yayi mu na mu kofie ni de. Ye besre mo a ahoho hwe no mo nte so. The visitors, please reduce the visitors' time. Like, and mommy, let me say, Moko Fieno, baby, Obawa, Ontiminko, Fiamponi, no. Oh, be ever shiny be. And so, mammy, no, oh, me, who ye, baby, who ye. Any pony frab on ban in some feet, in some James. Nini Nana, Bessa baby moon, a monkey to no more feeling, some free school, but baby, but a moon, or more dear, the young besom, but won't prevent it. Some on bet me out, no more romans are come. To walk on a baby, why, mammy? Grandmother, them the showers, sir. Mammy, way, me kind of, me kind mammy, way,
Doctor for the must say. Mommy, I cried about 20 miracle. Miracle, na nyamia yebi. Oh, me don't want to.
Thank you very much. A big round of applause for them. This grandmother did. Ready to dance? You have never been to a conference like this before, have you? Give a round of applause for the LOC. Thank you very much, Team MBU. Thank you very much, our very own Dr. And please take out your, if you have TikTok app, please follow him at drdanibest.com. He does a lot of fun videos, educating us on medical issues and so on and so forth. Thank you very much. Danny is one of our households. Danny, I hope you come back and do pediatrics, please. This program will not be possible without some of our wonderful sponsors. So next, we have a short presentation by one of our sponsors. No, hold on 1 second. Novartis Ghana. Ready? Okay, with a round of applause, we invite Dr. Isaac.
Good afternoon. Thank you so much for having me. My name is Isaac Amponsa. I'm a pharmacist, and I'm here today representing Novartis, one of the leading pharma companies in the world. And there was something that happened in the world in July this year. What happened was that there was a global approval for a product that has come to fill a gap that has existed in malaria treatment from the beginning of time. That gap is that until this product, the existing antimalarials that we have were not known to be used in babies less than 5 kg. And so that approval means that from that time onwards, any baby who weighs less than 5 kg who will get malaria, we now have a solution for those babies. And we are happy that Novartis is leading the forefront towards the fight against malaria. Yeah, so in the next few minutes, what I'm going to do is to introduce to you the product Coatem Baby, and I'm going to talk about the study that led to this innovation. We call it the Kalina study. So that's what we are going to do. Yeah, so I have a disclaimer. This is for education purposes only. And the truth of the matter is that a lot of us, we consider malaria to be a part of us because we've all had it and nothing happened to us. But the sad truth is that about 76% of malaria deaths in Africa happen in children less than 5 years old. And research in Mozambique, Mali, Kenya, and Sierra Leone, which are our neighboring SSA countries, show that 8.4% of those malaria deaths happen in children or babies less than 6 months old. And I'm happy we are having a Prematurity Conference, which we are focusing on this population. And so malaria continues to be a big issue in our continent, and Ghana is not an exemption. The truth, which is sad, is that most of the malaria deaths are preventable, but unfortunately, it doesn't happen all the time. And so it is important that we all join forces together to fight that. Yes, so what is also important to note is that the prevalence of malaria in young infants is poorly characterized. The reason is that I have been in consulting rooms I have had engagement with some pediatricians, and we cannot tell how many babies who weigh less than 5 kg get malaria. Usually, the common response is that it doesn't really happen, which we don't have the evidence to support that. And so in some countries, we've been able to have a fair idea about the prevalence rate. Nigeria having about up to 59.5% prevalence, and then in some other countries. We do not have data for Ghana. But what we sometimes say is that, in fact, there is evidence that when the babies are being developed in the uterus, there is immunity that is passed on from the mother to the baby, and that is the immunoglobulin G antibodies. It helps to inhibit parasite invasion. Also, through breastfeeding, lactoferrin and immunoglobulin A are also transferred to the baby, which also helps to inhibit parasite invasion. There is fetal hemoglobin that also helps. And so all of these things protect the baby from malaria. However, the other point is that these protective factors, they decline as the baby ages from birth, day 1, day 2, day 3, and etc. And so what we are saying is that despite these protective factors, malaria should still be considered in babies who present with fever and other non-specific symptoms, because some of them continue to have malaria and we do not want to lose them. Yes, so we need to look out for malaria in those babies. Yes, so what is the current treatment guideline saying according to the WHO for malaria in young infants? We are talking about those who weigh less than 5 kg. The WHO malaria treatment guidelines make that infants weighing less than 5 kg with uncomplicated malaria should be treated with an ACT at the same milligram per kilogram body weight target dose as for children weighing 5 kg. If you've ever, I'm sure you've all seen artemether lumefantrine 2120 tablets, the dispersible tablets. You see on the pack that the product is for 5 kg and above, but the WHO makes this recommendation. Within that same WHO guidelines, the WHO admits that this is without evidence. And so in the guidelines, they will say that it is not evaluated using the GRADE framework. The GRADE framework is a standard framework that the WHO uses to in preclinical studies that high concentrations of artemether is associated with neurotoxicity. For this reason, this study was prematurely terminated because they saw that there was a risk for high exposure of artemether, which will predispose to neurotoxicity. And this is when the Kalina study idea started from. Because if babies are being exposed to toxic levels, then Novartis says we need to look out for a safe alternative for those babies. And that gave rise to the Kalina study, which we are talking about today. So we are going to talk about Kalina, but before, the Coartem or artemether lumefantrine dispersible tablets studies already. It was because of this study that we still have Coartem or artemether lumefantrine with us today. The endpoint of that study is that for artemether lumefantrine to be effective, you need to have a maximum concentration of artemether to be 101 nanogram per ml. Also, the lumefantrine concentration at day 7 after treatment, day 7 from the initiation of the treatment is supposed to be 212 because you need lumefantrine to stay in there to mop up any excess parasites that may be in the circulation. Also, parasite clearance time. This is the time of Coartem dispersible tablets, what we've been using already. It is 34.3 hours, and then the cure rate is 97.5%. So the Kalina study, investigating within less than 5 kg, the endpoint was that whatever results that we were going to get compared to this is the benchmark or the gold standard for an anti-malaria to be considered effective. So if the Kalina outcome is measured against this and it is same, then it means the molecule is going to be effective. Yes, so now we are going to talk about Kalina. Kalina, as I've mentioned, the focus is in babies weighing less than 5 kg. And so we use the physiologically based pharmacokinetic modeling to predict the strength or ratio of artemether lumefantrine that will be safe in those babies. Remember, the 2120 was considered not safe. And so based on the PB-PK modeling approach, you were able to identify these doses, which is 560 milligram, 5 milligram of artemether, 60 milligram of lumefantrine, given twice daily for 3 days. If you realize this is a ratio of 1:12, unlike the existing ratio, which is 1:6. Yes, so the study evaluated this optimized dose in AL in young infants between 2 kg and less than 5 kg. And then we compared the outcome of that to what I mentioned earlier, which was from Abdullah et al. Yes, so now the study design of Kalina, it was a multi-center open label trial. It was a pharmacokinetic study bridging the gap between what we know already about AL. The sample size was 28, but the 28 was divided into 2 cohorts. We had cohort 1 and cohort 2. Cohort 1 was babies who were 28 days and older. And then cohort 2 were babies who were less than 28 days or neonates. So they were given the 560 formulation for 3 days, and then they were followed up to 1 year. The trial or the study had the following endpoints that you were looking at. The primary endpoint was the artemether maximum concentration following the first dose, which is supposed to be 101 nanogram per ml. The key secondary endpoint was also the lumefantrine, day 7 concentration, day 8 or day 7 after the first day concentration. And also, we also looked at the other secondary endpoint, which is the parasite clearance, and then the 29-day cure rate and safety as well. So now let's look at the outcome. I've spoken about this. The inclusion criteria was male or female. They were all recruited, and the cohort 1 was babies who were 28 days and above, and then cohort 2 we had less than 28 days. The body weight of those who were recruited for the study, they weighed between 5 kg and 2 kg. microscopically, we looked at parasite count for cohort 1, 500 to 100,000 parasites, cohort 2 from 100 to 100,000 parasites. And then we had exclusion criteria. Babies who were severely malnourished, babies who had other clinically significant neurological and cardiac renal issues were excluded. Babies who had severe anemia were excluded, and then HIV status of the parents were, all of those people were excluded from the study because we wanted a real world, a real life situation of it. Yes, so for the outcome, the first primary endpoint, you are looking at the Artemeter Cmax. The Artemeter Cmax, 90% confidence interval of the outcome should contain nanogram per mil. And you realize that for the range of Artemeter maximum concentration, we had a range of 45 to 103, which concentration for both cohort 1 and cohort 2. For this reason, this gives, this is the fact that the study or the outcome of the Kalina trial proved that when that 560 dose is given to babies less than 5 kg, they are going to get the required Artemeter Cmax, which is needed for the immediate clearance of the parasites from blood. The other endpoint, which is the secondary endpoint, was about lumefantrine concentration. Lumefantrine concentration at day 8, it needs to be above 215. It needs to be above 215 nanogram per mil. And we had for both cohort 1 and cohort 2, the range, all of them were above that. So the outcome of the Kalina trial was actually similar to what has been established already. And also from what we mentioned earlier, the parasite clearance time of the existing 2120 tablets that we have is 34.3 hours. The outcome of the Kalina trial for cohort 1, we had a clearance time of 35 hours. And for cohort 2, we had a clearance time of 30 hours. What this means is that if you give this new formulation Coartem baby to a baby weighing less than 5 kg, within 30 to 35 hours, the baby is supposed to get parasite clearance, which is going to translate into clinical response. And also the other endpoint, which is very important, is about the cure rate. For any new anti-malarial to be considered appropriate for use in human beings, it should have a cure rate of at least 95%. And for the Coartem that we have already, the 2120 and then the adults, they both have a cure rate of 97.5%. Now, for the Kalina trial in cohort 1, we had 95.5 cure rate, and in cohort 2, we had 100% cure rate. So all the endpoints that the Kalina trial was investigating for were actually similar to the existing Coartem 2120 that we have already. And this is what led to the approval of the molecule. In terms of safety, there was no serious adverse events that was observed, no death related. The participants were followed up to a year, and the side effects that were recorded were pyrexia, anemia, vomiting, bacterial rhinitis. And in Novartis, once you take any Novartis molecule, whatever side effects that you experience is recorded regardless of causality. And so these were the outcome of the Kalina study. And as mentioned earlier, the safety profile is similar or same to the existing Coartem 8480 and the Coartem 2120 dispersible tablets that we have. Yes, so the summary of the Kalina study or trial is that the Kalina study demonstrated that the optimized dose, which is 560, a ratio of 1:12, giving us 2 dispersible tablets, provided appropriate exposure levels of AL in young infants 5 kg, less than 5 kg. Also, the study showed that the dose 560 is efficacious in achieving above 95% PCR corrected ACPR. The safety profile is also consistent, and the study provides evidence for the appropriate dosing of malaria treatment in young infants weighing 2 kg to less than 5 kg. This point is very important to me because from this point, we can now put a stop to, we now need not worry about what we are going to do with the 2120 tablets in babies less than 5 kg. Some people who use suspensions will have the volume instead of 5 ml, they will give 2.5 ml. Some will crush the tablets and etc. All is a ratio of 1:6. And whatever you do, you are exposing those babies to toxic levels of artemether. And this is the optimized dose, 560, which is considered safe and efficacious in those babies. So this is Coartem baby. We still maintain the name Coartem because it's our legacy molecule. And the strength is 2.5 milligrams/30 of artemether lumefantrine. However, as mentioned earlier, the dosing is 560. So they are small tablets, dispersible tablets, cherry flavored, and they are dispersed in about 5 ml of water given to the baby, and the mother breastfeeds the baby right afterwards. On the other hand, the mother can express breast milk and then disperse the tablets in the breast milk and give it to the baby straight away. So this is how the pack looks like. We launched it in Ghana in October, and in Kumasi, we've had a number of babies. We've had a number of babies who have benefited from Coartem baby. I just saw a pediatrician who I had to drive to his facility because 2 babies on the ward needed Coartem baby, and then we got it to them. And about 2 hours ago, I've had calls from Kumasi South Hospital, Suntreso Hospital, 3.5 kg baby, 3.8 kg baby, uncomplicated malaria, and we have gotten Coartem baby to them. Yeah, so we want to intercede on behalf of those babies weighing less than 5 kg who may get malaria. And we believe that with a common voice, when we unite together, we can make sure that those babies, when they get malaria, we will have the first clinically proven anti-malaria. We can make them available to those babies. Thank you so much for your audience.
Okay, question. First question is already on availability.
Yeah, so let me start with the cost. Some of you think Novartis, our medicines are expensive. It's a myth. It's one of the myths about Novartis. Yeah, it is very cheap. Wholesale price is 17 cedis. I won't talk much about it. Yeah, so retail maximum 25 cedis. Yes, it is very cheap. Yes, clap for us. So, yeah. And also about availability, it is available on the market now. Some retail pharmacies have it. However, we are advocating that hospitals stock at the hospital pharmacies. Yes, so those of you who have facilities who take products from the regional medical stores, you can send your requisition there. We are engaging the regional medical stores to get it over there. And also, let me leave my number with you. If you need one as soon as, from today or tomorrow, you can call me and I will dash to wherever you are. So my number is 0546 89. Okay, 0546 89 2929. A very simple number.
Dr. Ambonsa.
Yeah, Dr. Gesua. 0546 892929. My name is Isaac. You can add Coartem baby to it for easy identification. Yes. Is there any other question?
Any other questions? Okay. It is
Thank you
finally-
so much.
Thank you very much, Novartis, our sponsors. A round of applause for them. That's a question from the back.
Please, I want to know, won't the mothers abuse this drug if they find it in the market? Because I know in our part of the world, normally when we are having high temperatures, some of the people might resort to the pharmacy shops, get malaria treatment. So in case the mothers get to know of this drug, what remedy are we putting in place to keep them from buying and giving it to their babies without seeking medical attention?
Thank you so much. That's very that's a genuine concern. Because of the kind of population that we are talking about, these are babies who are usually less than 3 months old. The emphasis is on testing. Yeah, you need to get either an RDT test or microscopy. And so from now, most of our engagement has been at the hospital level. You are engaging the pharmacy level as well. That we are going to make sure that before they give coartem baby to any mother, they need to have a test which is validating that the baby is having malaria. Yeah, so that is how the communication and education is going about, making sure that no baby should get coartem baby without testing. Yes, and in the same way, we are encouraging healthcare providers to also test babies who present with malaria, fever and other symptoms, just in case it is malaria. We kill it as soon as possible. Thank you.
Thank you very much, Novartis, our sponsor. It is now finally time for lunch. Does that sound good? Okay. So we have just about 30 minutes for lunch. We are still running behind time. I will try to catch up. We're going downstairs to the restaurant, all the way down at the basement. That's where the restaurant is. And please kindly go down there. Thank you.
Jervis about to lead us in a great time of worship. Him and the team. Jervis is
Hello. Please, they would want us to go to the next room for the poster presentation for just 10 minutes. Then we come back and continue with the other presentation. So just the next room. Thank you very much.
Hey, Jervis, about to lead us in a great time of worship. Amen.
For his name, we will throw off your pain. Jesus destroy them all. Up from the grave, he is with us now. Say, no, he trampled the darkness. Nothing can stop it. You are the God of the promise. Every word will be a promise. Nothing can stop it. You are the God of the promise. Of God will your name prevails. Jesus the leader. No word will fail. No word unformed against you. Your name prevails. Jesus the leader. Your name prevails. Jesus the leader. No words will fail. No word unformed against you. Your name prevails. Jesus the leader. Trample the darkness, your nothing can stop it. You are the God of the promise. Every word will be accomplished. Nothing can stop it. You are the God of the promise. It's time. But often it's hard. Understand. What can I say? What can I do? But often it's hard. Lord, what can I do? Oh, what can I do? But often it's hard. Complete. My soul surrender. I stand with arms high above me. In all of the world, my soul to you surrender. I'll stand with arms high and hearts abandoned. In all of the world, you give it all. God, we look to you tonight. Above the singing, God, above the music, above the songs, let your name be lifted high. Let your name be honored. Commit all that we are to you.
Oh, poster presentation is ongoing in the other room. Mom Prima. Enjoying the Mom Prima. Anas, why is it sitting down? Hello. 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 Please, we need to continue in the other room. Mommy, we need to continue in that. Is it?
They're at the start or the beginning of time. No point of red. Spoke to the dark, flushed out the wonder eye. And as you spoke, dripping in galaxies of one. The vapor of your breath, the planet. Stars were made to worship. See your heart, everything. Every burning star, see fire out. Creation sings your praises all night.
Welcome back. We'll be ending very soon. Very soon. Very soon. So we'd like to call on one of our sponsors, Panacea Pharmacy, Mr. Godfred Boatin Safo. Make some changes here. So we are moving on to the next presentation on necrotizing enterocolitis by one of our very seasoned pediatric surgeon. Please let's welcome Dr. Michael Amon.
Good afternoon. I'm Michael Amo, and I'm presenting on one of the devastating conditions of preterms, necrotizing enterocolitis. So this happens to be one of the most common devastating diseases in neonates, and it's preferentially a disease of preterms, affecting about 0.8 to 2 babies per 1,000 live births. And it forms about 8% of admissions to all neonatal intensive care units. Conditions resembling this neck have been described earlier, but it was not until the advent of the modern neonatal intensive care unit when awareness was drawn to the proper necrotizing enterocolitis. Over the past 4 to 5 decades, we know there's been advancement in neonatology as well as in fetal-maternal medicine. And this has resulted in the survival of high-risk pregnancies as well as extremely premature babies. And all that these have done is to just swell up on the numbers and the incidence of necrotizing enterocolitis. Unfortunately, the incidence as well as morbidity and mortality associated with this condition has increased or remained the same despite the advancement in knowledge about this condition. And this has become a major health concern, not only because of the morbidity and mortality, but the cost implications, okay? It's been indicated that those who undergo surgical management, as far as neck is concerned, in the US, after about 2 or 3 months, they spend about $1.6 million as the cost of treatment for this condition per baby. So what is the etiology for this condition? Unfortunately, this has remained elusive over the period, despite all the research efforts people have put in. In fact, some people have spent their entire career life attempting to unearth the actual underlying etiology of necrotizing enterocolitis breast, but without any success. The contemporary models places emphasis on multifactorial factors. You have a host of factors coming into play, and then results in inappropriate response by the immature gut of the premature baby to this host of insults, which results in necrotizing enterocolitis. So several studies, when you look at some meta-analysis, right, it shows what clearly stands out among most of the studies is prematurity. Okay, some have formula feeding as well as infectious agents as part of the risk factors, but what's stand out throughout all the studies is the risk factor of prematurity. But all these come together when you have a genetically predisposed unit or premature unit, and then you have all these factors coming into play, resulting in an inflammatory response, which is mediated by some inflammatory factors like cytokines, tumor necrosis factor, and then nitric oxide. And this result in inappropriate response from the immature gut. And then there's going to be some inflammatory changes in the bowel, which may result in coagulation, necrosis, sometimes perforation. So that is how it is. You have this premature unit and all these factors. We have others here. And then all these come together, which will result in necrotizing enterocolitis. So the hallmark of the pathology is that of coagulation necrosis, with or without perforation. Okay, and then there's trapping of air within the intestinal wall, known as pneumatosis intestinalis. And then when you look at the pathology, mostly it's a focal disease affecting the ileum, but in about 44% of cases, you have both the ileum and the large intestine being involved. And occasionally you may have segmental disease, which affect multiple segments along the bowel. And then in rare instances, you have what we call neck totalis, where the entire intestine undergoes these inflammatory changes. Because this is not compatible with life, I must say. Clinically, to make the diagnosis, one needs to have a high index of suspicion, because the initial presentation is really, should I say, indeterminate, okay, in the sense that you don't have any specific signs or symptoms, okay, but from the history of prematurity, maybe the circumstances surrounding the delivery and all that. And then, sorry, initial specific physiological instability, right, which is manifested by lethargy, temperature swings, recurrent apnea, bradycardia, or sometimes total cardiovascular shutdown, hypoglycemia, and then sometimes shock. Without any warning, these signs will start being exhibited. The classical picture is that of feeding intolerance, which is manifested as high gastric residuals or sometimes frank vomiting and diarrhea. And sometimes there will be frank hematochezia in the stools, as well as abdominal distension. But the distension might not be that gross. It may be just a mild distension that will be exhibited. So in addition to this, on examination, you realize there will be some mild abdominal tenderness, or sometimes there could be frank tenderness with the erythema of the abdominal wall, occasionally with crepitus. And then there may be palpable abdominal mass, which may be fixed or mobile. Okay, and sometimes it may affect the entire anterior abdominal chest wall, even extending to the scrotum and the thighs in severe instances. Okay, so if you look at this picture, you can see there's erythema of the anterior abdominal wall. In fact, this one is in patches. I can see one patch here. There's one around the umbilical area, and then one here. This picture, this was quite a bit extensive. Okay, and of course the distancing here is also extensive compared to this one. The cause of this condition, sometimes it may be insidious, in which case you may have the luxury of time to actually decipher what is going on and then institute your management. But occasionally, it may tread a permanent cause. Within 24, 48 hours, it will result in death. That is a sad aspect of it. Okay. And before we get to management, we must know the classification, because that is what determines whether there's a need for conservative management or there's a need for surgical intervention. Okay. And the most accepted classification is a Bell's classification, even though there are other, some people have, should I say, challenges with this classification, so they use their own system of classification, but this is a widely accepted classification as far as neck is concerned. So we have Bell's stages 1, 2. Okay. Stage 1 part is a suspected disease. Okay. Where the neonate exhibits signs and symptoms which is suggestive of neck, but there's no, should I say, diagnostic criteria per se as far as investigations are concerned. Okay, and then we have the stage 2, which is a definitive neck. Okay, and in this case, when you do your abdominal series, there will be evidence of pneumatosis intestinalis. And then we have the stage 3, which is an advanced neck. So after your history, your examination, And then your classification, these are the investigations that are necessary to confirm full blood count. And here it's likely that the HB is going to be low because of the necrosis that is ongoing with hemolysis. Okay. Urea creatinine and electrolytes. It indicated that when you have a hyponatremia of less than 130, that portends a worse or prognosis. Okay. Blood culture and sensitivity, unfortunately, in almost all cases, this will come out as a negative. There will be no growth as far as culture and sensitivity is concerned. Arterial blood gases will show that there's a metabolic acidosis. And then if you are lucky, you may find evidence of blood in the stools. Paracentesis, you may yield just serous fluid, or then may find intestinal content in the cavity. And then the H2 or hydrogen breath test would also be positive. As far as imaging is concerned, mostly we rely on X-rays, okay? And X-rays should be repeated hours, okay? Yes, I know the challenges that, yes, we what the literature dictates, okay? So, but the fact is that X-ray will not to come to a conclusion because you need to see a fixed pattern. Okay, when you see a fixed pattern of dilated loops of intestines, then because as I said, initially at the early stages, in stage 1, for instance, you may not see anything. Okay, though pneumatosis intestinalis, this is pathognomonic for neck, but it's stage 2, stage 3 that you will see this. Okay, so if you want to see pneumatosis intestinalis before you make your diagnosis, then it will be too late. Okay, and that is why at the early stages, you get, once you repeat your X-ray and you see a fixed pattern of bowel dilatation, then it points towards neck and you have to start treatment immediately. So that is it. Yes, I know we have challenges. Even just one X-ray, it takes so many hours before you can even get that done. Okay, but that is it. And then evidence of portal venous gas. The gas that results from fermentation of substrate within the intestine is trapped within the intestinal wall. Sometimes it extends within the veins into the portal vein. Okay, and the presence of this also portends worse prognosis as far as the outcome is concerned. The presence of pneumoperitoneum points frank perforation. Okay, sometimes you may have just a pimple, then it shows that there's a perforation with leakage of intestinal air into the abdomen. Then there's also evidence of ascites. Okay, so yes, this shows the presence of pneumatosis intestinalis. Okay. When the light is Okay. All right. So yes, you see circular patches of air. Okay, in the pattern of like a droplet of air within the intestinal wall. Okay, that is pneumatosis intestinalis. Okay, another picture here. And then portal venous air, as can be seen. You see branches of air, shadows over the liver. In actual fact, it's trapped within the portal vein. And then when there's frank perforation, there will be pneumoperitoneum, free air within the abdomen. Okay, this is a massive air in the abdomen. The erect view and then supine view. Okay. Ultrasound and MRI may also be used. Usually rely on this for diagnosis. Right. So when it comes to the management, we have conservative management and then we have surgical management. Okay. Conservative management is usually employed in stages 1 and some instances of stage 2 as far as the Bell's classification is concerned. Okay. So what is done is keep the child nil pairs. You give IV fluid as well as, if possible, parenteral nutrition. Okay. There should be an NG tube to decompress the bowel. You give antibiotics. Sometimes there will be the need to give antifungals as well. And then if it becomes necessary, hemotransfusion has to be done as well. Then you keep on monitoring with physical examination and then your serial x-rays as well as full blood count. And then you also, where there was blood in the stools, you also have to monitor the stools for the disappearance of blood in the stools. So this monitoring will go on until the child shows signs of improvement. Okay, and then you start by small feeds. Okay, and this should be breast milk, a mother's own milk, mom, M-O-M, mom. Okay, it's not, they have what we call donor human milk, but that is not the appropriate one. Okay, DHM is not the appropriate one as far as management of these babies are concerned. It should be the mother's own milk, okay, which, as we all know, will contain colostrum, which has all the protective benefits for the baby, okay. And then how to progress, that one, in fact, there's a controversy surrounding it. Some studies claim that too rapid progression of the feeding worsens the prognosis, whilst others found that not to be true. Okay, so I think that how to progress, you have to be monitoring the child and see as and when the child tolerates the feed, then you progress accordingly. So that is how we manage the stages 1 and then some of the stages 2 that are stable enough to undergo conservative management. For surgical management, there are indications for surgical management, but the aim should be that you have to remove any necrotic segment of bowel. Of course, having in mind that you have to preserve intestinal length, otherwise it may result in short bowel syndrome or And then, so yes, the indication, and then of course the timing should be right, and the strategy of the surgery, the method that you are going to employ should also be right. So these are the red flags or the indications. We have the absolute indications for surgical management. So once there is pneumoperitoneum, okay, or once on your paracentesis, you will get positive yield of free intestinal content in the abdomen. It calls for a surgical management. There's no room for conservative management here. So as soon as this is established, you will need to call on the pediatric surgeon. It's no longer a neonatologist issue. The pediatric surgeon has to be called in. Okay. And then we have some relative indications. When you have erythema and edema of the abdominal wall, this signifies the presence of peritonitis. Okay, but we know that it's not all cases of peritonitis that will require surgical intervention. Okay, so it requires monitoring, and then if you realize that there's rapid deterioration, then there will be the need for a surgical intervention in such a patient. Okay. Where your series, X-ray series, is persistently showing the fixed intestinal pattern without any improvement, okay, that would also require surgical intervention. Or when you have your abdominal mass, the palpable abdominal mass is increasing in size, that would also require some surgical intervention, because it may be that the bowel is completely gangrenous and therefore will require resection. Portal venous gas, yes, its presence is not an absolute negation, though the presence of that signifies a worse prognosis or outcome for that baby, but occasionally there might be the need for a surgical intervention. Okay, and where there's a rapid deterioration as far as the clinical condition of the patient is concerned, then there will be the need for surgical intervention in such a situation. Okay, so surgically, what do we do? There are various options depending on the severity of the condition and then the stability, how stable or unstable the child is. Sometimes we just put in drains, or we may just do peritoneal lavage and then come out. At times, we may have to do proper laparotomy with resection and anastomosis or resection and stoma formation. It all depends on the findings when we open up. Okay, we have the patch and drain and wait, or the clip and drop. All these methods are available depending on the scenario. Okay, and then this for the closure of the stoma after the patient has recovered from this condition. Usually it will be after 6 weeks onwards. The complications may arise from several aspects, maybe from the TPN that is, there might be strictness later. In fact, when it comes to closure of stoma, it is important that do a contrast to ensure that there is no stricture formation before the stoma is reversed. Then if it warranted massive resection of bowel, then there's a likelihood of short bowel or malabsorption syndrome. Okay. In 6% of cases, there has been the report of recurrent necrotizing enterocolitis. Okay. has also been realized that most of these children will have neurodevelopmental complications later on in life. Prevention, these are the measures that should be employed. Infection prevention control measures, okay, should be employed in the neonatal intensive care units. And then augmentation of the host defense. Yes, as I already indicated, breast milk is the best for every unit and not formula feeds. Okay. And then the feeding practices, as I indicated, as to whether you should progress rapidly as far as premature neonates are concerned, as to whether we should progress rapidly or we should go slowly. Administration of maternal glucocorticoids has also been found to help in reducing the incidence of neck. Okay. The use of probiotics and prebiotics. Some studies have found it to be useful. Others think that is of no reducing the incidence of neck is concerned. Okay. So all these are available. So yes, to bring my presentation to conclusion, yes, the knowledge base as far as neck is concerned has increased or has improved over the past few decades. Yet the condition remains a trouble problem for pediatric surgeons and neonatologists. Okay. It appears that no new treatment strategies are going to help as far as making any major breakthrough is concerned. So our only hope is to employ preventive measures so that we don't even encounter these conditions in the first place. Okay. Thank you.
Thank you so much, Dr. Amwa. Mother's own milk. Mom, if you didn't hear anything at all today, Mom, please let's say mother's own milk. Please, some people are not saying it today. I'm just looking at my fascinator. Mother's own milk. Mom, please, any questions? Oh, I thought hands would just go up. Or I should bring the microphone to somebody. If I see you're sleeping, I'll bring it to you.
Yes, this study that we followed, they said that if you are having neck, you can stop the feed, but meal per horse, they were against it. They said that you can give 1 meal or 2 meal after some hours. And I don't know, I have not tried in so many, but about 2 or 3 cases that I've tried, I've seen significant improvement after that. So I don't know what he has to say on that.
Thank you. That is trophic feeding and not proper feeding per se. Yes, that is trophic feeding. That one, yes, is allowed. And you realize that you have an NG tube in situ. So whatever you put in eventually will come out. Okay, the idea of stopping the feeding is that when you have high residuals in a bowel, which serves as substrate for bacteria to ferment, and then generate a gas which gets trapped into the intestinal wall, and then results in progression of the inflammatory condition. That is the reason why we have to put a halt on the feeding, okay, so that it slows down the pace of the inflammatory process. And of course, also if there happens to be a perforation, then you are sure that you don't have much intestinal content to leak into the peritoneum to also worsen the condition. But as for trophic feeding, yes, it is allowed.
Thank you. Dr. Ajman has something to say.
I think I agree with you. We all pray we never get NEC on our wards. It's a nightmare. And my question is, how far with parenteral nutrition as far as your unit is concerned? Because these babies, we keep on chasing our own tail. You don't feed, where are they going to get enough substrates to heal? And they don't heal, they end up getting sepsis and they die. So I think it's a lesson to us. Let's aggressively promote mother's own milk as early as possible, and we will not get into this dilemma. It is a tough one. We're doing more ultrasound of the gut ultrasound. And in neonatology, I think ultrasound is gut ultrasound in respect to NEC has really advanced, and we're able to see. We have something called the bowel signature, and the moment the bowel signature vanishes and you see more blood flow, then we are in trouble. So I think because X-rays are a little bit difficult. Where I work, we don't have portable X-ray. You have to take this sick baby down to X-ray, and it's all horrible. So I think we need to train more people on the point of care ultrasound to help us diagnose this as early as possible. I think if you catch neck early, we may avoid, I mean, surgery. And as you rightly said, neurodevelopmental problems with these babies, and it's so tough. Anytime you enter the neonatal unit, pray we don't get NEC.
Thank you.
So, as far as parenteral nutrition is concerned, I think it has to do with availability as well as affordability. Okay. As far as we are concerned, when it comes to affordability, sometimes we sacrifice. Okay. The challenge is that sometimes it will not be available on the market for you. And then when you get it, to get your central venous catheter for such a unit, an appropriate size for such a unit also becomes a challenge. But luckily, the TNA peridot we use, well, they say that it can also be given peripherally. So as far as that is concerned, we don't have much of a problem. But I can also imagine in the district and regional hospitals, the availability and affordability is going to be a challenge. Yes. Yes, ultrasound is increasingly being used now. If you have a POCUS, point of care ultrasound available, yeah, that would be, but unfortunately, Confanochi, I don't know if the NICU you have an ultrasound, they do have now. Okay, all right. Because we have a mobile X-ray. So getting the X-ray done isn't much of a challenge. So that is it. Okay. So as he said, the best is to avoid it because it's a hell to get into. Okay, the mortality, as we know, even in the advanced world, about 30 to 50%. And even when you factor, that is for the medically managed one. When you factor in the surgically managed one, it's running to about 80 to 90% mortality. That is how scary the situation is.
Thank you very much, Dr. Amwa. Please let's take these announcements. All the nurses who came from St. Teresa's, Redeem, please, you're supposed to see Dr. Eunice Minta. Eunice, now. Please, you're supposed to see Dr. Minta now. And also, when you check your emails, we've sent the evaluation forms. Please fill them for us. Please, we beg you, in the name of Mom, please fill for us. We'll take our next presentation from Panacea, one of our sponsors, Gilbert.
Good afternoon. Please, good afternoon. Oh, my apologies. Good evening. My name is Godfred Boateng Safo. I'm a medical rep with Panacea, and mostly for Panacea, our core aim is to meet the needs of eminent and wonderful clinicians like you all with cost-effective, quality medications for all the problems and burdens that comes to you at your facilities. But today, that's not what I'm here to focus on. Today, I'm here to talk about the smallest, maybe the tiniest fighters in the world right now. I'm not talking about the ones that appear in probably our books, not the ones that appear on the TV sets as well. I'm talking about the ones that come a little too early, the ones that come a little too fragile, a bit unprepared to face the harshes out here, but yet they are still able to put up a very, very good fight. I'm talking about our premature babies. They are what I'm talking about today. Mostly, many people think you have to be great before you get something ongoing. But I believe you have to start from where you are before you can walk into greatness. And this is a direct replica of what happens to our premature babies every day whenever they are introduced into the world here. That's a direct replica of what happens to them. They are brought here not ready, but still great opportunities find them. They are brought here not prepared for whatever harshes await them, but still great opportunities find them anyway. World Premature Day or month, to us, it's not just any day on the calendar. It's not any month on the calendar. It is just a constant reminder to us all that every tiny heartbeat matters. And behind every premature child out there might be a mother praying constantly, a father who is very hopeful, and an amazing team of clinicians and prescribers also giving out their best so that a child out there can get a chance. Eminent prescribers, today I'm not just here to give you statistics or figures, but rather I'm here to give you perspective. I really like the theme for this conference very well. I really like it, providing equitable healthcare to premature babies out there. It is very, very crucial because whenever we hold a premature baby, we are not just holding any child at all, but rather we are holding a door to many opportunities. And I believe we all combined together can make this very, very possible for the premature child out there. Today, at the end of this presentation, my aim is simple: to have us all leave here well equipped to wage a good war against neonatal mortality associated with premature birth. My name is Godfred Boateng Safo, as I stated, and today I'll be talking about the need for iron supplementation in infants. So we all know that mostly for preterm babies, their birth mostly happens around the third trimester. And Delaney et al. Makes us understand clearly that for iron supplementation in the preterm baby, it mostly happens during the third trimester. About 80% of iron supply from the mother to the baby happens during that time. And it's quite unfortunate these babies are not able to go through this phase. And as well, they are put at risk of iron deficiency a lot. Because of this iron deficiency, it can impair a lot of developmental stages. And sometimes these babies, because they come out too early, they try to go through the catching up phase where they give off their best. I mean, they try to grow very, very fast. And sometimes the iron demands that requires is not enough for what their body can give. So sometimes it's very, very crucial that we add iron supplementations to these babies. But the very, very important thing is some of these babies only have about 20 mil size of stomach in there. I want to just jog our memories a little. About 20 mil stomach. Imagine baby feed. Imagine breast milk. What will be the extra space to contain medications? How are we going to supplement for the medication need? This is why we are here from Panacea to present our solutions. Ideally, when there's iron deficiency in the baby, there's going to be the issue of neurodevelopmental deficits. They are going to have some long-term cognitive abnormalities. There are going to be some neurological reflex deficits in there as well. Ideally, for every mother during childbirth and pregnancy and the whole phase, it's ideal for them to be well supplemented so that they can meet the demands for the babies in there. But what if for a mother, she puts in her best, she feeds right, she takes the necessary supplements, but still the baby decides to come a little bit too early? It then becomes very crucial for us to start therapy very, very early for the baby, knowing that signs of anemia, they sometimes show late after birth. And because of this, the AAP and the ACOG, that's the American Association of Pediatricians and the American College of Obstetricians and Gynecologists, makes us understand that the supplementation for iron that you need to do is about 2 to 4 milligram per kilogram per day, every day for your preterm babies. Some other research states that you can even go as high as 4 milligram per kilogram per day. Sometimes some of these formulations might be present in syrups. Some might be present in drops as well, but what at all might be the best for your baby? Knowing the need for solutions that might be well accommodated in the child, seeing their very, very tiny stomach sizes, you'd want to give solutions that have very low volume. When you are talking about the iron supplementation, you have to also give solutions for other supporting nutrients in there. It has to be very acceptable for the infant as well. There has to be ease of dosing, because when dosing is a bit difficult, the mother out there might find it a bit difficult giving it to the baby. And also, it has to have very low allergic properties too. Eminent clinicians, wonderful prescribers, and amazing neonatologists gathered here today from Panacea. We saw this need and we brought Profant onto the market. Profant is our great tasting iron supplement that comes with a perfect blend of iron, zinc, folic acid, and vitamin B12, a perfect mix to actually meet the needs of every premature baby out there. Ferrofant, as I said, contains 75 milligram, that's about 15 milligram elemental iron. Also, it contains vitamin C, that's ascorbic acid, 12.5 milligram, folic acid, and zinc too. But why at all would we choose to have all this present in there? For ferrous sulfates, which is our iron, is going to help with the iron formation. Vitamin C would help boost the immune system. And not only that, it would also enhance the absorption of the iron and have its antioxidant properties out there to help the baby. The folic acid too would support the brain and spinal cord formation and development, as well as red blood cell formation. And our zinc too would improve the immune system and function of the baby. Why at all have I taken the time of my August congregation, my amazing prescribers, to talk to you about Ferrofant? One, it is because it's able to deliver the recommended dose of iron to meet the need of every premature baby. Also, there's the presence of other micronutrients, and there's very, very good ease in dosing. The packaging too is very, very nice. It's very well tolerated by the babies, and also it's free from other additives that might have some side effects. Also, it can be found everywhere. It can be found everywhere. When you go to every pharmacy out there, based on your location, Ferrofant can be found there as well. And with the dosing, how at all would you want to dose Ferrofant? Ferrofant comes with a 1 ml syringe. It comes with a 1 ml syringe, well graduated to as low as 0.1 ml and as high as 1 ml to deliver all the needed solutions you want for your baby. Of course, there are some side effects like constipation and diarrhea, and it's very, very critical to store the product in a cool, dry place away from light, and also keep out of reach from children. Before I go, I would want to pass in a few reminders. The first one would be our Vegatem, which is our artemether lumefantrine combination. This being a pediatric congregation, we are focusing mainly on our suspension. That's the 2120 suspension. Ideally, it gives a taste of hope. And all the feedback that we've collated out there is saying its strawberry flavor really increases the appetite of the child for the medication. We had one of our own workers try it on their own babies, and they mentioned the child was actually coming back for the next doses. The last reminder that I would want to give is our Vitaran. Our Vitaran is our growth and appetite tonic. And what makes it special is the presence of lysine in there. Lysine, according to Delaney et al., makes us understand that it helps to increase the growth process of the child, and it boosts appetite as well. Vitaran comes as a 200 ml bottle, and when it comes to the dosing, every infant can take about 2.5 ml twice daily. Children from 1 to 4 years taking 5 ml twice daily, and children from 4 and above taking 5 ml 3 times daily. So thank you very much for your audience. Thank you for taking time to listen to me. And if there are questions.
Thank you very much, Godfred. And usually when you meet the pediatric team, our question is it affordable? Oh, I lie. You can have all the ingredients, all the elements, but our question is it affordable? You said it's available. Is it affordable?
Thank you very much, Doc, for the question. Ideally, before I started, I made mention of one thing, that Panacea is out there to meet your needs with cost effectiveness. And so the price of Ferrofant comes for no more than 40.8 Ghana cedis, 40.8. That's 40 cedis, 80 pesos, 40 cedis, 80 pesos. And when it goes to our Vegatem suspension too, that's wholesale. On wholesale, we sell Ferrofant for 40.8. For a UK product, I believe we are giving quality with cost effectiveness. Yeah, and when it goes to our Vegatem suspension too, our Vegatem sells for 20.5. That's 20 cedis, 50 pesos. And our Vitaran sells for just 60 cedis. Yes, please. Okay, thank you very much.
Thank you so much. Please, a hand of applause for Panacea. We've been hearing a lot about temperature, hypothermia, temperature instability. So to crown it all for us, we have a neonatologist all the way from Accra. You see, he works like the Accra people. Yeah. So Dr. Ajuman is here to take us through the thermoregulation and the warm chain in preterm care.
Thank you so much. It's always horrible giving a lecture at the end. I mean, and especially after lunch. I mean, of course, the cardiac output, a lot now is going to the gut. Right. This is where I work. It's our small village. This corridor So this corridor, anytime there are a lot of people talking out there. Shh. Anytime I walk into our NICU, I look at the activities on this corridor. If you see doctors and nurses walking in and out, it means the day is going to be terrible. If you see it very quiet like this, with people sitting quietly, it means the world is good. And so that's how we test it. Anyway, so I don't have any disclosure. These are a little bit practice gaps. It's always sad talking about hypothermia. It's something that is ancient. Over 100 years ago, I mean, doctors realized that, I mean, when babies are cold, they die. And all these years, we still having hypothermia. It means we are not doing well. Our practice gap, we want to say that a lot of people overlook hypothermia. On the word babies are cold, people will not even know. So this presentation, I want to draw attention that our healthcare providers should understand that the admission hypothermia is a very serious scenario. The moment the baby is cold, chances of dying is very high. And healthcare workers are supposed to be able to plan how to manage hypothermia on the ward. And then not only on admission, but beyond. These will be our learning objectives. We know that all neonates, the moment they are born, they are supposed to go through aggressive adaptations so for them to survive the external world that is very cold. One of the major adaptations they need to do will be able to be able to increase their body temperature. The moment they come out, the cold hits them, and they are supposed to be able to raise their core temperature. We know that under normal equilibrium, the fetus is very metabolic. The metabolism in the baby is very, very high. It's like twice that of the pregnant woman. So at equilibrium, the temperature of the fetus is 0.5 to 1 degree higher than the mother. So the net flow of heat is from the baby, majority through the placenta to the mother. Some may go through the skin. We know that in mammals, the little ones of mammals, especially human beings, are inefficient homeotherms. When we say homeothermy, it means that our core temperature, we regulate it irrespective of what is outside us. And when these babies come out, because they are cold and they don't have enough response, they are not able to mount a lot of this response, and they are very likely to be very cold. So keeping newborn babies is actually very challenging. It needs a lot of effort, but we have very cost-effective to manage this. So that's what we're going to talk about. So they are very much increased, well, hypothermia. So as I said, way back 1907, over 100 years ago, the founders of neonatology, the Silverman and co, they saw on their units that babies who are cold, especially the preterm babies and the low birth weight babies, they were dying. And if you warm them, you make aggressive effort to prevent hypothermia, they survive. Not until early 2000s, a lot of systematic review, this is what Nana talked about, that for every 1 degree drop below 36, the mortality rate increases by 28%. We know this very well. So based on this, admission hypothermia has been incorporated in a lot of prediction scores, the CRIP and the SNAP, they use it. And the moment you are admitted cold, chances of dying is very, very high. We know that hypothermia at delivery is associated with respiratory distress syndrome. We always say that you can go buy expensive surfactants, but if your baby is cold, you pour the surfactant into the lungs, you won't get any results. So for us to jump to surfactant here, we are not supposed to do that. We will have to stay at basics first. We have to make sure that we prevent that preterm baby on admission to be warm. We need to make sure that we start the baby with early CPAP so that we open up the lungs. And trust you me, our babies are so strong that the moment we manage hypothermia, the moment we start early CPAP, a lot of our babies truly will not need surfactants. Right, so let's go back to the basics. Pulmonary hemorrhage. On our unit, we were realizing that a lot of our babies on day 3, day 4, day 5, especially the very tiny ones, those less than 1,000 grams, day 3, day 4, day 5, before you say Jack, they are bleeding. They are bleeding from the mouth, the nose, everywhere. And we are beginning to see that hypothermia may play a crucial role. You go back and you look at it, their temperature charts, and you'll be seeing 36.1, 36.2, and nobody takes action until they start to bleed. So pulmonary hemorrhage has been associated with hypothermia, and then, of course, sepsis. So now, this is what WHO recommends, that our auxiliary temperatures, we should try and keep it at this. Now, we looked at some, is it a problem when we talk of all this? People will say that, but in Ghanaian babies, maybe no. Let's look at some of the studies in the very few, it's not so long ago, most of the studies. These are studies that they really mentioned admission hypothermia or the incidence of hypothermia in their respective work. This Eastern Regional Hospital, Dr. Panga and co, they looked at the predictors of mortality, and they used all admissions. They quoted 59.3. This is TTH Prof. Moomin. They looked at all admissions during their study, looked at the number of babies, 2,400. They quoted 54.7. This is RAGE. We looked at a little over 2,000 babies, admission 58.6. We all use the same definition, right? So look at this. Now, Confanochi here, they looked at the little ones, less than 32 weeks. Look at it's the 84%. So the smaller you are, the very likely that you'll be cold. And Kolebu, when they did their study on that machine, they attached their hands. They looked at low birth weights. Look at their number and look at 85. So truly, if you take all our babies, the true incidence of hypothermia may, with 95% confidence interval, may be around 50 to 60%. And the lower you come in terms of weight and gestational, look at this. And these are big shots in Ghana. These are teaching hospitals and regional hospitals. What happens to district hospitals and sub-district level, where probably we have over 70% of our newborns, right? So this message, it's crucial. So let's do a little bit basic science. Why the newborn is so prone to hypothermia. And you remember that in adults, when you guys are cold, you begin to shiver. And during shivering, you generate heat. Unfortunately, the little ones, the newborns, don't have that ability. So for them to be able to generate heat, they use the non-shivering method, and that is chemical thermogenesis. So when they are cold, the thermoreceptors in the skin gives instructions to the hypothalamus, increase sympathetic activity, noradrenaline. Noradrenaline is found, we will talk a little bit about brown fat that newborn babies do have. You guys, as you sit here, you don't have any brown fat. Brown fat has a lot of nerve endings and they are highly vascularized. So it stimulates norepinephrine from brown fats that gives instructions to the adipocytes. And they end up through fats oxidation and they produce heat. So the brown fat, the characteristic is that the heat generated from brown fats or the energy derived can never be stored. It's used as heat to warm the babies. This is contrary to the fat, the white fat we have. The white fat, you can conserve the energy. But once it burns from the brown fat, it's heat that comes out to warm the baby. It can also go through the TSH surge. When a newborn is born, the sympathetic is stimulated, it increases TSH that produces the T4, T3, converts to T3. T3 uncouples what we call the thermogenin, and thermogenin works through the same mechanism to increase heat from the brown fat. So a little bit about the brown fats. It starts in the fetuses around 25 weeks, and it increases up to term and is present up to 9 months where it vanishes. term babies may have up to about 4% of their body weight being brown fat. It's mainly around the internal organs, the heart, the big vessels, and then in between the scapula and the kidneys. And as I said, we gave the name brown fat because it has a lot of blood vessels, it has a lot of nerve endings. So visually, when you look at it, it doesn't look white, it looks just brownish. So that's why the name brown fat came. Once it burns, you cannot replace it. It burns and it gives heat to the baby. And gradually by 9 months, or in the human species, 9 to 1 year, all the brown fat vanishes. So we say it peaks around term. So the preterm baby, unfortunately, will not have enough brown fat. Compared to the term baby, which constitutes about 4% of the body weight, the preterm baby may have about 2.5 to 1% of the body weight being brown fat. It tells us that even with chemical thermogenesis, our preterm babies are disadvantaged. So that is the reason why we need to be very careful with this group. When they are hard hit, they cannot shiver. The chemical thermogenesis, that is their disposal, they cannot utilize this effectively. So another area, physically, why the preterm baby is susceptible to hypothermia. Our head is big. I mean, the preterm baby has a very big head relative to the body. Being big head means that a lot of area is exposed for mainly radiant heat loss. They have the ratio of skin surface to body weight is also very high, right? And it all increases the risk of radiant heat loss. Here, subcutaneous fat is thinner with more transepidermal water loss. So when these babies, those of us who look after these tiny ones, when they come to your ward, when you don't provide enough humidity, they lose a lot of heat. Transepidermal water loss, they can lose a lot of fluid through the thin epidermis. When I'm cold, when I was sitting here and I was cold, I was like this, right? I was flexing to conserve heat. Preterm babies, they cannot. And that is the reason why, one of the reasons we always want to promote that developmentally supportive care, swaddling them, nesting them, right, is to try to help them to conserve energy. You walk to the units and you see preterm babies lying down with their legs and hands open, right? And that is not right. We talked about the brown fat, and it have definitely low glycogen storage. Their TSH search, when at birth, 10 babies are able to mount this. Preterm babies are not likely to mount a lot of TSH search, in that they will not be able to promote the production of T3 that will have to go and uncouple the thermogenin for chemical thermogenesis. Hypoxemia is very likely for the preterm baby to hypoxemic. Hypoxia will not help a lot of TSH search, in the same way will inhibit chemical thermogenesis. My picture is not going to come. It's never going to come. Right, so we're talking about how newborn babies lose weight, lose heat. And this is purely physics. You remember the first way when the babies are out, the first means, I had a diagram here that shows how heat is lost. The first one is through evaporation. So when the babies are born, the liquid around them and everything will pull heat from the baby, and it uses that heat to evaporate. And that is newborn babies. The first area they lose heat through is evaporation, right? The second one is radiation. In medical school and in the residence, you ask them these questions and people struggle to, see the mechanism. Radiation means that if I'm here and the wall here is very cold, without contact, I'll be losing heat from me that is warm to the wall here. So that is radiation. Conduction is contact. If I am warm and I'm lying on a cold surface, then I'll be losing heat from my body to the cold surface. So that's the difference between radiation and then conduction, right? Convection means that when wind is blowing over me, it picks up my heat and goes away, right? So remember, evaporation, radiation, conduction, convection. Understand these terms, and we're going to, it's not just to memorize it, but how are we going to use it on the ward? right? So when the baby is born and baby is wet, we need to dry. That's the essence of drying this baby, so that we don't leave wet thing, liquid on the baby, so that it pulls heat from the baby. Radiation, that's the reason why we really want, especially the head. A lot of our babies in our neonatal, the labor wards and other things are not wearing caps, which is very worrying, right? You have to dry the head and wear them woolen caps. Just one of the, because the head is a big surface area, radiation is very, very. Make sure air conditionings and other things are not warming your walls too much. One of the mechanisms we talk about, the incubator, is to have a double walled incubator. It reduces heat loss by radiation, right? And then conduction, we don't want to be opening windows so that air blows over these babies. And then, um, um, which one is the last one? Convection, right, good. So we always ask, apart from physiologically, the babies are small, they don't have this, what else could influence them neonates in general to be hypothermic? Number one will always be contextual, whether the seasonality, right? During rainy season, during dry season, we need more studies on this in Ghana to see whether it really affects, and really, really it affects. This is the physiological example, the low birth weight and its characteristics. Behavioral, especially when we go to the low resource areas and in the communities. Remember, this problem is facility problem and is also at the community level. And you might, but I don't know whether anybody can tell us what percentage of delivery in Ghana are home deliveries. Who knows? We don't have, all the obstetricians are gone. Who has any idea how many deliveries, the home delivery rate in Ghana? Right. It's very high. So when we are talking about this, it's a facility problem and it's also a community problem. So behavioral things, even in when I was a young doctor, we used to bath our babies very early. Right. And it took several years. Now I think the message is really kicking in, right? But early birth is something that is major. It's a behavioral thing. And now WHO has found out that in level and low resource places where you don't have the more guides, you have to play around the behavioral way and make sure that a lot of the behavioral problems, especially early bathing and everything, are addressed. And that's why WHO has come up with that 10 chain warm, everything we'll talk about later. Socioeconomic, of course, if you're poor man is at risk of everything, right? So I will be walking you through what happens at my hospital. And then you will have to take whether, we are right, we are not right. You are free to take some of what we do. And it's this, every regional hospital should be able to dance around this. So number one, we want to know what happens in the delivery room, the labor ward, the theaters. Coordinate care between obstetric and neonatal teams. I don't know from your unit how often you coordinate. Ideally, these two teams should be talking a lot, should be communicating. We are delivering a 26-week severe preeclampsia. The neonatal team should be aware, or the delivery team should be, we have a delivery room assessment team who we call on to be part of this delivery. So we want obstetricians to be talking as much as possible. This area is something that a lot of people in Ghana, we've not really paid attention to, maternal temperature. Normally, I would go to my labor ward and my theaters, and the mothers waiting to go in for surgery, and they are the corridor waiting, and the temperatures are so cold and they are shivering, right? Remember that at equilibrium, the mother's temperature, fetus, and we said that the fetus is always like 1 degree above mom. The more mommy gets cold and mommy is struggling, you are translating this. Let's juxtapose to the other end, maternal pyrexia. So if mommy temperature is 38, it means baby is almost around 39. So that is why we don't joke with maternal pyrexia. It is a very big. So we cannot look at the fetus without the mom. So let's make sure all our mummies are having normal temperatures at the time of delivery. Delivery room temperature, it is a major problem. We've battled time and time and again in our units as to what will be the delivery room temperature, right? Currently, the WHO recommends that at least 26 degrees for preterm and 24 to 25 for term babies. Who controls labor ward theater temperatures? My hospital and the anesthetist, they control. And for us to really break this chain, we need to be talking to them more that in our delivery suites, the most vulnerable patient there is the neonate, right? And we should be planning this. You walk to a lot of theaters, there's no thermometers in the theaters or delivery suites. Every time we should have a thermometer there to measure the temperature in the delivery suite. And as a KY project, probably every day the nurse on duty will have to record the temperature of the delivery room and make sure that we chart it, that today at the way we check body temperature, we should be checking the room temperature so that we keep our babies warm. Delayed core clamping is something that is being studied a lot. And we were so shocked to see that. I know those of us who keep dogs and cats, how do they cut the cord when they deliver? Who knows? What happens? They chew it. They chew it. Among mammals, it's only human beings don't chew their female. So all these animals, they chew it. And the dog will not chew it immediately. They wait for some time. They wait for at least 1 minute. After 2 minutes, anything that is not moving, the mother will chew it. So if you're a puppy and you are born, you have to be moving. Other than that, your mommy will chew you, right? So way back, the animals have been doing delayed cord clamping, and we are now getting the benefits of delayed cord clamping. They are more advanced than us, right? So it's something we need to be engaged in. Today, I was so happy to hear, I think the obstetricians who joined the morning, they were confident that they were doing it. We have started, if you do it and you don't document, you didn't do it. So please, we have started documenting this, that at least the current recommendation is that at least 60 seconds of delayed placenta transfusion. Right. I told you that metabolically, the heat in the baby is moved to the mother. So at any given time, a lot of the baby's blood is the placental circuit. So when you move it back, it will warm the baby. Early breastfeeding is not for nothing. So many benefits. One area we are seeing is in the area of hypothermia, prevention of hypothermia. The earlier you give colostrum has a lot of other things, and it really helps. At least the fat component is going to help the baby burn to get heat. Early skin to skin, we cannot overemphasize this. So we try as much as possible to do this. A lot of my pictures are not coming. It hurts so bad. Bosses, how come my pictures are not coming? I need a lot of pictures to show. How come? Even if you can show it in this. A lot of pictures to show. Good. Yes. Okay. Good. Okay. So we can go back. Yes. So this is what we talked about. So this is what we normally will require as a minimum requirement before baby is born. Now, we have improvised. This is what we call it, the transport cot. If I show you the real one, it looks so nice. This we've improvised. So this is a baby's cot. We've put in our oxygen cylinder here. It's attached. This, don't mind, this is called a T-piece. This is what we use. It's called a T-piece. With a T-piece, you're able to start CPAP from the delivery room before you send the baby to the NICU, right? So our transport trolley is always at the labor ward ready. We have two, one at the theater, one at the labor ward, and we have one at the NICU, and it's attached. It's the duty of the nurse, the delivery room assessment team, to make sure that all the things, the oxygen is full at any given time T. So we never carry babies from the labor ward or the theater to the NICU. It must be in the trolley. So rule number one, all our babies will have to wear a cap. So the babies who are less than 2 kilos, you dry the head and then you wear a cap. We don't dry the whole body. All the babies less than 2 kilo, we put them in food grade plastic bag before they come to NICU. So this is the journey from labor ward or theater to the NICU. We put them in a food grade plastic bag. And a lot of studies have shown the importance of the food grade plastic bags, especially in low resource places like us. It helps to preserve heat. And the babies, especially less than 1.5, there's no need for you to clean the vena caseosa from the skin. The vernix melts and humidifies the skin very well. So the rubber is up to the neck, the cap is on. This is our nurse applying the T-piece to the nose and the face through the face mask. This is where we give the PEEP. You set the PEEP here, and you're able to maintain at least a PEEP of 5 on the journey from labor ward to the NICU. So it's a must. We had a chance of having a thermostable gel. This morning, I heard some innovations. I said, this is an area we need to really look at. We had donations from an NGO. This is a gel. It's called a thermostable gel. And these gels, we autoclave them. When it's ready to use, you just press the side and it starts to warm. It can warm up to 2 hours. So we put it in our blanket, So it's gone in. So we show this is going in and it's gone in. And we wrap, when we are ready, we wrap the baby on it. So all babies coming in should be on if baby is less than 2 kilo, we'll have the food grade plastic bag together with the warm gel, and then we wrap. If baby is less than 2 kilo, we don't use the plastic bag, but we wrap them in this. Nurse keeps on this, wears the cap. This is our pulse oximetry during transportation. This is our T-piece, and then we move. When we arrive at NICU, evidence-based, we need to be documenting this. So we have generated our checklist. So the time decision was made to send the baby to NICU is 11:35. Time NICU was informed by phone is this. Time of transport to NICU is this. Then, was the NICU informed? Yes, NICU was informed. Was the baby placed in plastic bag? Yes, it was. Was the baby transported in a transport trolley? Yes. Was warming blanket used? Yes. Was these are T-piece? Yes. Time of admission to NICU, the NICU nurse will have to note it. And then body's temperature, the baby's temperature on admission is this. Nurse transporting baby science, nurse receiving baby science. And is there evidence-based, right? So with time, we should be able to see these interventions we've brought in to see whether we are making any progress. So try as much as possible, whatever you do, to be able to document these things. We talked about this golden hour. I'm not going to go through. I wanted to touch base with. We're talking about incubators, but I go around and I find out that a lot of doctors and nurses don't know how to use the incubators. And it's worrying. The first concept is neutral thermal environment. This is the temperature at which the baby expends, around the baby, that the baby expends the least energy in conserving heat. So you realize that no two babies will have the same neutral thermal environment. It will depend on the weight of the baby, it will depend on the gestational age of the baby, and it will depend on how old the baby is in terms of postnatal age. So we have this. Please search for them, neutral thermal environment. You can hang them in your units and say the baby is this weight, this is the number of days, and this is it, so that you set the temperature in the incubator to that. The temperature in the incubators will not be the same day 1, day 2, day 3, day 4, day 5. You have to keep changing depending on this. So Google search for neutral thermal environment. We are a little bit lucky. We have incubators that can do that job for us. So I wanted to touch on the two modes of the incubator. There are so many incubators, but how they work is the same, right? So remember, this is a type of incubator. This is a baby, this is a fan. The first mode is called the baby mode or the servo-controlled mode. So in servo-control mode, you, the clinician, or you, the healthcare worker, is going to set the temperature. So I have set it to 36.8. I'm giving instructions to the incubator that please make sure you warm the baby so that it is the temperature of the baby. So we set this, and the incubator tries to warm so that the baby gets around this and stabilizes. So this is the servo-controlled. We like this mode when the babies come first, the premature babies, when they enter the NICU. We want to put them in the servo-control mode so that we can control the temperature of the baby. Here, the nurse cleverly is called the humidity. Our units, all the babies, the extreme preterm babies, start humidity at 60%. So it's still warming. And humidity is beautiful. With a good humidity, you heat less to get to what temperature you want. Without humidity, the incubator will heat and heat and heat. So please, anytime you're going to buy an incubator, make sure your incubator will be able to humidify. It's one crucial component. So this is the servo-controlled mode. When it comes to the air mode, assuming this baby has been on the ward for about 7 days, and we are planning, or 5 days, and we are planning to see whether we will test the waters to see baby is ready to come out of the incubator. So you put it in the air mode. The air mode, you are going to set the temperature, right? You are going to set the temperature in the incubator, and the baby will use that temperature to maintain normal temperature. Do you understand the difference? Yes. But how do you set it? So this is what we call the neutral thermal environment. This incubator can help you do that. So you input the weight of the baby. If the baby weighs 1,200, you accept this point. Gestational age is 31. Postnatal age is 7. Then it tells you set it around 33.8 to 34.8. And then we have set it to 34.5. It's warm to 35, and the baby's temperature is 37. Why? Yeah, so this is the air mode. So the air mode, this is the same as the chart. This is the same as the chart. This is the same as this. But this is automatically, the incubator is doing it for you. Of course, you have to spend more money on incubators that can do that. But if I have money, I won't buy that incubator. I'll buy a simple incubator that humidifies, and I'll look at my chart. You understand? Yes. So I just wanted to show that these are available, and you have to know the two modes of how the incubator works, the servo-controlled and then the air mode. We talked about the 10 steps of thermal care in low resource. We don't like the word low resource, but probably thermal care in districts, sub-districts, and regional hospitals, right? So it's the same mode, but I want us to draw our attention. Warm delivery, we all promote in facilities. At community level, we need to immediate drying, but make sure that those less than, say, 1.5, we don't dry, we only dry the head and put on the plastic, food grade plastic bag. Skin to skin is something we all need to promote. Early breastfeeding, delay bathing, crucial area, warm clothing, keep mother and baby together here, especially when I'll show you one study in Ghana where they give us more hope that this can be done. Warm transportation, warm resuscitation, right? So it's the 10 chain of those preparing for exam. This is quite a very hot area. So the WHO has carved this nicely for us. This is one study that was published this year. Amazing. Newborn care practices in urban slums in southern Ghana. So they use mother-baby diets in Ashaiman and Sodom and Gomorrah, those who know Accra. And they looked at what care practices, even though they didn't measure temperatures, they were looking at care practices. And they were only able to show us that only 24% of deliveries actually did something that helped with thermal control. So we have a lot of work to do, especially at the community level. Cape Coast, Dr. Okain and colleagues, this was a brilliant study. They did a cluster feasibility study on how they receive their babies from the district where they work. It was a very good study. One group, this was a cluster study, so they did not randomize individuals, they randomized groups. So the one group was randomized so that the mother is transported with the baby in the KMC position, and the other group was the conventional type. They did prove to us that admission temperatures were not so different between the two groups. This tells us that transporting babies in the kangaroo position is feasible and is something we need to be promoting, especially when we work here that we don't have. And we've been begging that at least transport incubator should be in one ambulance. Still, it's a mirage. So it's something we need to work on. This study gives us hope that it's safe, it's feasible, and it can be done. Right. So I will just conclude that newborn hypothermia remains high in facilities and communities in Ghana. Care bundle, we talk about this, is not only care bundle to prevent hypothermia. You go to some hospitals, they do have it, but the compliance is poor. We need to really revisit that. Neonatal units should enforce a rigorous approach to hypothermia in preterm populations. A lot of our preterms, they die, and the main trigger is hypothermia. QI projects are strongly recommended. We can really look at the incidence of our hypothermia now, bring in a care bundle, and pre and post intervention measure. And it's something that we expect a lot more work in this area. Neonatal health promotion programs for home births needs to focus on behavioral changes. The doulas, the traditional birth attendants, they all need to have education on the thermal care, and together we will warm our babies for a better future.
Thank you so much, Dr. Ajiman. I mean, once I get to your hospital and I even see the corridor, I know I'm safe. At a point, I thought I was watching one of these white series when you're doing the incubator. I had to pinch myself again and say, hey, we are in Ghana. Thank you so much. Please, do you have any questions, any comments? I'm sure Greater Accra Regional Hospital is far from most of our hospitals. Yes.
Thank you very much. Please, I would like to know Dr. Ajiman's take on therapeutic hypothermia, especially for asphyxiated babies. And then my second question is the plastic wraps that we put on the babies. Is it done for the very preterms or any baby that weighs below 2? Thank you.
From the plastic bags. So a lot of studies done in Europe, the cutoff is 1.5 and below, but we decided to do 2 kilos. So all 2 kilos below, we put we go to the market to buy food grade. And no, there's no need of a sterility here. Food grade bag, I mean, plastic bags, and it's there. Yeah. Shh. Shh. It's a good question. Mhm. The TP donation. It was donation, so I don't know where to get it. I'm telling you, yes. I mean, when I got used to the T-piece, it's an excellent fit. You can start CPAP at the delivery room and move the baby, and you can set your PEEP very well that you don't do excess distance. Yeah, yeah. So it's a food grade plastic bag we use. This is a different topic altogether on the term baby and then the hypothermia, right? We realize, I mean, there's a study, shh, there's a study called the Helix trial, HELIX, that you need to read about that study. It was done recently in countries with low settings, India, Pakistan, and I think one country in Africa, where the argument was that our babies would they benefit from therapeutic hypothermia? And they realized that it was a randomized study. One group used the hypothermia and the other group was the conventional. You keep them warm, normal temperature and everything. And they were shocked to know that the arm with the therapeutic hypothermia, a lot more babies, the mortality was high. It tells us that when you cool these babies, they need more support. So if your unit cannot probably say do inotrops, cannot ventilate, you keep this baby cold and they die. So before you do all this, you should have a baseline that can support. We will get there. I strongly believe a lot of our babies would have benefited from that, but we need to up our skills in that area before we start therapy. What we don't want, I've seen some units in Ghana doing passive cooling. You need to be very careful. The study shows that the temperature they keep these babies is 33.5 to 34.5. If you do anything around this range, you are harming the babies. So you have to be very careful. And they use the servo-controlled method. You put them on a mat and then you set the temperature. We don't want you to put ice on the babies and then you don't know where your temperature is, right? So for now, I think in the future we may, but for now, let's just be a bit careful.
Thank you very much. As we take the last question, please, this is for evaluation of the conference. What we did in the email was a pre-conference. We just wanted to know the data, but this is for the conference. So please scan and then give us your feedback.
Thank you very much. I want to ask if you have a preterm baby, let's say 26 weeks, and then the baby is hypothermic and also having jaundice. Maybe you check and then you check the bilirubin, it was around 260, and you want to start photo. And photo to most of the time, how to expose the baby. I want to know whether you have to control the temperature before you start the photo, knowing very well the jaundice too can cause other issues. Sometimes we get confused at the NICU.
Yeah, some questions, she's really working hard. I mean, these are the implications. But if you have a 26-weeker, the baby definitely will be in an incubator. Right? Yes. So you can do the overhead phototherapy. It shouldn't be a problem. The good news we have is that a lot of the modern phototherapies are LED, light emitting diodes, and they don't overheat too much. So you can do the overhead. And I think it's a genuine concern. We get a lot of preterm babies who are also jaundiced, but you have to do the two concurrently, right? Yes. Yes. So yeah, I'm just imagining if you don't have an incubator and you are trying to manage a 26-weeker. Amazing. No, I know. Yes. 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 But you remember that under the radiant warmer, I mean, heat loss by convention and everything is going to be right. It's going to be tough for you. So remember that on the radiant warmer, one strategy is that you can again use this food grade plastic bag to cover the radiant warmer. So my unit, we do that if the tiny baby is going to be under the radiant warmer for long, in order to prevent heat loss by convection, we cover the baby with it. But the slightest stabilization, we move the baby into an incubator. So I guess I understand your question, assuming you don't have it and you need to do phototherapy. Yes, but again, make sure that you balance it in such a way that you can do the two. And yeah, you slant the light to go from one side and then you hit. Probably, but we are realizing that especially phototherapy, you have to be very careful with the extreme premise under the phototherapy, right? I mean, we are now beginning to see that they may have more side effects on phototherapy compared to the term baby. So probably you can do it in bits. I mean, like the way we give medications, right? So in cyclic form, you do it for 3 hours, you rest the baby for 2 hours, then you check your thermoregulations, right? But I salute all who are working with preterm babies in limited resources in our country, right? It's tough. And it's time for us to make, there's no shortcuts. That's where people get it wrong. It's labor intensive, it's capital intensive. There's no shortcuts. And the more you improvise, the more you harm these babies. So it's time for us to make sure that if you are qualified to take care of a preterm baby, you should get the basics. We are improvising too much and we don't know the long-term effects.
A round of applause for Dr. Ajman. We've learned a lot today, even with the limited resource. It looks like we have limited resource because his facility, they don't look limited, but we have very limited. So thank you so much, boss. We are ending and would like to call on our beautiful doctor. She's also Dr. Mrs. Mami Fremakotomoti. She went to one of the best schools in the country. Hey, girl. I didn't go to Wesley Girls anyway. My school is better than theirs. So she'll give the announcements and she also give the closing prayer.
Thank you so much, Nanekia. Dr. Mrs. Nanekia Bakuma Ajiman Apia. That's a mouthful. Thank you all for waiting. It's 6:30 already. Some of us were here as early as 8 o'clock or even earlier. And we haven't seen you frowning. You just keep on smiling because pediatrics is full of fun. I want to say a very big thank you to you all for staying through till this time. So for tomorrow's session, we start at 8. So registration will be at 8. And the poster presentation, we're supposed to do that today, but obviously that's not going to be possible. So we want to start the poster presentation at 8:30. Oral, yes. The oral poster presentation at 8:30. So anybody presenting should be here by 8 so we can set up and we don't drag the program. And for tomorrow too, we are going to have a lot of hands-on sessions. We've heard a lot. I'm sure some of the things, we have read them in books, we have never seen them happening before. So tomorrow we'll have different sessions for doctors, for nurses, combination here and there. We'll have sessions on CPAP, and we are privileged to have the original people who put the value CPAP together coming over to train us. So you have those manufacturers having their trained people coming. So any questions you have as far as the use of the value CPAP is concerned, please put them down and come and ask. I remember in my facility, we used it on one baby and we just kept on hearing this hissing sound. And we're all so scared. But when we got the chance to ask them, they explained to us and we are now so comfortable. So we want to optimize the use of the devices. We'll have sessions on the surfactant administration, as Dr. Nana talked about today, the preterm care bundle, KMC. We have a nice package tomorrow. So tomorrow when you are coming, brace yourself for a lovely time. And tomorrow we are going purple. Tomorrow we are going purple. Tomorrow we are going purple. So everyone is supposed to come in a prematurity t-shirt. Please, who doesn't have one? So we'll make some available tomorrow, 60 Ghana cedis for one. So dress in a way that if you have to put on your prematurity t-shirt, you'll be so comfortable and confident wearing it. And you can add any accessories of your choice. So just like Nanekia has her fascinator on, Aisha has her fascinator on. Yeah, just look premature, purplish, adult, and all, just to make it fun. So tomorrow we go purple. And for the certificates for the course, it will be electronic, so we'll send them to your emails. We are trying as much as possible to also compile the course materials and send them to you via email. So all those who are trying to take pictures, don't worry if your picture quality wasn't good. We'll send the course materials to you. And as Naneki announced, scan to complete the evaluation form. We want to wish everyone a restful evening. It's been a long day. When you go, if you're hungry, get a good food to eat, take a warm shower, stretch yourself, and make sure you don't lose a lot of heat because you don't have brown fat, and rest enough for tomorrow's session. So let's be on our feet as I give you the closing prayer. Father, we thank you so much for today. We thank you for making the day a very successful one. We thank you for all the knowledge that has been imparted into us. As we go back to our various homes or wherever we are lodging, we pray for safe trips to wherever we are coming from, and keep us safe in our sleep and bring us back tomorrow refreshed and restored to come and learn more to save our preterm babies. We thank you for the answered prayer in Jesus' name. Amen. Enjoy your evening.
Stay. I can be you. You take me just as I am. You choose me all over again. 'Cause I am the one you love. I am the one you love. I don't have to prove anything. There's room at your table for me. 'Cause I am the one you love. I am the one you love. Yeah. I know you're proud of me, even though I don't deserve it sometimes. Even though it hurt, the mother, still on his grace, his hope, still my friend. I can call on him when I need him. He's still my friend. I can call on him when I need him. He's still my friend. I know that I can call on him when I need him. I know he's still my friend. Oh, I call on him when I need him. He's still my friend. Oh, God.